groups. But if we check the treatment groups, means that hydroxychloroquine, zinc, and hydroxychloroquine plus zinc group, there is no significant difference between each treatment groups. But sepsis group, as expected, P lower than 0.01. I can say that there's no statistical difference between hydroxychloroquine, zinc, and hydroxychloroquine and zinc groups, but numerically we have seen that, we have observed that the tissue damage higher than hydroxychloroquine plus zinc group. In the examination made by biochemical parameters, white blood cells notified, we can see the difference between hydroxychloroquine plus zinc groups. There were higher damage on the red tissues and red biochemical parameters, but this was not statistically important. This can be because of we have used 9 rats per group, and 3 of our rats died because of this. Given together in the group which hydroxychloroquine or zinc were given alone. If the amount of zinc inside of the cell increases, tissue damage is higher in both histological and biochemical examination results, and it's not significantly statistically important. And it is parallel to the older groups, older experiments. Zinc level increases inside of the cells, inflammation increases, and hydroxychloroquine also suppressed our inflammation. And
invasive fungal sinusitis often cause, generally we see that in diabetic patients or having corticosteroid treatment or immunosuppressed patients. Generally, they have non-specific symptoms like bacterial infections, fever, headache, or epistaxis and nasal congestion. And fungal, especially invasive fungal sinusitis, have a high mortality rate, 85.100%. For early diagnosis, in emergency department, we can use only 3 ways: endoscopic examination, computer tomography, and magnetic resonance imaging. And we can see this. And 55-year for smoking history. He had hypertension, but no regular anti-hypertension agents using, and he didn't use any anticoagulant or antithrombotic agent use, and he hadn't a history of trauma of all admissions with epistaxis. And we had after our first examination, we had otorhinolaryngologist consultation, and they had nasal.
Good morning. Thank you for your attention. Foreign body penetration is a prevalent cause for individuals seeking medical attention at the emergency department. Superficial traumas, particle case of nail penetration, are commonly found within this context. In these circumstances, dressing, tetanus vaccine, analgesic, and antibiotic therapy are typically considered adequate treatments, unless the patient has comorbidities. The purpose of the presentation is to highlight the potential development of severe complications in patients who present to the emergency department with nail penetration. And to
thank you for your presentation. Any question? Okay, thank you. Is there anyone behind left? Okay, thank you then. Have a nice day.
in Singapore. We have 3 medical schools there, and I'm an emergency physician for 33 years. So I've trained many residents and doctors, many generations of doctors. So today I'm actually going to talk to you about how the healthcare simulation spectrum is transforming itself and how we are moving forwards and moving beyond. Right, the picture that you see here is actually a picture from Bhutan. How many of you have been to Bhutan? It's the country with the highest happiness index at one point in time. And this is the Hanging Tiger Nest Monastery up in the mountains. And it was quite an effort to actually climb the steps and trek upwards to this monastery. But then, you know, technology is driving everything that we do, including in the practice of medicine and emergency medicine as well. So we have to make sure that we adapt. Let's look at this video for a while. Can I have the volume up? The sound? Okay, so this is what happens when you go shopping these days. You don't even have to put the clothes on. You can just look at the mirror and AI will show you what you're going to look like. Oops. Okay, that's a technology glitch. So let's just wait for that. So nowadays you can just look into the mirror and then you don't have to try the clothes on, and it will just show you what you're going to look like with those clothes. Okay, just give them a minute. In the midst of all that, we must not forget that humanism must still prevail. It is at the center of everything that we do, including when we use technology as well. So, humans must be at the core of everything, whether it's related to our patients, our learners, their family members, and the community around us. And don't forget the healthcare staff, all of you as well, because oftentimes we care about others, but we forget to care and think about ourselves, which is really very important, because we are not there, then there's no healthcare provider really. So the character important learning curriculums and everything are all on your phone now. And serious games. I developed serious games to teach healthcare providers how to excel in certain tasks and skills. So that's the game-changing technological tools. And then of course we do a lot of VR, virtual reality, augmented reality, extended reality, mixed reality, and all these, including robotics. Robotics is not new anymore. People are already using this to do surgery and surgical processes, and I'm sure it's the same in Turkey as well. And a lot of AI. We are location. We can do it on our own. We don't have to have group learning anymore. We can have our technology devices in our own homes, and we can study anatomy by putting on a pair of spectacles, which is AI savvy, and you can actually learn anatomy on your own practically. So people are becoming isolated. People don't talk and meet face to face anymore. They can interact through their mobile devices, for example. So therefore, think about the human to human interactions that we have. Our patient contact with the physician, that's important. I mean, that is something you cannot run away from, because I think in medicine, no matter how much technology we have, the face-to-face contact is still definitely important. In healthcare, including emergency medicine, we are, I would call, a high-tech and high-touch industry. You know, there are some technology or some industries which are high-tech but low-touch. But for us, we are high-tech and
built by hands and robotics for awakening health. I can do all kinds of things for elderly people. I can visit with people and brighten their day with social stimulation, entertain and help guide exercise, but also can do talk therapy, take bio readings and help healthcare providers assess their health and deliver treatments.
Hi, my friend. Nice to see you. Okay, great. So while we talk, I
I will take your temperature reading and pulse with this little thermal camera on my chest. See? You are 36.6 degrees Celsius, by the way. No risk of COVID. Also, I note that you are responsive and
So this
aware,
robot can
which
be
is
taught
good, and
to
they
speak
might
different
share that
languages.
important data back
So
to
in
the
Hong
doctors and
Kong,
nurses
they've
at the
actually taught
institution.
them how point that we have, but perhaps it could be a machine touch point. But really it's up to us. Whatever technology we're going to use these days, how do we integrate the humanistic aspects and the humanism aspects into what we're doing? We cannot run away from having technology because I think it's already here to stay. And technology can offer us a lot of things. For example, during the pandemic, that has given us a booster with the adoption of technology in healthcare. Healthcare was lagging behind in terms of technology adoption compared to other and the interactions that we must continue to have, and of course the social skills, the communication skills, the deeper emotions, the finer aspects of correspondence, and the touch and feel as well. You know, that's very, very important. So therefore, technology can offer a certain amount of things, but there are certain things that we still need to have the human elements to it. So therefore, technology can enhance, but I don't think it will replace the human representations and interaction. So whenever we are adopting technology, make sure that we think about the humanistics and the humanism aspects. It's a very interesting area. Function in cardiogenic shock or diabetic ketoacidosis, you know, with severe sepsis, you know. So those are the stories, the narratives that are very important, that helps us to keep our scenarios and our simulation human. When we do debriefing after the simulation, we are usually doing it face to face. That's the best. And of course, there are virtual debriefing sessions, which we have done during COVID especially. But again, there are certain limitations to it, but it can be done. It still works, and I've done many of those virtual debriefing sessions as well. But of course, it will be more satisfying if you can do it face to face. And then of course, we can use hybrid simulation to humanize our simulation sessions. I'll be talking about this in the afternoon at 4:30. If you're and there's wisdom, which you're going to use it. So let's make sure that wisdom can have a bit of an edge over that. So thank you very much. And if there are any questions, I can take them. Thank you. Our next speaker is Dr. David Carr. You guys know him already. So he's going to have a long tutorial session with you on dermatology, because I think we only have the two of us this morning at this session. So if you have any questions, just ask him. So David, over to you.
Good morning. Thank you for coming. It's early, and it's amazing to see, I don't need, no, I'm okay. It's amazing to see so many faces I met in the last 3 days here this morning, because that inspires me to do better, to see my friends here. And it's been amazing to be part of this conference for the first time, to be part of your country, and to be welcomed so warmly. So thank you all for that. Yesterday, I gave a talk on 20 years of my career and what I think about. Today is different. Today is 20 years of my career in pictures. This is it. These are 20 years of rashes that I've captured on my phone or my camera that made a big difference to me. It treats almost everything. You know, I once, when I was a medical student, I did a rotation in dermatology for 2 weeks. And I went to see a patient, and the dermatologist said, "What do you want to give the patient?" I said, "Some hydrocortisone cream." And she looked at me and she said, "That is a great answer, but if you write hydrocortisone cream from a dermatologist's office, people aren't going to think we're dermatologists. You have to write something different to confuse the other people to think we're specialists." So we're not going to talk about this. 16 pictures. Is everyone ready to go? Okay, so what I'm going to do is I'm going to give you 16 pictures with 16 stories. It got hot, it got red, it got warm, and he got put on some Kefalexin. It wasn't getting better the next day, so he's referred to the emergency department for intravenous antibiotics. This is my daughter Dylan's foot. Dylan and I were at the basketball game. We're big Toronto Raptors fans, and Dylan said, "Daddy, my foot is so itchy." You know, I'm watching basketball. I don't really care about her foot, to be honest. And she kept my foot. This is one of my favorites. This is the patient's camera. The picture on the left, that looks pretty good with the piece of gauze, is when he presented to the emergency department. He got bit by a dog, his dog, and he came in, he was given some antibiotics, some amoxiclav, clavulanic acid, and told to keep it clean, to put a dressing on it. Okay, this is a strange story. This is a gentleman who was going on a cruise. He was going on a cruise in Hawaii in the United States, and when he was wearing like a tank top, he had recently been sick with strep throat. And when he got on the cruise, does anyone, do you guys like cruises? Does anyone go on cruises? You're a cruise guy? Okay. So he's about to go on the cruise, and they're in line, and the person says, "Whoa, whoa, whoa, whoa. You can't come on the boat. Not with that. You could like get the whole boat sick. You must see the ship doctor." I wonder if you... Dad says maybe he has a pinworm. Any parents here? Have any of you ever tried to look for pinworms in children? So it's a crazy thing once you have kids. You go to your kid's bedroom in the middle of the night and you put some tape on their bum and a flashlight, and you hope to see worms coming out of their kids' bums. It's actually the most disgusting thing in the world. So this dad keeps checking for pinworms every night, and he can't find pinworms. He treats the kid with pinworms, he treats the kids for dermatitis, and then he says, "Dave, crap, like, can you just take a look at my kid's bum? My wife's gonna kill me because she says I need to see a doctor." You've looked like this for a year and you haven't seen a doctor? No. Can you fix my neck? So I feel his neck and swollen and a bit cold, and I said, "Hold on a second, I'm not cutting into this." That's him. Next one is a 25-year-old female. She comes to me with sore wrists, sore ankles, and this hemorrhagic pustular rash on her fingers and her body that's been going on for about a week, and she doesn't feel great. So this is a guy I saw last winter. Comes in with a fever, she's not feeling well, and she has these big swollen lips. She kind of looks like Angelina Jolie, and she comes to see you to say, what's going on with this, my face? Why is it so puffy? And why do I have this rash on the body? 16 pictures, 20 years. Who got 16 rashes correct? Do we have 8? Do we have 4? Good. Perfect. This is what I want. That means that if we're mean average of 4, I've taught you 12 things. Okay? If I can teach you one thing this morning, if you take one thing away and nothing more, I will be watching you, and I will be looking down on you, and I'll be shaking my head like this. Don't ever call something bilateral cellulitis. We get sent these people all the time. You do not get bilateral problems at the same time. And it's a cycle of unnecessary antibiotic after unnecessary antibiotic, and stop the cycle. These people need weight management to lose weight. They need a steroid. Now, usually we just give everyone hydrocortisone, that's fine. They actually need a real steroid. Something like clobetasol, which is a class 1, a very potent steroid. And they need their circulation checked. Ankle brachial stuff to make sure they don't have arterial disease. But this is something we do terribly in Canada, and I'm gonna guess all over the world people just give antibiotics and get these people out of their emergency department. Opioids. This is necrotizing fasciitis. You can see some bruising. This is a young kid, and saw this kid. I don't even care what you think the rash is. If you are hypotensive, tachycardic with a rash, that is neck fash. And you need to give this broad spectrum antibiotics, some vancomycin, some piptazo, some clindamycin, and get them to see a specialist immediately. This kid, I called plastics. We went straight to the CT scanner. I had done a bedside ultrasound which showed gas, and within 15 minutes, he's in the OR. Start just bleeding all over. So he was just in septic shock and starting to bruise all over. I see this kid every summer in Turkey. I wish I was here every summer in Turkey, in Canada. And the key here, who wants to give this kid a prescription for intravenous antibiotics? No. I think we have a major problem, which is somehow people come to see me when they get stung by a bee. Does this ever happen in Turkey? I don't even know why these people are here. And I think the key is that the reason insect bites get infected is because you're dirty. It's because S shape. It's serpentinous. It's like a thing burrowing her skin. And essentially what had happened is we were in Florida on a holiday, and we were playing in the sand. And a dog, typically it's dogs, they pee in the sand, and in that urine there are the larvae of this worm, and this gets under your skin. And the hardest part about managing her was how I had to tell her and her 2 siblings that Dylan has a worm crawling through her skin that's going all around. That part was more delicate to manage, but she was treated with something like albendazole or ivermectin, And literally, do you see a lot of syphilis in Turkey? Yeah. Let me ask you this. Here's a bonus question. What happens when you treat this person with penicillin? So they have syphilis. You look at this and you're like, ah, you have syphilis. And you give them bendazine penicillin. What happens after you treat them? Do they feel good? They come back the next day with a fever, a headache, and a stiff neck. I see someone nodding. What is that called? Jerish-Herxheimer. So Jerish-Herxheimer means you made the right diagnosis. It's the killing of the spirochete makes them come in with fever and feeling crappy, and you tap yourself on the back, say, I nailed it. Okay, next rash. Guy who says his wife told him to come here, hiding behind that, with this rash on his legs. You're going to see this in your practice in people who use heating pads, and sometimes they'll get this on their back. Does anyone know what this is? So this is called erythema ab igni. We see it for people who put their laptops on their legs, or where you will see it is people with chronic back pain who fall asleep with a heating pad on their back. And it's a thermal burn of the back, and it causes this livido-like rash and this brown hemosiderin stain that will never go away. You got this, dude, forever. And it has a small group here that everyone has different skin color and different levels of melanin in their skin. This is a person I saw with guttate psoriasis who's Caucasian. And I want you to look at the difference. And what I want you to realize is that you need to know dermatology for everyone. A lot of the dermatology books are just for white people. And they show white people's rash, but they don't show darker rash. And Malone Makwande wrote this great book on minding the gap and showing the way skin presents differently in dark-skinned person. When I saw this rash, I think about it as these are plaques, and if I met my partner. Herpes, unfortunately, you got it for life. It's the one thing you never want because you don't shake it. Okay. This is an important one. Kid with the rash, kid who has sick, kid who has a history of atopic dermatitis. Does anyone know what this is? So this is eczema herpeticum. So what happens here is mom has HSV1. Mom has a cold sore. Child has eczema. Mom is snuggling with child. Herpes plus eczema. Eczema herpeticum. And this gives you these painful lesions. Remember, itchy, very red, it's very painful. One of the things is we don't like to look at things. Oh, a kid has a rash. Just try this medication. We don't look. But unlike, this is a very red, painful rash. And in the kid who's not getting better with a diaper dermatitis, swab the bum for strep. And you have to think about treating household contacts. I feel like I'm in a part of the world where you may see more of this than I do. But this is the first time I've seen it. This is a Filipino male who's come in with this abscess on their neck and a recurrent abscess. Does anyone know what this kid has? What's that? Yes. So this kid has scrofula. For me, in Canada, we don't have TB, but I'm going to tell you. I think I have a couple more. Young woman, arthritis, rash. Anyone got this? You see where I'm focusing on today. This is disseminated gonorrhea. And I think the key thing about disseminated gonorrhea is it happens about 3 to 4 weeks after the initial infection, and there will no longer be urogenital symptoms present. So if you ask her, do you have discharge or odor? She'll be like, no. But if you say, in the last month, have you had an STD-like symptom, she would say yes. And for some reason, it's much more common in women than men. 4 times more common in women than men. And they get this arthritis dermatitis. So they get these hemorrhagic vesicular and fruit. This is our traveler who's come back with the fever, who doesn't have malaria. What do you got? He has an eschar. There's not many things that cause an eschar. And if you Google search eschar after return from Africa, you find out that he has African tick bite fever. If you work in this part of the world, or you do global health, you're like, yeah, we see this all the time. If you work in Canada, you're like, what the hell is this? If you want to be a good doctor, you need to be able to look after people from all areas of the world. Has anyone seen DRESS? Yeah. So DRESS used to be called delayed phenytoin hypersensitivity reaction. It's often started, it's a late effect. So delayed reaction, usually after starting phenytoin, and these people are sick, and DREG stands for drug rash with eosinophilia and systemic symptoms, and they're sick. There's not a lot of rashes that make people sick. In my talk, we talked about neck fash, we talked about DRESS, but most people aren't sick. That's 16. If you got 0, I'm delighted. If you got 16, you're crazy. If you got 8, 4, it doesn't matter. I want to just say thank you so much for having me, for learning with me, and for listening to me in Turkey. I hope to see you all soon. Thank you so much. I'm happy to take any questions about sports, life, anything. Come up, chat with me, because I'm heading to go visit Antalya.
Al-Munir to present to the stage to start his topic. Thank you so much.
Good morning. My name is Dr. Ayman. I came from Mohammed Medical Corporation in Qatar. I'm working as Director of Clinical Research and Trauma and Vascular Medicine with background data. The problem of our analysis, the conventional analysis we are using, that when we deal with the big data, we have a problem. Also with the connected data, again, the software available like SBS or R or so on have a problem with the big data and the connected data. So the machine learning have solved this problem. The other type of machine learning is a deep learning, which is a multi-layered neural network that learn from huge amount of data. So as I mentioned, after collecting the data and specifying the inclusion and the exclusion criteria, then the system will be trained and validate the data you entered and give you a certain model. From this model, you can choose which one is the best to use. The example of using the artificial intelligence is the matching patient condition to appropriate physician and intervention. So it can quickly when you enter the data of the patient, the machine learning can quickly give you what is the best physician or timing or whatever you want. This according to the predefined data you enter to the model. So it can help the physician for patient diagnosis. This will, which model you can choose, it depends on your aim and the outcome you are looking for. So artificial intelligence in trauma surgery has a plenty of application and it proves to be efficient. It helps to shift away from the old screening method to start to utilizing a new decision tool. The artificial intelligence application in trauma can start even before the trauma happens. So you can use it in the pre-hospital event. You can start applying the artificial intelligence or machine learning from before the starting of the injury or before arriving to the hospital. Then when the patient arrives to the hospital, it can help you to triage the patient. It will guide you when the imaging, X-ray, CT scan finding, laboratory finding, all this will be entered automatically in the Cerner, for example, and the machine learning will tell you what we can do next step. Also, one of the important things for the machine learning, especially for the junior doctor, he cannot detect unseen injury like cervical injury in patient who's in coma. So with using the model like ANN, it can predict the cervical injury for the patient. It can tell you there is a high probability that this patient has cervical injury. So there is many areas of machine learning is the musculoskeletal trauma, for ligament injury, for muscle injury. This also easily missed in the X-rays. So this machine learning can guide the physician about the accurate location of the injury. In traumatic brain injury, it is very important because there is a limitation to predict what is going on or what will happen for the patient with brain injury, because a lot of factors will play in the prognosis of brain injury. So if you utilize that machine learning or artificial intelligence and train the system about what is the important variable we should use for this patient with brain injury, this is very helpful with the resuscitation and so on. All this information automatically on Cerner connected with the machine learning software that will end up with very accurate or nearly perfect accuracy of the prediction. Also, it is important thing in machine learning, they give you this as a figure. So you will not be bothered by numbers and so on. I will show you this. This is another example of how we can apply the machine learning. So if you have 1,000 patients, for example, the machine learning will do what is called a training. Use, for example, 30%. It will give you a figure showing you what is the important variable in these 7 days. We found that the blood transfusion and the ICS is the most important variable that can predict the patient will stay 1 week. If we look for more than 10 days, we found that if the patient develops VAB, this means the patient will stay more than 7 days. An artificial neural network model we used for prediction of more than 2 weeks, we found that ICS and blood transfusion and what is the lesion in the brain can predict the patient will stay more than 2 weeks on the ventilator. So predicting patient at risk of prolonged mechanical ventilation can help you to the time and the cost and the life. And thank you very much.
Thank you, Professor Ayman. For the interest of time, we'll take the questions at the end of the session. I'm pretty sure you all have multiple questions pent up. We'll take it at the end. Next, we have Lies, Damn Lies and Algorithms by Professor Prabhat Nanayakara. I wonder what this whole lies, damn lies and algorithms are about.
Yes, thank you very much, Mr. Chairman. It's good to be here. And my name is Prabhat Nanayakara, and I'm the Professor of Acute Internal Medicine in Amsterdam University Medical Center. Our research in the last couple of years has concentrated especially on, we all talk about algorithms, but almost nobody uses it in the practice. Why is that? If you look at, this is my alter ego, you know, this is my alter ego. I'm a musician and singer and songwriter. My songs are there in Spotify. I get mails all the time from American companies. We have run through your songs through an algorithm. They have potential is the best thing for the patient. And our journey in artificial intelligence started a long time ago. And a couple of months ago in Annals of Internal Medicine, we wrote this piece about ChatGPT. We're going to hear more about it. And what we did was we took an abstract from ChatGPT, from Annals of Internal Medicine, put it through ChatGPT, and asked people which is which. Which one is ChatGPT? Which one is from real Annals article? And most of them got it wrong. So you see that artificial intelligence is going to end up in Grey's Anatomy. You have done something well, you know, so you think, okay, you don't need to do anything else. But what we saw in our patient population was we had a negative results. There was no difference in the two groups, but we could see that young patients probably, if we had more young patients, would have given us a positive result. I mean, every result is positive, but effective results. So what we did was we used machine learning to see and to play with our population to see. Let's say we had more young patients. Do you think the results would have been different? So what we saw was there was an interaction between time and antibiotics. 50% is contaminated. So it's happened all over the world, so I'm sure in your departments also. The yield of blood cultures can be about 1.4% to 17%. Positive blood cultures. Contamination can be as high as 30 to 50%, especially in the emergency department. Because the blood culture outcomes are only known about 2-3 days later, their contribution to clinical decision making can be pretty low. Less than 3% of the blood cultures really helps us in our decisions. So we thought, we are going to, and also one of the biggest problem is we think that blood cultures are very harmless. So you can do system and did not tell anybody that the model was running behind, which means whenever somebody did a blood culture, we could see what the predictive is. By this patient, the chance of positive blood culture was 10%. I'm just taking through the journey of developing and integrating algorithm in a chart and then try to get it working in a department. So this is the third step, integration, and just running it behind their backs, and doctors don't know about it. What happens was, when we did the prospective evaluation in 1,000 patients, doctors didn't know that this was running. Still, the AUC was pretty good to predict blood culture positivity. You could read those in the publication. Effective. These models improve the processes of patient outcomes. So we are busy preparing a randomized controlled trial now. We hope to start this on 1st of December. We got the ethics approval, we got our funding. There are 2 PhDs already working on the process, where what we are going to do is, if somebody decides to do a blood culture in a patient, we have some exclusion criteria, because you cannot use people with immune-compromised patients and also patients having catheters to predict blood culture.
The order a bit. Next topic.
Sorry, because we have changed actually the topics now. I don't know, it's good morning or we're such afternoon now. What's the time? I'm not sure. Nice to meet you all here once again. I'm Dr. Ibrahim Abu Jundi. I'm emergency consultant and head of the hospital called Al Khor, which is stated in Qatar. Usually Qatar has a medical corporation which has 5 hospitals, and this Al Khor is one of those hospitals. This is the night view of Doha, the capital of Qatar, and this is the sea view, because I love sea, and this is a beautiful place. I really invite all of you to come and have a nice time in Qatar. If you have a chance, really you'll love it. Okay, this is very important for me. I have no conflict of interest, so I don't get any money, nobody give me gifts for all these things. Okay. Today we're going to talk about ChatGPT and how we use it in the writing and research. And we're going to go through the introduction, application in the medical research, advantages, and of course the most important, limitation and ethics consideration, and future prospect and practical application and recommendation. Before starting the presentation, I just would like to share with you my personal opinion. Actually, I belong to the old school. Within 10 minutes, it's done. I remember just a couple of weeks back, my daughter, she's 13 years old. She has some project in the school, and she asked my son in the lunchtime. They're discussing something. I said, what's wrong with you? I think she's late to submit that project. So I told her, don't worry, it will be done. I really realized that she's helping her to do the project. So he went to his room, as was I said. After 10 minutes, she finished a bath, and then she went to him. Did you do this? I said, it's in your email. Then I thought, hold on, come here. What's in her email? No, the project. When I saw the project, I was shocked. Now I am head of the Department of Emergency and have been experienced more than 20 years. I cannot do this in 10 minutes, what he did my son in 10 minutes. That's really scary. But let us go to the lectures. We'll go back to that. In GPT-3, this is GPT-4 now. They said it is 82% less likely to respond to requests for disallowed content, and this is very important actually, disallowed content, and 40% more likely to produce factional responses. We'll go through a little bit of the uses which has been mentioned earlier here. Languages editing, scientific articles, and can write literatures and review the health related topics. It can generate summaries or provide abstracts for articles, and can synthesize ideas. It can give you an idea which topic you want to research about, which topic you want to present. Can give you lots of ideas around. And do proofreading and grammar checking, and analyze data for scientific purpose. It can be done by done by the most expert person in that field, but actually it's done by the program which has been downloaded. The other part of the ChatGPT which we have to care of, it is the limitation and ethical consideration. So it is really a tool. It is really, like you can say, way of gaining information, but we have to be very careful in using it, and it has lots of limitation. It actually is not made for only medical field. It's not made for us. We think about it, we are talking about it now because we are in medical field, we are physicians. Those type of access to information and different platforms affect, I'm sure, 100% directly on us as a physician, on our juniors who's learning, the resident, even our patient, our customer who's their patient, their concept of the medical field, their concept of a physician, what the physician can do to them, how they can treat them, what type of what's called your blood works and all. You just cannot Google your medication. He said, doctor, it's not only me, everybody's doing the same. And don't think, you'll not lose your job. But I said, it's not a question of losing my job, you're going to lose your life with this one. You cannot just Google medication over the line. And this is what actually, those information has been put in the platform from different sources. Some of them are not even medical, putting the information. I have even seen some papers, some people talking about medical aspect. He's not even have medical background. And this is really scary. The other is it can spread disinformation that based on extraction from available online content. Now, anyone can upload any information belong to his belief, his ethics, his background, and this will be uploaded. With my child, if you depend on this, even our medical resident will depend on this. The other day I was discussing with one of my colleagues. One resident presented with case presentation. When I saw that case presentation, I was so impressed. I am in the emergency field for more than 20 years. I cannot do this type of things. So I told him, how did you do this? Who helped you? Who's for example, other consultant or assistant professor? He said, no, I did it on my own. And we find out some ChatGPT. So people want to start using this, they'll switch this and use this. This is the dangerous. The institution, what's called critical thinking skills, the communication skills, all will be lost. This question has been different answer, different opinion, and I'm not sure the right answer for that. But some people say it doesn't even make sense. It is dignity of science and use of ChatGPT as co-author, and it is fun, but it's not an author. And many scientists disagree with this. But let us see why and how. ChatGPT cannot take responsibility for the content and the integrity of the sentence. Artificial intelligence and ChatGPT's update, of course, we're not ignoring it or subusing it. It is a very useful tool, really very, very helpful tool to be used. And it should be used as adjunct rather than private sources, primary source for the writing process, and always use de-identified patient data to protect the privacy. Disclosure of the use of the ChatGPT is very, very important. We have to disclose that we're using this information, we got it from what source. And cite it when you use the tool or source with the assistance. And AI-generated text must be critically reviewed by medical experts and to validate it before using the content.
I'm Siju. Without much ado, let me just go straight to my topic. Now, how many students in here? Residents, medical students, undergrads? Oh yeah, quite a fair number. I'm going to actually see, when the topic was initially allotted, I was under the impression I was going to talk more about ChatGPT. But the moment I gave this lecture as a topic, I knew I was in trouble, because the moment I gave this, that was maybe a couple of months back, 3 months back, everything has drastically changed. And now I'm actually modifying it every day, including yesterday evening. So without much further ado, let me just go straight to my topic. And I'm going to start by actually telling you what I'm going to talk to you about. I'm going to talk to you about the current landscape of artificial intelligence in scientific writing. I'm going to talk to you about the good, bad, and ugly of scientific writing using artificial intelligence. We'll go and maybe have some idea about the ethics behind the whole stuff, you know. And Dr. Ibrahim actually made my life much more easier by actually handling all the nuances with regards to the biases. So these are my references, and I would want you to actually take a look at it, because you know, you have the UNESCO, you have the WHO actually coming up with guidelines. In the Indian Council for Medical Research has come up with ethics of AI. So you can make use of these. Reconstructed what the functional MRI was looking at. Can you see that? You know, it's quite similar to what they were looking at, you know, if you match it out. I'll give you another example. So this was in 2023 published in Nature Neurosciences. You know, I couldn't get the video from their abstract, but you know, look at the video. So they showed this video to a few people sitting in a room. They did their functional MRIs. They asked the artificial intelligence platform to look at the functional MRI and respond. So it said, I see a girl that looks just like me get hit on her back and get knocked off. And you know, I have my whole data set ready up for me. That's what they were talking about mostly, about antivenom development, about hypnale. You know, the word cloud is built for me. Now, it took me just that many minutes to actually get it done. Now, I'm doing a PhD in coagulation disorders, so and doing a literature map to see where my research stands right now. You know, that's me there. How many of you has cited me? Whom did I cite earlier? Like he was saying, I had to take all these literature, sit down, timeline map them, and then see what happened where. Is it all good? So that's what I want you to actually, you know, think about. You know, is it all good? Dr. Ibrahim was actually putting it up in a very nice way. You know, you have the complexity of the review, which this algorithm right now doesn't understand. Probably it will start understanding in the future. You know, I put in something called GIGO out there. You know, anyone know what GIGO means? Yeah, garbage in, garbage out. You know, you put in garbage, you're going to get garbage. So whatever, it's all pre-trained, right? So your input matters. So whatever you put in, if you don't know what it is, and if you have no clue, and you're going to get garbage out. Now, and with regards to the bias, there's so much biases with regards to confirmation bias, contextual bias. The best example which I heard was, you know, the camera phones. You know, data privacy issues, all this came across when you started having small microchipped camera phones around you. So these things are going to change drastically around you. And with all new tech, a new class of responsibility comes. And if the tech
is not regulated properly, it's going to end up in a rat race, and the rat race is going to end up bad. Now, I'll put one thing here. This is the interesting paper, Theory of Mind. Theory of Mind. This is by Kosinski. It's in the preprint format. So, if you look at it, you can see. You know what theory of mind is? Theory of mind is what you and I have. The human way of thinking, and able to put, say, unobservable mental states in, spontaneously emerged, but it has seemed to have spontaneously emerged in these large language models. If you put, so ChatGPT was given, ChatGPT performed the best of the lot, and you can see that particular theory of mind has changed over the last, and the time frame, just take a look at the time frame, 2018, 20, nothing happened, 22, 20, and the bottom line is going to be that with all great power, so use it responsibly. Now, keeping that in mind, I want you to actually have an overview with regards to the ethics involved in AI, and the UNESCO WHO guidelines and, say, the Indian Council of Medical Research guidelines are excellent. And since we are already talking about it in lots and lots of different medias, I think we are in the right direction. I'm going to leave the question about whether we are in the right direction to you. And when you're writing, see, the LCB has got, it's got its AI-assisted technologies in scientific writing. They got Springer's actually having their own policies now. So I'm going to leave that question to you, whether we are in the right direction, because the responsibility resides in you, in using this technology responsibly.
Actually, I don't know if it's developed already, or do you think ChatGPT is good for that use?
To be honest with you, and I'm sure there's no right answer for this, because it still is under development, and one of the recommendations which I mentioned in my talks, really, it's a tool. It's very, very useful tool. It's very, very important tool which has been developed very fast and help in different aspects, really, and it helped different professions, especially in the medical field. It is very, very good help, but at the same time, it is very, very important to know how to use it, when to use it, how extend to use it. Like, for example, I'll just give a very, very simple example. The butter knife or the knife, it is a tool, has been for many years. If I give it to my wife, she can cut apple and make nice fruit salad. If I give it to my 2-year-old child, he can cut his hand. So if this tool has been given to an experienced person, a resident R1 or R2, just starting his life, using this, depending on this, he will lose a lot of things. Confident, communication skills, critical thinking. Yeah, he will get good outcome, because not he's the one did the job, someone else did it for him, and he'll be appreciated and all this, but he will lose the learning. He will lose, the intuitions is what comes from you doing the job, doing learning, doing the research, and getting at the end of it, getting the result. And that, believe me, psychologically, you'll feel more proud of yourself when you did hard work and you get the end product and successful. Other the person who's sitting 5 minutes, 10 minutes and get amazing outcome, but he did nothing, someone else did it for him. It is actually a very controversial discussion about this. And to be honest with you, I'm not an expert about this. And to be honest with you, I'm not an expert, an emergency physician. Give me a patient I can handle.
What do you think of it?
Let me repeat your question. Your question is whether we should include more workshops with AI, right?
AI, how to use an AI in the practice.
Exactly. So I'm going to echo what he just said, and coming back to what I was saying also, using AI responsibly. How do we use it? Now, yes, you are absolutely right. In the sense, we need to have, and I'm pretty sure it's going to come up in the next few months, I guess. You're going to get all these workshops. Who's actually going to? Because see, even so, I've been using artificial intelligence for multiple purposes, including a systematic review.
should be done for multiple injuries and in patients with blunt major trauma and suspected multiple injuries. Patients should not be repositioned during the whole body CT scan, and use the clinical findings and the scanogram to direct CT of the limbs in the adults with limb trauma. So the question here is still, are we going to say that we suspect multiple injuries in this patient with low risk road traffic accident and only a graze and a bruise on a head? Second is a high energy head injury guideline looking at further literature. There has been an attempt to answer this question by Richa Arora and Abhishek Arora, where they looked at a retrospective analysis of 150 cases of polytrauma who underwent whole body CT scan in 2017. It was a single center tertiary care major trauma center in North England. And of those 150 patients, including in that study, the whole body CT scan was positive in 46 patients, that is in 104 patients, while 46 patients, the 30%, had normal scans with no trauma-related pathology. The 25 scan requests were made due to and looking at the literature with regards to the trauma CT scans. It is the positive rate which determines what the thresholds has been used to actually conduct the CT scan in the first place. So in the first study we had a positive rate of 70%. In the second study we have a positive rate of 40%. So they already had a relatively low threshold to actually do CT scans. However, the authors concluded that in high energy trauma, they should consider the whole body CT scan based on the mechanism of injury alone, regardless of the clinical examination findings. So the question still remains whether we would do a And interestingly, what they found that within the single system injuries, when comparing the pan CT with the single system CT, there was no change in the mortality. However, there was a significant change in the length of stay between the two groups. The ones who underwent a single system CT, there was a significant number of patients who had a longer length of stay. So the question still remains whether to do a whole body CT scan or not, and then he's fallen down on the ground. And these things matter. The exact mechanism of injury matters in trauma. At this stage, I would want to remind you of another case where a 12-year-old presented to an emergency department with a history of falling from a trampoline. Now, history was documented at triage, fall from a trampoline. She has walked in, she was examined, and she was then discharged. In reality, the child had actually had a fall after jumping on the trampoline into the air and then landing onto the ground. So rather than a fall from just a 2 foot high from a trampoline, it was actually a fall from more than the child's height after going up in the air, dependent on the length of stay rather than the mortality effect, especially in the hemodynamically stable settings. In the settings where we are, whole body CT scan is much more cost effective compared to actually admission into the hospital. These are the references which I have quoted during the talk. I'll take any questions if you have.
Any questions from the crowd? We have 2 minutes? If not, we'll move to the next session.
Thank you very much. So I'm also moderating this session, and I would like to introduce the next speaker, Dr. Vimal Pillai. He's professor of emergency medicine at Kasturba Medical College in India, and his Kasturba Medical College in India, and his skills include the coordinator for the medical.
A lot of fluids in the emergency department. The patient's still in shock. Now that's going to ring a bell somewhere. What are we going to do for a patient who is persistently in shock? You want to give blood. You're thinking blood, right? You're thinking some strategies to reduce the bleed, right? So we'll talk about how you can change your thought process for managing a refractory shocky patient post-trauma. Emergency medicine is nothing but you recognize patterns, you translate the knowledge that you have, and you have the courage to take the best decision based on the limited knowledge you have at that point in time. Because retrospectively, and I'll tell this to all residents in the room, retrospectively, every other consultant would come to the ER and say, you didn't know this? Retrospectively, they'd come down and say, we had more information, you guys didn't do this in the beginning. So that's a curse that we're born with, the responsibility that we have to work with limited information. We'll talk about some newer strategies in managing hemorrhagic shock. We'll talk about a case-based approach, something that I do day in, day out for hemorrhagic shock in the emergency department. Shock, we all know, it's inadequate perfusion to the tissue. It's not just a low BP. We know that trauma is a leading cause of mortality. There are stalwarts managing trauma in this very room, and you'll hear from them in a bit. Trauma, it just doesn't kill, it kills more than 40% of the world. It just leads to poor quality of life. And that is the reason we just don't need buildings for trauma care. We just need processes in place, systems in place for trauma right from the field to rehabilitation. That is what the focus should be. There's a need for rapid intervention instant by the acidemia that you have in that place. Your triad kicks in, your death triad kicks in with severe acidemia and hypothermia leading to coagulopathy. The dilution that we induce on the patient by pushing in a lot of saline is another component. Not to forget the inflammation, the medications that the person's already on, and the genetics part. Now we are living in an era of longevity. We are living in an era where we are treating more and more elderly, older people. People who are on oral anticoagulants, newer oral anticoagulants, newer antiplatelets, newer drugs, which can lead to more bleeding, specifically in our part of the world. There is a huge focus. The focus earlier when we were doing residency a long while back was on products, products, and products. You order for blood, hemorrhage protocol in your setting. You got to work on that. There are different stratification scores which have come in to trigger a massive hemorrhage protocol. There is an RABT score, there is an ABC score. Converge on a score that is accepted by your university, by your hospital, by your setting. Team prep and performance. It's important to sim and sim again with all the stakeholders. You've got to get the transfusion medicine in. You've got to get the blood bank in. You've got to get the buy-in from the trauma surgeon. You've got to get the buy-in from the emergency physician. You've got to get the buy-in from the critical care physician. You've got to get the buy-in from the nurses. You've got to get a buy-in from the ancillary care lab guys. You got to get a buy-in from all these people together to run a system. So team prep and performance in advance. Tranexamic acid, I don't need to specify more about it. It's come into literature. It's proven its benefit again and again. We need to test early. We'll focus on testing. ROTEM or TEG. I think that is going to be the point of care test for hemorrhagic shock. This is the ECG for hemorrhagic shock for your trauma patient, for your polytrauma patient. And I'll tell you why. If you look at viscoelastic hemostatic assays, they give you a dynamic opinion of where you are in the cascade, whether you've got a hypocoagulability, whether you're hypercoagulable, whether you need cryoprecipitate, whether you need platelet, or you just need fresh fluorescent plasma. It's as simple as that. Who decides on the product? It is a patient who decides on the product. It is not the protocol of your hospital that decides, I need to give this patient pack A or I need to give this patient pack B. It should be the patient's hemodynamic status. It should be upper GI bleeds. You need to ensure that that thrombocytopenia is not your target. Your target is the coagulopathy that the patient is coming with. And that can be worsened with our volume resuscitation in the emergency department. You need to dictate terms on how you can correct the same. Now, if you look into the method, it's all in a cup. I call it the cup and pin method. You take in a cup, a pre-warmed cup, either the cup rotates or the pin rotates. You have a shear strain on the cup. It forms a clot, a thin clot, and you measure the clot stability. The mechanical activity is converted into electrical activity. Where have you heard of that? Residents in the room? ECG. Now, if you look at the first half, that leads to the clot formation part. And if you look at the second part, that leads to the fibrinolysis part. Now, what we need to do is, we need to use these parameters to just check up where your patient is. Is he in the clot formation pathway or is he in the fibrinolytic pathway? Where is he in that balance? I'm not talking about static parameters where you look at one fibrinogen level value and the fibrinogen is very low. But the time which is passed when you get that value in hand, the patient would have received more blood, more fluid, and would have passed that strategy long ago. So you need to think of dynamic strategies here. So just to deal with a BP of 90-60, residents in the room would definitely manage with fluids and then ask for blood. The moment I sent a check for him, I did the same. I did the initial resuscitation. He was bleeding too much. I did initiate the massive transfusion or hemorrhage protocol. In our setting, we gave PPIs, we gave octreotide. I asked for the SB tube so that I can place off the Sengstaken-Blakemore tube to prevent more bleeding. And then I checked up on the values, severe shock, hemorrhagic, hypo, you've got platelets which are on the lower side too with an APTT more than 120, static value. I sent for the TEG, it turned out to be like this. If you look at the values, again, the lysis is happening at a high level, at an extremely high level, the lysis is happening, and then you have the MA on the lower side. You need to make a change to create a change in the world. Thank you for your patient listening. You can have my references from this QR code.
We have 2 minutes for any questions.
Like me, much of this room is working in the emergency department. Also in emergency, when we solve the hemorrhagic shock trauma, our main goal as soon as possible to send the patient to surgery room. So we generally have less time with the patient instead of rare cases. So what do you think about, also you mentioned that hypocoagulopathy is more risk for these patients in hemorrhagic shock, to use in a sudden time synthetic factor X3s for coagulopathy.
So we now have a next talk on lethal hyperkalemia during massive transfusion protocol after preservation period of red blood cell products was extended.
Welcoming Professor Mizobata.
Mizobata. Oh, sorry.
welcoming Professor Misabata, who is Professor of Trauma Critical Care Systems in Osaka University, in Osaka Metropolitan University, Japan.
Thank you. I'm Misabata from Japan, and I appreciate for EPAT and WASM for giving me this opportunity to present my study. And also thank you for Professor Himanshu and Professor Bimal to moderate this session. But first, I have no COI for today's presentation to be declared. Massive transfusion protocol arrival, the airway was maintained spontaneously, respiratory rate was 30 breaths per minute, blood pressure was unmeasurable, but the pulse of the femoral artery was palpable. Heart rate was regular at 136 beats per minute. Glasgow Coma Scale was E3V1M5, and his body temperature was 36.1 Celsius. After we found a massive hemothorax on his right side chest via focused assessment with sonography for trauma, first, we immediately performed tube tracheostomy and activated MTP with the use of options, including the calcium ion product. Next case is a 44-year-old Asian man. When he was riding on his motorcycle, he ran out to the opposite lane and had head-on crash with a car. He had no helmet and was transferred to a hospital. On hospital arrival, the patient's airway was maintained spontaneously, respiratory rate was 30 breaths per minute, blood pressure was 98/87 millimeter Hg, with a purpose of the transfusion. Arterial pH was low on his arrival with high blood lactate level. The potassium concentration increased from 3.5 to 7.8 ml equivalent per liter. This elevation of the potassium concentration was supposed to be the cause of lethal arrhythmia. The amount of blood product delivered at this time were 12 units of RBC, 12 units of FFP, and 20 units of platelet concentrate. The calcium PC 1:1 ratio theory based on the previously reported evidence. In our institute, blood product including cryoprecipitate is always available, and once MTP is activated, packages are constantly brought to the resuscitation unit to maintain the ratio of composition as shown on the slide. We usually administer blood transfusion with the use of level 1 fast flow fluid product. Thank you very much.
Thank you, Professor Misabata. Any questions for Professor Misabata? There are no questions? No. There's one, yeah.
How practical, thank you for the excellent presentation, but how practical changing the filter for the potassium during a infusion every 4 hours, and the amount of blood transfusion in these patients is quite extensive. So how practical changing, potassium filter to capture all the excess potassium?
Thank you very much. Yes, I know that the filter for the potassium is recommended to change every 4 unit. But it is thought to use in the ICU or in the ward. For the mass transfusion protocol, the 4 administered calcium ion to prohibit the elevation of the potassium ion level. Thank you. Thank you very much.
Thank you, Professor Misabata. For the last talk on the session in trauma, we have Professor Dr. Hassan Al-Thani, head of Trauma and Vascular Surgery section at Hamad General Hospital, Qatar, who will be talking about acute kidney injury in trauma. What do we know? Over to you, sir.
Thank you. I would like to take the opportunity to thank the organizing committee for the privilege of the podium and also for the kind invitation and the exciting program. As usual, they never failed me to see an exciting program. This is what Sagar recommended that we have to put the slides. So my name is Hassan Al-Thani. I'm from Doha, Qatar. I have nothing to disclose for this presentation except that I am working in Hamad Medical Corporation. So the specific objective of this is the injury in a trauma setting is a similar things. We actually give a contrast for these patients when they come for scanning. We have a tissue damage, we have hemorrhagic shock, we have rhabdomyolysis and abdominal compartment syndrome, as well as the excessive fluid that we give the patient. There is a ischemia, reperfusion injury, hypovolemia, myoglobin is produced, systemic inflammatory process, renal oxidative stress, and then intrarenal vasoconstriction, and the abdominal compartment will result also in renal parenchymal effect with the renal vein compression and actually compromise, and more activation of massive transfusion protocols. When we also looked at the complication, patients with acute kidney injury suffer from more ARDS, more ventilation-associated pneumonia, sepsis, and also central line and catheter-related sepsis. And the length of stay of the patient in the hospital with acute kidney injury were significantly higher in comparison to a patient who did not develop acute kidney injury. Ventilation requirement is high, and hospital length of stay was also significantly high, with significant mortality. 65% of the patients who developed acute kidney injury died while they are in hospital. CT scan for them, and the contrast required for these are quite high. When we looked at also the procedure done for this patient, we have 96% of the patients were intubated, the patient who actually suffered acute kidney injury. Hemodialysis was required in 64% of the patient, and patient who survived and off dialysis was 23%. And there is patient recovered from acute kidney injury with normal kidney function is 32%, and with not normal kidney function but did not require dialysis was 32% also, and 7% of these patients require ECMO. The stage of acute kidney injury, the majority were stage 3, high stage of actually acute kidney injury. Also, the severity of injury was much higher. ISS was 33.7 plus or minus 12 for non-survivor in comparison to 25.5 ISS. And as I said, all the patients who did not survive with acute kidney injury were intubated in the scene or in the emergency setting. And 30% of them underwent laparotomy and 6% had craniotomy. Complication was also significantly higher for the patient who who did not survive. And the main thing when we look at the multivariate regression analysis for the predictor of mortality for acute kidney injury were age, hypotension, and injury severity score. And this is actually a chart of all the patients who actually are the mortality as demonstrated in the graph here. So in conclusion, acute kidney injury is not uncommon among the trauma patient and associated with high rate of a prolonged hospital stay and mortality. Early detection and prevention of acute injury should be a priority in such high-risk population. I would like to thank you for actually the privilege to present, and I thank the organization committee for the invitation.
Thank you, Professor Altani. Any questions from the crowd?
Hi, Doctor. Thank you for this great presentation. I have one question as I'm a new emergency medicine resident, so I have this inquiry about the rhabdomyolysis. So what is the greatest risk factor of rhabdomyolysis to cause acute kidney injury? Is it the site of the injury to the muscle? So for example, is it in a great muscle, for example, the quadriceps, or a small muscle? Or is it the duration of the injury since the muscle is crushed until we detect the myoglobin in the urine, so we can determine the acute kidney injury is being already detected? Thank you.
There are no questions. We are wrapping up the session on time. There's one more question.
Hello, Dr. Altani. About AKI in trauma patients, the crush injury point was a very excellent point regarding the injury pattern. But when it comes to preventive strategies to prevent AKI, is there still an accepted norm to have a prevention algorithm in terms of fluid? Or if there is a crush injury, we start with bicarbs early, estimating rhabdomyolysis, or we make sure that the pressures are maintained, because if the patient is in hypovolemic and the use of contrast, when they come together, that could be. So is there a renal protective strategy which has been discussed or highlighted in literature?
That's a good question. In a trauma setting, the best renal protection method is resuscitating the patient early. By resuscitating is trying to stabilize the patient hemodynamically. When you achieve that, you actually achieve the renal protection method. Adding medical treatment, we know that it is not working for a trauma patient, and therefore, in my management of these patients, we looked after the ABCs.
Çeki karını. Onları da vereceğiz. İman şunu. Şunu aç. Bunu da aç. Bir de şey abi. Yasemin su. Şimdi heybe vereceğiz abi.
So we'll bring this session to a close now. We had excellent sessions about low-risk trauma decision-making, then a hemodynamically shocked patient using tech-guided MHP protocol, and then 2 cases with unfortunate outcomes following major trauma, and finally...
Atuder ve Vacem Başkanı Sayın Profesör Doktor Başar Cander. Bir diğer konuşmacımız ise Altınbaş Üniversitesi.
Bizim hayatımızı en çok etkileyen olaylardan biri. Mesela biz workshop yaptık İstanbul'da. Workshop yapınca bir hocamız workshop yaptığımız otel mesafesiyle hastane arası 500 metreyi geçmiyor. Sayın Boy vardı burada. Otele yürüyüp geleceklerini planlamıştık. Bir türlü gelemediler. Sonra sorduk nerede arkadaşlar diye. Onlar da telefon açtılar, dediler ki ayağını incitmiş, yürüyemiyor. Bu yüzden gelemiyor. Biz bir arabayla aldık. Şimdi şöyle düşünün. Biz buraya aylarca, yıllarca hazırlandığımızı söylüyoruz. Ama bir ağrı semptomu, bir boyun ağrısı, bir kas ağrısı bizim bütün aktivasyonumuzu burada ne yapabilir? Geriye düşünebilir. Yani bunu hayatta da gördüğünüz zaman aslında basite alıyoruz ama yaşayınca şunu anlıyoruz. Hepimiz yaşadık, yaşıyoruz. Bunun aslında hayatımızı ne kadar etkilediğini görüyoruz. Mesela hepimizin deneyimi olmuştur. Yaşamadan anlamıyorsun diyorsun ya. Yani mesela her gün çorap giyiyoruz değil mi? Çok basit. Herkes çorap giyiyor. Sırtı tutulan biri, sırtı ağrıyan biri nasıl çorap giyiyor? Ben birkaç defa denedim, neredeyse düşüyordum. Mümkün değil yani. Yardımsız çorap giymeniz mümkün olmuyor. Pasif elemanlar ve aktif elemanlar olarak söyleyebiliriz. En genel belirtiler ne? Ağrı, işte sabah tutukluğu, hareket kısıtlılığı. En çok hissettiğim yer ağrı kesiciler. Eğer etkili bir ağrı kesici. Mesela bir diş ağrısı çekiyorsunuz. Hayatınız kararıyor. Hiçbir şey yapamıyorsunuz şiddetli ağrı için diyoruz. Ve bir ağrı kesici eğer sizin diş ağrısınızı kesiyorsa veya renal koliyi düşünün veya işte bahsettiğim sırt bel tutulmaz. Ağrı kesici alıyorsun ve birdenbire bir konfor hissediyorsun. Bir mutluluk oluşuyor. Dolayısıyla arkadaşlar ağrı kesmenin bir doktorun en önemli görevlerinden biri olduğunu unutmamamız gerekiyor. Bu yüzden de tabii ki biz ağrı kesicileri çok fazla kullanmak, çok fazla yazmak durumdayız. Bunun için de mutlaka ağrı kesicileri çok iyi tanımamız gerekiyor. En sık kullandığımız ilaçlar olduğu için. Tabii burada bir kaslarında bir şey oldu. Kaçıncı dakikada çıktı? Biz bir taraftan kongre takip ederken bir taraftan da bunları görüyoruz yani. 45. dakikada Fred'i çıkarttılar değil mi? Benden başka Fenerbahçeli yok yani. Peki. İlaçlar sebep olabiliyor spazmına. Ani keskin ağrı varsa, cilt altında sert bir kas dokusu hissi varsa, kas seyirmesi varsa biz bunlarda kas spazmını görüyoruz. Şimdi gerçek bir spazmda kasları uyaran sinirlerin öyle düşünün yani. Bel kas spazmı bu da kötü. En sonunda bir şey yapalım, anket yapalım. Hangisi daha kötü diye. Gerçekten bel kas. Böyle duruyorsun. Bunları da yaşayınca daha iyi anlıyorsun. Hastaları da daha iyi anlıyorsun. Kas güçlü değilse vesaire bunlar oluyor. Evet bunlar hayatı tehdit etmeyebilir ama birçok insan hayatını tehdit ediyor. Neden? Ya adama hazırlanıyorsun. Mesela şu anda düşünün biz bu kadar çalışmadan adam Hindistan'dan geldi, Japonya'dan geldi. Ondan sonra diyelim ki kası tutuldu, beli tutuldu. Nasıl konuşma yapacak? İşte o sırada bu ilaçlar devreye girmesi gerekiyor. Burada bir ağrı vardır. Sırtta kas spazmı, omuz kas spazmı bunların hepsi diye düşünmek lazım. 2 litre su içmemiz lazım. Süt, portakal suyu, muz gibi kalsiyum, potasyumdan zengin besinler ve stressiz bir yaşam diliyorum sizlere. Bu nasıl yaşanıyorsa. Sonuç olarak arkadaşlar tedaviye geçeceğiz. Tedavide bakın ağrı kesici yazarken aklımıza gelen en önemli şeylerin başında nedir? Şimdi Murat Seyit önümde olduğu için soruyorum. Ağrı kesici de ilk aklına gelen ne? Yazarken ne düşünürsün? He? Hızlıca etki etmesi. Bu ofansif bak. Ofansif duygu. Bu duyguyu yaşayanlar genelde farklı. Ama eğer şöyle deseydin, bu ilaçlarla. Bu önemli. Dolayısıyla tedaviyi yaparken semptomatik yapıyoruz. Güven duygusuna önem veriyoruz. İlaca güveniyoruz. O ilaca güveniyor olmamız lazım. Tabi burada fizik tedavi yapılabilir. Lokal ısı uygulamaları yapılabilir. Bazen soğuk uygulama gerekiyor. Eklem içi enjeksiyonlar var vesaire. Cerrahi tedaviye kadar gidebilir. Ama hem analjezik hem de miyorelaksanlar bize bu konuda yol gösterecektir. Bir an önce tedavi olmak istiyor. Bir an önce işine dönmek istiyor. Daha doğrusu o ağrıyla işi yapmak zorunda. Ağrısını azaltmak zorunda. Çünkü çoğumuz bu ağrıyla yaşamayı öğrenmek zorunda kalıyor.
Efendim, hoş geldiniz. Tamam, zorlamayalım. Buradan konuşalım, sıkıntı yok. Efendim hoş geldiniz. Şeref verdiniz. Hem sizler hem uluslararası konuklarımızla beraber burada olmak oldukça güzel benim için. Çok basit bir soruyla başlamak istiyorum. Eğer sizin için uygunsa. Genç, yaşlı, erişkin hepsinin ortak problemi her geldiğinde ne oluyor? Ağrı. Tabii ağrı dediğimiz zaman ağrı ile ilgili olarak birçok şey söyledi hocam. Bağlantılı olarak spazmla ilgili de birçok şey söyledi. Bütün bunların hepsinin temel kaynağında, özellikle mesela spazmın temel kaynağında bir homeostatik dengenin bozukluğu söz konusu. Dikkat ederseniz replasman tedavilerin hepsi aslında homeostatik dengenin arası enflame olmaya başlıyor. Aynı şeklin bir başka görüntüsünü burada sol tarafta görebiliyorsunuz. Enflame oldukça aslında kas lifleri hafif hafif birbirlerinden ayrılmaya başlıyorlar ve arası şişmeye başlıyor. Tabii enflamasyon beraberinde kendi medyatörlerini de getiriyor. Enflamasyonun medyatörleri çok enteresan. Enflamasyon medyatörleri bildiğiniz gibi aynı zamanda ağrıyı da tetikleyen medyatörler. Özellikle nosiseptörler üstüne çok ciddi anlamda etkililer ve sensitizasyonunu sağlıyorlar. Ağrının en kötü tarafı şu, ağrıda bir ileti gerçekleştirdiğiniz zaman ağrı yukarıya kadar gidiyor. Yani hani yukarıya kadar, beyine kadar geliyor fakat cevabı oluşturulamayan bir durum. Yani bir respons veremiyor vücut buna karşı. Yani enflamasyon cevabı oluştuktan sonra endotel hasarı başlıyorsa, dokuda ciddi anlamda ödem gerçekleşiyorsa veya doku bütünlüğünün bozulması başlıyorsa o zaman bir fasit daire haline geliyor ve doku hasarı sürekli kendisini yeniler bir duruma geçiyor. Tabii biz bunu hani kronik olarak CRP'nin falan filan çok yükselmediği durumlar da söz konusu bu arada. Ama yani hani akutta gördüğümüz kadar çok fazla gözlemleyemiyoruz. Ama vücut içten içe kendisini hırpalamaya ve dokusal olarak hasar vermeye devam ediyor. Şimdi burada ana hani spazmdan başladık. Ağrı ve spazm için
iki farklı grup ilaç kullanıyoruz ama niye bu konuda kafanız hani gidip de fenomenolü nereden buldunuz derseniz aslında prostaglandin yolağı üstünde de etkili olması. Çünkü ağrı mekanizmasını aslında prostaglandin mekanizmasını inhibe ederek sağlıyor. Prostaglandin E2'yi inhibe ediyor ve nosiseptörlerin de bu şekilde uyarılmalarını azaltıyor ve periferik sinir ucunda da bu uyarıyı oldukça düşük seviyeye çekiyor. Ağrı oluşum eşiğini de supraspinal ve spinal seviyede de arttırıyor. Bizim işimiz sizinkinden biraz farklı. Bizim işimiz hasta ile değil, bizim işimiz moleküllerle. Moleküller dediğimiz zaman birçok farklı molekülü aslında özellikle başka bir etkisi var mı, nasıl bir etkisi var şeklinde deneyerek özellikle yaşlı hastalar açısından biliyorsunuz yaşlı hastalarda demin bahsettim protein yıkımı çok yüksek miktarlara vurabiliyor. Dolayısıyla çok ciddi bir böbrek yükünüz var. Siz kronik bir antiinflamatuar, kronik bir antiinflamatuar kullandığınız olarak veya kronik bir ağrı kesici kullandığınız zaman en büyük probleminiz böbreklerde oluşturduğunuz yük oluyor. Dolayısıyla bakıldığı zaman böbrek üstündeki yani böbrek hücrelerinin üstünde de bir toksik etkisi olup olmamasını da bakmak zorundayız. Sağlıklı insan böbrek hücrelerine baktığımız zaman fenomenolün sitotoksik etkisinin çok düşük olduğunu gördük. Diğerlerine oranla aslında böbrek hücrelerini çok daha az hırpalıyor veya çok daha az yaralıyor bir ağrı kesici ve antispazmolitik olarak. Dexametazona benzer olduğunu gözlemleyebiliyoruz. Buradaki en önemli şeylerden bir tanesi bizim dokunun içerisindeki o stokinleri veya mesajları dengede tutuyor olmamız. Çünkü günün sonunda enflamasyon bir cevap ve enflamasyonun temel mantığı da dokunun iyileştirilmesine yönelik olan bir cevap. Doku iyileştikçe enflamasyon azalıyor aslında kademeli olarak ama bu azalım yani bu dokunun iyileşme sürecini hızlandırabilir miyiz veya antiinflamatuarlar bu dokunun iyileşme sürecini geciktiriyor mu kullandığımız zaman sorulardan bir tanesi bu. Birçok antiinflamatuarın ortak olarak yaptığı şeylerden bir tanesi özellikle interleukin 1B ve TNF-alfa'nın aynı anda inhibe edilmesi ve dolayısıyla dokunun tedavisinde geciktirebiliyor. Hastaları da mükemmel olarak %43 derecelendirilmiş, iyi olarak %38 derecelendirilmiş, orta olarak %15 derecelendirilmiş ve zayıf olarak %4 derecelendirilmiş. Dolayısıyla totale baktığınız zaman neredeyse %70-75'ler oranla iyi ve mükemmel kategorisi içerisinde hastalar tarafından da seviliyor. Fenomenol kullanıldığı zaman da memnuniyet yaratıyor. Efendim dinlediğiniz için teşekkür ederim. Tekrar sağ olun, var olun.
Evet, çok teşekkürler hocam. Arkadaşlar soru katkı kısa bir süre için alabiliriz varsa. Şu anda salonda herhangi bir soru katkı göremiyorum. Zaten anladığımız bir konu, hepimizin muhatap olduğu bir konu. Hepimiz bu konuda deneyimlerimizi paylaşabiliriz. Ama bu kadar vaktimiz yok. Hepinize katkılarınız için buraya geldiğiniz için teşekkür ediyorum. Ve şu anda program devam edecek burada ve diğer salonlarda. Ona göre herkes görevli olduğu veya dinlemek istediği yere gitsin ama salonlara gitsin. Başka yere gitmesin lütfen. Bu şeyi de bitirelim. 2 saatimiz kaldı bugünün. Şunun şurasında çarşambaya ne kaldı diyorlar. Onun gibi bir şey yani. Bekliyoruz arkadaşlar. Evet.
At that time, in the colder seasons, everybody has the potential to acquire pneumonia, community-acquired pneumonia. And according to our study, we have recruited the data from the historical records of the Turkish General Staff Headquarters. We have seen that the basic aim of this study was to analyze the natural courses of the infections in the absence of antibiotics. So we have seen that pneumonia has 31% mortality 100 years ago in the absence of antibiotics. So most likely to be the bacteremic form at the ultimate stage, the bacteremic courses. Finally, this is my last slide. In the rational management of bacteremias, First, the microbiological diagnosis is excessively important because no antimicrobial therapeutic modality is reliable in our age. Any time we can see a drug-resistant microorganism that the antibiotic we have provided is not working on. And the second issue is infection control and prevention. This is the basic issue to prevent the dissemination of problematic microorganisms from one patient to other patient. And the third one is the source control. Time to time we have in the management of problematic infections, we have
Very good evening all. So now we are at the session where we'll be discussing about geriatric emergencies. So geriatric emergency and its unique challenges is what we'll be discussing today. As an effect of having a very good advanced WHO's definition, it says when you're more than 65 years, that age is considered as a geriatric age. So we'll be discussing about certain unique aspects of geriatric age. What are their challenges? You'd be wondering what is the importance of a geriatric age group. There's a specialty called as geriatricians are there to take care of it. But when you look at the data of any emergency department across the globe, you can see that nearly 40 to 50% of our patients are from the geriatric age group. Yes, we do get a lot of younger age group, but still, if you look at the data across the globe, not just, I have a couple of data from India, but still, if you look across the globe, we have a very good number of population who falls in the geriatric age group. It's very much depicted in the an aging population has significant implication for healthcare, particularly emergency medicine, because they form a major chunk of emergency department patients. So geriatric patients, on average, a substantial population of ED patients are majorly elderly individuals, which we already told. These patients present a wide range of issues. They need specialized care due to their age-related changes and comorbidities. So like how a pediatric age group requires a special area for care, a geriatric age group also requires a special area of care and special policies, protocols, and their unique challenges has to be addressed. So this is a distribution of clinical symptoms. Pediatric population comes, the parents are very much concerned. The same way the geriatric patient comes inside, their relatives also very much concerned about their father, grandfather, XYZ. So in this age we can see is like there's adequate amount of trauma and also poisoning, some bites and urinary tract infection, and also malignancies and psychiatric illness. All these contribute to us to make think and develop a unique area or unique way of approaching these patients. The geriatric patients pose a unique challenge for healthcare with the following issues. Like one is cognitive impairment. So in most of the patients, because of their cognitive issues, it will be very difficult to take proper medical history. The patient might have come in and unresponse you need to ask, because many times 3 months. Because many times they will come and tell, my father is not moving his leg from today morning. So you'll be asking what happened. I don't know, nothing, everything was fine. Today morning he is not moving. But there might be history of fall which went unnoticed, or the caretaker was not experienced enough to appreciate that. Use of walkers, cane or mobility devices, and currently feeling dizzy or faint, currently on any fall precaution, because he has a high risk of fall. Because many times patients have a small trivial falls which translate into fractures or bedridden, and they come to us. So if any fall precaution is advised, it means that he has already in a risk, patient is a risk for getting injury due to fall. And completion of fall risk education, time up and go test has to be done. Is it a son, wife, or his relative, or his friend, or his attorney who has to make a decision for his clinical management? Another reason for geriatric referral, and that has to be taken into account. So this is how a geriatric patient's workflow has to be established in an ED. The patient arrives, that patient is done triaged by ED nurse, and the ED nurse puts in triage criteria where if it's more than 65 years, emergency severity index 1, 2, 3 or 4, that has to be done. And then the geriatric EM, that 4M assessment is done. And then as per that, the patient is admitted in an area, and current workup and diagnostics are done, specific checkups are done. Disposition is planned. Our patient is given to a particular supporting system, in a public supporting system, who can take care of the patients even if the patient is discharged from the home. Were 3.6%, and nearly 1.3% went against medical advice. So mostly these patients, if you look at them, 78% admission is to ward, so they have minor clinical, and more than 21% they are admitted in intensive care unit. So the falls in elderly, when you look at the risk of falls in elderly, it's more in, it's 1.56 times more in females than males. And the most common cause is faintness, dizziness, and low blood pressure and muscle weakness in legs. So there are intrinsic factors and external factors. If you look at the external factors, slippery fall, tripping, and uneven surface collision and falling in downstairs, the most common is check for any pressure ulcers or bed sores. So this is geriatric syndrome. Geriatric syndrome is where in the geriatric age group multiple issues come in, like pneumonia, diabetes, renal dysfunction, cardiac ischemic cardiac diseases, dementia, depressive disorders. So it's a very complex condition seen in most of the geriatric age group. End of life care. So managing symptoms, patient wishes, spiritual well-being, asking if there is any need for any continuing care. Patient and family has to be counseled adequately. Breaking the bad news is a very important step in ED. If a death happens, emotional support, and legal issues like any DNA, DNR, or who has to make decision, etc. And after that, what has to be done. Geriatric emergency guidelines. So this is how a geriatric emergency system should be set in, and this is based on the GED guidelines by the ASAP. And so this we can take as a model and maybe replicate in many EDs. So most important recommendations is certain societies is do not prescribe a medication without conducting drug regimen review. That's very important because they are on polypharmacy. Do not assume
Good evening all. I would like to thank Team WASM and EPAT for giving me the opportunity to talk on the topic analgesia in elderly. So pain is considered as a sixth vital, and as a result we need to address analgesia. As the overview, we are going to discuss the topic starting with prevalence and types of pain in elderly. So what are the challenges in geriatric pain management? Already Dr. Hanif has explained the challenges in general care of geriatrics. So what specific for pain? pain management principles. Fear of using proper or oligoanalgesia, which is usually happening, is the fear of adverse effects of the analgesics. So it is very important to use the correct analgesics at the right dose, and also be aware of the drug interaction and polypharmacy. So this is a study which comprises of 1,454 patients with hip fractures over the age of 65 years. I put this study to exemplify the fact that even though the pain was severe, the pain score was 7, over the 40% of the patients were not prescribed an analgesic, and there was no objective assessment done. So you can imagine there can be multiple reasons for the same. But the pain as such, increased toxicity of the drugs in gastrointestinal system due to decreased secretions, it leads to impaired dissolution of some drugs, and as a result, there can be decreased effect of drug as such. When we consider the liver or the hepatic system, it can lead to decreased protein binding, and as a result, increased free drug. So increased free drug in turn lead to toxicity. So we need to do the dose adjustment accordingly, whether it be hepatic or renal. When you consider renal, obviously as the age advances, GFR decreases, renal blood flow decreases, and as a result, half-lives also increase, and as a result, toxicity. When you consider musculoskeletal system, you know, as you age, what is the goal of the pain relief you are going to get, and other expectations. So what are the available pain scoring tools with us? So we have a famous visual analog score, which can be used in cognitively intact patients. So it can be from no pain to worst possible pain. Okay. The other is numeric rating scale, which is numbered from 0 to 10, and 0 is no pain and 10 being the worst. And next is verbal descriptor scale, phases scale. And phases scale, you can see in the last row, it's usually used in, not in which is used in dementia and non-communicative patient. Okay. So our aim is not to attain a zero pain. It is a practically a pain decrease or a accepted decrease in pain. And in the background of opioid epidemic and the adverse effects, we need to have some other options also, other than the pharmacological options. So we will aim for a balanced analgesia. So you can see the basic pain pathway, which starts from the peripheral receptors, going with to the spinal cord via myelinated and unmyelinated fibers to the dorsal column, and then to the central pain center. For elderly analgesia, we to start low and go slow. And if on reassessment, if you want to increase, it can be done later. So to start with, the paracetamol, which is a widely accepted across the globe, it is a safe drug to be used even for musculoskeletal pain and other pain also. And it doesn't have any anti-inflammatory action. So you should consider other analgesics for such anti-inflammatory action, and there is no antiplatelet action too. It is considered safe and not associated with any other side effects. So you can have a ceiling dose, weak mu opioid agonist, and serotonin norepinephrine reuptake inhibitors also. So even though it's used, it has to be used carefully, because it can even precipitate seizures and also serotonin syndrome if mixed with some drugs, and always 20% less tramadol than younger adults. So the drug regime is to start with 25 milligram once or twice daily, increase by 25 milligram if increments, and finally a goal of 100 milligram per day. And coming to the morphine, it has a similar efficacy to neuroopioids such as oxycodone. It has a hepatic metabolism where morphine 6-glucuronate and 3-glucuronate and produce the analgesic effect and also the neuroexcitatory effect. Another option, instead of giving analgesic, you can consider regional minimally invasive therapy as we discussed in the WHO LADAP. So nerve blocks like perineural blocks, neuroaxial techniques can also be done instead of giving IV or other route of analgesia. So take home would be, to overcome barriers of effective treatment of pain, we need to proper pain assessment. Pain assessment using pain assessment tools, consider multiple comorbid condition and also the changing physiology or altered physiology as well as polypharmacy. A multimodal analgesic approach with non-opioids and regional techniques should be sought, and always start with lower doses and titrate in case of elderly patients, and also consider non-pharmacological therapy.
A very good evening to everyone who's still here. Thank you so much for being such a good audience. And thanks to the translators who's actually making this possible. Now we'll have our toxicological symposium. I am Siju V. Abraham, and with me I have Linu Shekhar. And this is the disclaimer from my institute. And I'll go directly into it. I want to introduce to you Claude Waveform, and as Dr. Linu was gracious enough to say, I have this tool which came out of necessity for me. Because when we were taking care of snake bites, so I would like to look at TEG, I would like to look at Rotem. We do have Rotem, but Rotem costs maybe 3,000 rupees, which is approximately divided by 3 is what in lira. So if you look at it, it's actually quite expensive for anyone in our part of the world to actually afford. And the people who get bitten by snake is almost always the platelets. You're having the intrinsic, extrinsic TNAs being formed. You have the two-ways gathering and forming the intrinsic TNAs. So it initiates, it amplifies, and then the clot starts propagating. That's essentially what coagulation cascade looks like. But the problem is, to test all this, what you have is your PT and APTT. You have your prothrombin time, you have your activated partial thromboplastin time. Now, it does look at parts of the coagulation cascade, but it doesn't give you a holistic view. What if I were to tell you that even when you're doing it, you can, but using nephrometry or transmittance or absorbance, you start getting, so this is an absorbance waveform. What it tells you is, if you look here, you can see the milliabsorbance, and here you have the time frame. So as time goes, the coagulation, the color of the plasma changes, and you have a coagulation change in the absorbance. And this is the clot waveform, or the fibrin clot waveform. So this is what is telling the machine that there is an APTT. Now what is APTT? The point at which there is a maximum slope, or the coagulation phase and the stabilization phase of the APTT. That's what you're seeing when you're looking at this graph. And these are the extra parameters which were described. One is maximum time, maximum velocity, maximum acceleration, minimum acceleration, and delta absorbance. Let me get rid of all those nuances, terminologies, but I want you to know that this is there in all your APTTs, and you're only looking at this particular value there. Now,
the drawback is even though all your machines are making use of it, only a few of them actually display it as a curve or a graph. I've just listed out a few from an article from Shima et al. So that's a basic of what clot waveform is. Now let me tell you about our work on snakebite. So I started working on snakebite because I had no other option but wait for the coagulopathy to develop. For instance, snake bites, you don't have venom detection kits in most parts of the world, including ours. So we have a polyvalent antivenom, and to give antivenom, we have to look if that particular patient is having some sort of an envenomation change. And this actually shows you that. Now I'll tell you why I'm more excited, because once you give the antivenom, the coagulation, the clot waveform normalizes. I'll give you another example. So this is another case, bite time 8, brought to at test 9, 1 hour's time. That's the initial waveform. If you look closely, there's this part of the waveform is missing, means that it's prothrombotic in the initial phase. It's initially prothrombotic, then becomes coagulopathic. So that's missing, and post antivenom you can see that has corrected. I'll give you another example. Now, what about the other parts of India, where what you see in a Russell's viper bite. So we propose this particular fact as an experimental data that it can probably be a marker for detecting envenomation, species-specific changes. We haven't looked into it in much. We are right now looking at hump-nosed pit vipers and cobras, but soon we'll have a data. So, and for all those who are sitting here who's not interested in toxicology, so I'm going to actually give you potential application for CW in other conditions. See, CW came out in the picture when it was initially described maybe in 2009 by Toe et al. And it bordered on to becoming one of the most sensitive and specific parameters to detect inflammation, species-specific changes. Detection of response to antivenom are things which you can consider. And research potential is still there. Anyone who's here, who's actually got. So I want you to go back, find out if you have CW in your system. It can actually probably cut your cost a bit. Or maybe at least, as an experimental parameter for research purpose. Thank you so much for listening.
Thank you, Dr. Siju, for that wonderful talk. So, do we have any questions? So the next speaker would be Sari Sogan on chemical leaks and toxic effects.
Hi, everybody. My name's Sari, and I want to apologize in advance. I think I have a little bit of a cold, so my voice is awkward. So I'm going to be talking to you about chemical leaks and toxic effects, taking you in a completely different direction, but back to a topic that we started in the toxicology session in Hall B this morning, where we started talking a little bit about some of the toxicologic risks associated with major explosion or release happening in the United States by virtue of combing through media reports, websites, government releases, and so forth. And what they realized was that there is a chemical incident happening in the United States alone pretty much every other day. And that number is increasing. Now, there isn't data sufficient to understand what this looks like on a worldwide basis. That has not yet been compiled. And to understand the reasons why this might be increasing is completely speculative. But the WHO has been turning our attention for some time. This was a report, a book that was published in 2018. looking at the problem of what are called NATEC events, or chemical releases and chemical disaster yield toxidrome to get prepared on. It would be this irritant gas toxidrome. And these are a group of chemicals much larger than the ones we saw in that initial list and much larger than the examples I'm going to go through right now, but that all basically dissolve in the water within our mucous membranes and respiratory tract to form caustics and create direct tissue injury as a result. So you see here, I've made a little scale of more soluble to less soluble, and that's important in terms of thinking about how we might experience these toxic effects and in what time frame. So number one on that list, the most common chemical involved in these big disasters or releases is ammonia. And most of us might have a frame of reference for pneumonia, upper limit of, or upper threshold for toxicity. According to, I've never smelled it myself, but according to these World War I posters where it was used as actually as a chemical warfare agent, it smells like fresh mown hay or like grass, something sweet, and not something that one would immediately want to run from. Again, increasing the risk that one could get a fairly decent dose before removing oneself from the gas. I don't know how many of you clued into what was happening during Fashion Week in Paris this year. There was a huge bed bug infestation in Paris that apparently is ongoing. So our approach to management really today doesn't differ all that much from what it was or what was elaborated in the First World War as a result of many medics having to deal with high volumes of soldiers being exposed to chemical warfare agents. And back then, the standard of care was to follow the same principles that we use today, which is decontamination, decontamination, and then supportive care. So back then, decontamination looked a lot like using gauze soaked with water or saline to keep the eyes moist, and to have people gargle every 3 hours per this kernel. Upper airway swelling and edema, I think I probably would recommend steroids, but their role to prophylax and to prevent the development of long-term sequelae, pulmonary fibrosis and so forth, after a significant irritant assault is much more controversial. And in most review articles that have examined what evidence we do have, mostly from single case reports and case series, as well as animal studies, there hasn't consistently been, no benefit has consistently been found. I know in toxicology we love to talk about antidotes. They're certainly the most fun aspects of therapy. In this case, there are not too many that would be helpful, with one exception, maybe with hydrogen sulfide, which again, as I said, acts a little in other chemical entities, and certainly not been well studied in many human models, but we do have some small evidence in chlorine that it may shorten the duration of symptoms and help people feel better faster. So I want to just end with a brief remark on the long-term effects of these chemical exposures and this kind of subacute management. I haven't focused too much on the history of major incidents, but I feel it would be remiss not to talk about Bhopal, which is both the largest chemical disaster that we've experienced in
protection measures in the community level.
Okay, so I'm going to talk about what we can do to protect our communities from these kinds of disasters. Brief slide about my background. I'm also a toxicologist who works in New York City. I work in Brooklyn, and I have no conflicts of interest to disclose. So I'm going to go over some background about preparation for chemical releases, talk about how we can identify some of the potential threats, whether they're industrial, whether they're used for malicious purposes, and then how we can prepare, what equipment we might need, how we can prepare about decontamination, how we can get information when we do identify a toxin, and then how we can address the availability of antidotes. So there are a number. This is from the sarin attack on the Tokyo subway, so this is an example of an actual chemical weapon that was used. And another example of state-level chemical warfare, this is in Syria, and you can see that in the explosion here, the gas release, that green color indicated the presence of chlorine gas. So these are all different potential ways that people could become exposed to a chemical in large numbers. And to just highlight the difference between a chemical attack compared to a biological and a radiological attack, the biggest difference is the time frame, right? People who are exposed to chemicals typically, for most chemicals, and obviously there are exceptions for things like phosgene, but most things tend to have fairly rapid effects, and you need to recognize that, and that's really important in terms of personal protective equipment and decontamination that take a much higher priority compared to biological attacks and radiological attacks, because it's very easy. You can see for every really critically injured person, there's a ton of worried well, and we have to think about preparing for what to do with those people when they present to your hospital, and specifically allocating specific space for those people, and have a plan for that. And also to control access to your hospital so you don't have people who have not been decontaminated coming and contaminating the clinical area that you're going to need to take care of these patients. And that kind of tip of the iceberg idea is really just an expression of the dose response curve, right? And that comes from Paracelsus, who said, what is there that is not a poison? All things are poison and nothing is without poison. It is only the dose that makes a thing not a poison. So people who are exposed to a lot are going to be critically ill, but there's going to be a lot more people who are You have appropriate PPE for your first responders and for your staff in the hospital. Having appropriate equipment to be able to decontaminate people at the scene. Ideally, you don't want to transport contaminated patients in your ambulance because it's going to contaminate the ambulance and take it out of circulation, right? So you ideally want to transport people after they've been decontaminated at the scene. But at the same time, if you're working at the hospital and receiving these patients, you cannot assume that that has been done appropriately. So you have to treat every patient as they are potentially contaminated. And that's really going to mean controlling access at your hospital and making sure that patients are decontaminated before they're brought in. This is an example of our decontamination facilities at one of my hospitals at SUNY Dental. And I can type in acetone and MSDS. Remember, MSDS is Material Safety Data Sheet. And I'll get a bunch of different sources for material safety data sheets. Now, these were originally developed for industrial purposes. So in the US, any chemical that's potentially hazardous that's being used in the workplace, they have to have the MSDS for that chemical on site. But now these are all online, and you can look them up for basically anything. And they're not just for chemical names, but also brand names of products will have the MSDS associated with them. And it has a ton of information, physical properties, what potential hazards that they pose, what to do for first aid, what to do for firefighters if there's combustion of these agents. So a ton of information with a quick Google search that's available. This is a 10-sheet document just for acetone as an example. This is an example of the hazmat symbols that are used when a chemical is being transported in the U.S. And so we can use these symbols to identify what potential threats, if there's a spill, if there's a train that derails, or if there's a collision of another type of vehicle that's carrying chemicals. And the WISER app, which is soon to be replaced by the ERDSS app, is really useful. It's something that you can download for free. It allows you to browse if you know what substance is involved, but if you don't know what substance, you can use the codes and it'll help you identify what the substance might be or what class of substances might be involved. The next thing I want to address is antidotes. And again, most of the things, as Dr. Sari mentioned, is really in terms of strategic national stockpiles. In the U.S., we have what's called push packages of antidote and equipment, about 50 tons of material in each of these push packets, and it's enough to fill the belly of a wide-body cargo jet. This is a picture, and you can see there are a number of carts, and they're designed to fit exactly into the space in the cargo jet. And you can get a large amount of material to where it's needed within a few hours, and they're at strategic locations around the United States for when they're needed. This was first created in 1999 by President Clinton at that time in response to a number of chemical events at that time, the first World Trade Center bombing, the sarin attack on the Tokyo subway, and the Oklahoma City bombing. And initially it was just for CBRNE threats, but now
Thank you, Sage, for this comprehensive overview of prevention and protection measures in the community level. Now, we have Dr. Linu Shekhar talking about the prevention and protection measure on a personal level. This will be the last talk for the session. And the last speaker, which was given as Ashish Bhalla, has already taken a session in the toxicology session earlier. So, Linu Shekhar, prevention and protection measures, personal protection. So, the question is to Dr. Sage. With regards to, so we decided to actually have an antidote bank in our place. Now, our biggest problem was the expiry date on these and the cost of maintaining it. So, for us, a cost, say, underdeveloped nation, do you have any suggestion as to how we can actually start one on a smaller scale with regards to what should be stored? Say for the Cyanokit, it's 5 lakhs.
The pandemic which we had just encountered, which has taught all of us how to do a proper donning and doffing of a personal protective equipment. So I don't have any financial interest to disclose. So disaster is considered as a hazard when it is more of a natural cause, something's beyond something called as force majeure. It's beyond the control of the humans, and it is considered to be a threat when it has got a more of a man-made character, like active bioterrorism or such things. Be it hazard or be it threat, we need to for transporting hazardous materials and poisonous agents. promoting compliance with safety codes and regulations and status. Many countries of which would have, many of the developing countries don't have the same. And there should be a plan so that hazardous chemicals are manufactured far from civilian areas. So those are few things which can probably mitigate or prevent future events. Increasing public and community awareness and support for the prevention. Because in most disasters and most hazmats, everybody is caught in the COVID. At that time, how he goes and handles a COVID positive patient. So there, the steps have been shown here. So I'm not reading out all these things because it is different in each case. In here, if you see, after completely donning the PPE, he has to put on a lead apron also. So it depends upon what agent you are dealing with. The steps might have a different. But you have to be knowledgeable. That is the take-home point. Unless you are knowledgeable, there is no use having any fancy PPE with you. And this is again a picture of another, I took it from some other place here, whether how you properly doff the PPE. There will be different steps, and it usually starts with the part covering the head and it ends with the part covering the legs. It is, if the doffing is also not done properly, it can also do more harm than your intended protection. You might be protected, but the PPE would be helping to disseminate. It protects splash protection as the same level as B, but a lower level of respiratory protection than classes A and B. Majority of the hospitals expect that their EMTs or the first responder team to have level C protection training. But that may not be the case in case of a toxic disaster. So these three are the actual levels, and there is a level D which is written theoretically, but it is not used because it is nothing more than a routine uniform or the scrubs which we use in our routine departments. It provides no respiratory protection and only minimal skin protection. And then why is there a level D? So this level D is that this should not be worn in case of toxic disasters. That's why it has been designed for decontamination of these patients. And so these PPEs are donned appropriately in accordance to the area as well as the toxin in question. So this is just a summarizing of the what level of protection is given by each type of PPE, and obviously the level A PPEs would be the best, which gives comprehensive protection against vapors, aerosols for the eyes, skin and the respiratory tract. So with that, I end my talk here. If there are any questions regarding personal protection or donning or doffing techniques, I'm happy to take it.
Are there any questions from the audience? I'm pretty sure by the end of COVID kind of helped us understand what donning and doffing meant. You know, it brought that to everyone. So this was the last speaker for the night, and hope you all have a good night. See you all tomorrow. And hope you all have a good night. See you all tomorrow. Good night. Thank you.
You know it's serious, we're getting closer, this isn't over. The pressure's on, you feel it, but you got it all, believe it. When you fold it up, oh, and if you fold it up, eh, tamina, mina, sangalewa, 'cause this is Africa. Tamina, mina, eh, waka, waka, eh, tamina, mina, sangalewa, this time for Africa.
I would like to invite Dr. Roger Dickerson, President of the Emergency Medicine Society of South Africa.
Listen to yoga, this is our hour. Your time to shine, don't wait in line, y vamos por todo.
Merhaba Türkiye. Professor Dr. Bashar Kandar, Professor Dr. Zeynep Turkish, Videonyanyan, her yerinden arkadaşlar ve meslektaşlar. Afrika'nın güney ucundan size sıcak selamlar getiriyorum. Bir kez daha distinguished international speakers that always join us here in Antalya, and to learn from the students who arrive, to listen, because it's their questions that drive our learning. I come from Cape Town in South Africa, which is really at the southern tip of the African continent, so on the other end of the continent from here. And though we live in very different countries, the problems in emergency medicine are the same wherever you are. And so on behalf of the Emergency Medicine Society of South Africa, it is my absolute pleasure not only to be here to share this conference with you, but also to bring our regards from the southern tip and look forward to working together into the future. I've no doubt that this conference will
a mujeres no me falta ni el dinero ni el amor. Jineteando en mi caballo por la sierra yo me voy. Las estrellas y la luna ellas me dicen dónde voy. Ay, ay, ay, ay, ay, ay, mi amor. Ay, mi morena de mi corazón. Me gusta tocar guitarra, me gusta cantar el son. Mariachi me acompaña cuando canto mi canción. Me gusta tomar pisco.
I would like to invite Professor Carlos Garcia Rosas, first president and founder of the Mexican Society of Emergency Medicine and Mexican Academy of Emergency Medicine.
Good afternoon. Thank you very much for inviting me to be here. Bashar, it's a pleasure. Emra, all team of the Society of Turkish, thank you for inviting me to be here. First of all, I want to say that we live in the last 3 years difficult times. We never know that the pandemic will be attacked in that way like we suffer around the world. They show us what important is different places around the world. And thank you, and I hope this conference will be great like the other ones. Thank you, and I see you the next days.
Thank you, Carlos Garcia Rosas, for your opening remarks.
walk the walk on every street. I wanna ball out with the world at my feet. Hit every discotheque and ask it for me, yeah. I wanna party 8 days a week. I promise you now. Everything gonna work out. Every tomorrow, no matter what go down. I promise you now. Gonna be sticking around. Every tomorrow, no matter what go down.
Now, I would like to invite Dr. Ayman Elmanyar, Director of Clinical Research and Development in Trauma and Vascular Department, Hamad General Hospital, Qatar.
Good evening. Assalamu alaikum wa rahmatullah. I would like to thank Dr. Bashar and the organizing committee for inviting me to attend such a great congress and to maintain a strong academic and scientific relationship with Hamad General Hospital in Qatar. And I hope that this Congress will be very successful, especially we are back in-person meeting. I came from Egypt.
Sono un italiano. Buongiorno Italia, gli spaghetti al dente e un partigiano come presidente, con l'autoradio sempre nella mano destra, un canarino sopra la finestra. Buongiorno Italia con i tuoi artisti, con troppa America sui manifesti, con le canzoni, con amore, con il cuore, con più donne, sempre meno suore.
Salvatore Di Somma, President Great Network Italy. Dr. Salvatore couldn't join us for an important reason. Now, I would like to invite Professor Paul Kivala, President of the ASA.
It hires an American football coach to basically take over the program. And so I heard that Dr. Kandera was a big football fan. And in the United States, our football, we have American football. And we call football over here soccer. So in that, I'd like to have Dr. Kandera come up here for me for just a second. So what I've learned is that, you know, to have a very strong team, you really need a leader that's calling the shots. And so I just flew through Los Angeles, and Los Angeles is the home of the World Championship in American football. So what I know it's football, it's a little different football, but
like to invite Josep Brugada, who is named by the Spanish cardiologist with Pedro Brugada and Josep Brugada, who reported is as distant. The clinical syndrome is 1992.
Thank you very much. It's a real pleasure finally to be able to come to your meeting. You know that we have been trying that in the last 3 or 4 years, but the pandemics made it completely impossible. So finally, I'm extremely happy to be here with you and to share with you all the knowledge that you have and that I might transmit to you also, and all the speakers and presenters in this meeting. So I really hope that the meeting will be an incredible success. The venue is fantastic. My first time in this part of Turkey, and it's absolutely magnificent. And I'm really sure that the days that we'll be here together will be great days for all of us to learn and to
We continue our opening ceremony with important news. A World Congress will be held in Turkey in 2023, the centennial of our republic.
Good evening, everybody. Am I audible?
Asia, from Africa, from Europe. And this year, every year we have from 5 continent speaker, but this year we have from 6 continent speaker. Now we have speaker from Australia too, and I want to thank to this speaker. Welcome, hoş geldiniz. Avustralya'dan aramıza geldiler arkadaşlar. Bir Avustralya kalmıştı katılmayan. Bütün kıtaları biz aslında organize ettik. Avustralya kendisi katıldı bizim aramıza. Çok teşekkür ediyoruz. O yüzden aslında çok zor yollardan yürüyoruz, biliyorsunuz. Yürünemez denen yollar yürüdük. Aşılamaz denen engeller aşıyoruz. Zirvelere tırmanıyoruz. Ve bu konuda sizden aldığımız güçle acil tıbbı daha ileriye götürmek için sürekli çaba sarf etmeye devam ediyoruz. Açılış törenini çok uzatmamak adına bu yıl yaptığımız aktivasyonların birçoğunu anlatmayacağım. Çünkü biz pandemiden önce yılda yaklaşık 400 aktivasyona ulaşmıştık. Bir gün gelmiş 3 ayrı ülkede 6 aktivasyon yapan bir dernek değil, büyük bir devasa güç haline gelmiştik. Tabii siz eğer zirveye çıkarsanız Zirvede olanların karşılaştığı iki şey vardır. Bir, yalnızlık. İki, onu zirveden düşürmeye çalışan insanlar. Ve dolayısıyla biz karşılaştığımız sorunları acil tıpta zirvede olduğumuza yoruyoruz. Buradaki tabloda aslında zirvede olduğumuzun bir göstergesidir değerli arkadaşlar. Birçok teşekkür alıyoruz aslında. Değişik ülkelerden, birçok konuşmacıdan bunları göstereceğim bir kısmını. Ama burada Mehmet Gül hocamızın yaptığı teşekkür hiçbir zaman unutamayacağım bir teşekkür. Türk bayrağı altında yaptıklarıyla onurlu bir şekilde dimdik bize bu şekilde katkı sunuyorlar. Bize değer veriyorlar arkadaşlar. Kongre sabahları biraz zor oluyor. Bunlar da umarım ki sesi geliyordur.
Kaldırıyorum efendim. Hani bakıyorum güneşe, evet diyorum, doğdu güneşim. Tık elimi yüzümü yıkıyorum. Güzel bir şarkı, güzel bir banyo. Üstümü başımı giyiniyorum. Sağlam bir kahvaltı. Modumu yakalıyorum tabii. Yani bu gidişat çok kötü gidişat efendim. Türkiye'nin ekonomisi nanay.
Neyse buradaki bu gidişat iyi değil diyorlar. Evet, gerçekten sıkıntılı bir gidişat var dünyada. Biliyorsunuz pandemiyi atlattık. Üzerine şimdi savaş, her dakika bir yeni sorun, ekonomik kriz derken bütün bunlarla birlikte mücadele etmek zorunda kaldığımızı değilim ama acil hissetmek istiyorum diye bir alan mı oluştursak diye. Tabii bu sadece aslında acilcilerin sorunu değil. Mesela genel cerrah, dahiliye, burada da aile hekimleri. Gerçekten herkesin böyle hasta yoğunluğundan ciddi sorunlar yaşadığımızı ve Türkiye'de, diğer ülkeleri bilmiyorum, ülkemizde çok ciddi boyutta hasta yoğunluğu olduğunu, acilde çok fazla hasta olduğunu bildirmemiz uygun olur. Biz kongreleri çok güçlü yapan bir derneğiz. Biz sadece bir dernek değiliz. Aslında hayatın her yanında bunu göstereceğim. Çok çalışması olan bir ekibiz. Birlikte çalışıyoruz. Bir sürü kongre, fantastik, değişik kongreler. Tabii bunlar haberlerde de yer alıyor. Başka en son ya bizim iddiamız bu. Daniel Lopez Tapia'nın. Bunu biz söylemiyoruz tabii. Bunu söyletmek kolay değil. Tekrar geri alayım. Dünyanın en büyük, en geniş konferansı olmaya aday bir konferans olarak hep birlikte ilerliyoruz arkadaşlar. Bu bizim için bir gurur tablosu. Acil tıp için bir gurur tablosu. Ülkemiz tıbbı için bir gurur tablosu. Bunu da görüyorsun işte her yerden ciddi bir teveccüh var. Ve bunlar böyle devam ediyor. Tabii biz dernek olarak çok iş yapıyoruz. Bakın bu yine Facebook'tan aldığımız bir şey. Birileri soruyor. Biliyorsunuz böyle soran adamlar olur. Sevgili babalar, bu uzmanlık dernekleri ne işe yarar diye. Hangi branşın ne derdine çare bulmuş bilen var mı? Biz hiç müdahil değiliz toplantıya bak. Burada bir arkadaş çıkıyor. Onur Sayakar ya. Hiç acilci falan da değil bu. Atüder işlerinde en aktif çalışanları sanırım. İşte bizim bütün camialar içinde örnek bir yapı haline gelmemizin tabi bazen bedeli oluyor ve bunları da beraberce göğüslüyoruz, beraberce üstesinden geliyoruz arkadaşlar. Amerika'dayken bir ara şeye gittim, bir arkadaşla birlikte Virginia'daydım. Bir 80 kilometre uzakta bir şehre gittim bir Türk'le görüşmek için. O da şaşırdı, dedi yani siz Türkler olunca birbirinizi görmeniz mi gerekiyor? Evet, biz Türkler birbirimizi görmemiz gerekiyor. Biz birbirimize düşkün bir milletiz. Bunu şunun için anlatacağım arkadaşlar. Çok kısa bir not bu. Şimdi biliyorsunuz YUSEM'le ilgili bazı şeyler anlattılar, durdular falan. YUSEM'le ilgili kısa bir öykümüz var. O da şu. YUSEM'de öncelikle böyle kongrelerden sonra bizi başkan adayı göstermek istediler. İstedik, o zaman başkan adayı olacaktık, olduk. Ve biz seçimi o zaman kaybettik ama detayına girmiyorum. O zamana kadar başkan 100 oyla seçiliyordu. Biz çok daha fazla aslında durum var. Birdenbire başkan 300 oyla seçildi. Onu geçtik arkadaşlar. Herkese hiç değinmeye gerek yok. Ama sonra bir genç doktorlar seçimi oldu. Genç doktorlar seçimi olunca da biz onların hani 20 yılda yaptığı üye sayısına 1 yılda ulaşmıştık. O zaman Türk adaylar çıkmış. Bizim de tanıdığımız değil, derneğimize de üye değiller. Tabii Türkler milli duygularla bunları desteklemişler. Bir bakıyorsun genç seçim, başkan yardımcısı Türklerden seçiliyor. Bizim konuyla müdahalemiz yok ama biz zaten bu konuda böyle bir gücüz yani. Biz nereye gidersek orayı güçlendiririz, oraya destek veririz. O yüzden bazı sorunlar önümüze koymuş gibi olabilirler ama biz o zaten hani acil tıbbın farklı bir kategorisindeyiz. Biliyorsunuz orada genelde pratisyen arkadaşlar burada da vardır yönetici konumunda. O yüzden biz o konuya fazla girmiyoruz ama detayını öğrenmek isteyen, merak etmek isteyen 4 gün buradayım. Bana sorabilir arkadaşlar. Biz çok kurs yapıyoruz. Bakın yoğun bakım kursu, ileri kardiyak yaşam desteği kursu, sempozyumlar yapıyoruz ve uluslararası birçok gördüğünüz hepsi başka ülkelerde Ukrayna'dan Suudi Arabistan'a, Ürdün'den, Katar'dan vesaire her yerde yaptığımız Makedonya, Kazakistan, Hindistan, biz uluslararası herkes sormaya başladı. Ya bu Türkiye'de ATÜDER nedir? Konumu nedir? Başka uzmanlık derneği yok mu? Hep ATÜDER duyuyoruz. Bu konuda çok iyi çalışmalar yaptığımızı. İşte görüyoruz mesela Mehmet Cihan Hoca'yla, diğer şeyle Fatih Altaylı'yla vesaire sürekli bir şeyler yaptık. Tabii en sonunda böyle bir şey yakalamış arkadaşlar. Altını hep gösteriyoruz. Başkan olursa seslendi diye. Arkadaşlar da nasıl yakalamışlarsa. Evet görüyorsunuz yurt dışı temaslarımız. Bakın Katar'dan Elman var. Elman, you know. Evet bu Ürdün'den aldığımız plaketler. Suudi Arabistan'dan, yine Katar'dan görüntüler vesaire. Özellikle yabancı konuklarımız da buradayken 4000 sayfa 400 bölümden oluşan devasa bir külliyatımız dünyada en kapsamlı textbook olarak göründüğünü söyleyebilirim. Her dernek bir dergi çıkartırken arkadaşlar biz 4 dergi çıkardığımızı her seferinde söylüyoruz. Onunla da yetinmiyoruz. Kısa filmler çektik biliyorsunuz. Burada da bakıyoruz artist olacak arkadaşlara da bakıyoruz.
CPR yaptık.
Görüyorsunuz Gizem Karaca ile birlikte
yaptık.
Emre Kızılırmak ve ben vardım bu filmde. Bunun geniş versiyonunu izlemenizi tavsiye ederiz. Tabii sağlıkta şiddet hiç çözülmüyor, bitmiyor.
Ben onlarla
biz elimizden gelen bütün çabayı yapıyoruz. Filmler çeviriyoruz, kamu spotu. Aslında biz tedaviyi biliyoruz da.
Simsiz kahramanları onlar.
İşte onu uygulamak önemli. Onu uygulayacak.
Beni siz hayata bağladınız. Kendim ve sevdiklerim adına hepinize minnettarım. Ben şanslıydım. Ama sizin anneniz, babanız, eşiniz, çoluğunuz, çocuğunuz, akrabanız, arkadaşınız bu kadar şanslı olmayabilir. Ne olursunuz unutmayın. Size rağmen olmaz. Ama sizinle iyi olur.
Evet, Türkiye bu filmi konuşuyor 80 milyon diye. Haber de yaptırdık ne olur ne olmaz diye. Şimdi gelelim bu kongremize. Arkadaşlar şimdi ben kongreyi çok anlatmak istiyorum ama vakit. Ya bizim kongrelerimiz dolu dolu. Her santimetre karede neredeyse bir aktivasyon var. Çok sıra dışı işler yapıyoruz. Çünkü çok güçlü bir ekibiz. Evet burada bir futbol turnuvamız olacak. Karaoke olacak. Sonra tabu oynama ilk defa yapıyoruz. Uçurtma bunları da yapacağız. Acil tıpçıların aynı zamanda bir sosyal bir aktivasyon yapması için şeylerimiz var, çabalarımız var. Tabi biliyorsunuz 99. yılı 100. yıla bağlayan geceyi burada birlikte kutlayacağız. 100. yıla burada birlikte gireceğiz. Gala gecesinde. O yüzden kırmızı, beyaz giyineceğiz gala gecemizde. Tabii böyle bir performans istiyoruz. Olacak. Cumartesi sabah yürüyeceğiz ama niye yürüyeceğiz? Hep yürümekten bahsettik. Burada çok güzel bir sosyal sorumluluk projesi var. Ve bu sosyal sorumluluk projesinde bir aplikasyon var. Yanlış düzelttim. Bu aplikasyonu indiriyoruz. Adımlarımız sayılıyor ve bu adımlar kadar köy çocuklarına bağışlar yapılıyor. İyi anlatabildim mi? Tamam, gayet güzel. Ve bunu hepimiz biliyoruz. Asla yalnız yürümeyeceksiniz. Biz bu kadar işi nasıl yapıyoruz? Çünkü biz asla yalnız yürümüyoruz. Benim yanımda benimle birlikte mücadele eden, dimdik benimle birlikte duran arkadaşlarla devasa bir organizasyon yapıyoruz. Sadece kongre, sempozyum yapmıyoruz. Türkiye'nin geleceğine, dünyanın geleceğine faydalı olacak işler oluşturmaya çalışıyoruz. Tabii burada benim yanımda dimdik duran arkadaşlarım temsilen çağırıyorum. Önce bronz, yani üçüncülük, ricordati Ufuk Bey buradaysa rica ediyorum. Hızlı adımlarla Ufuk Bey. Ben tekrar ortaya kadar yürümek istemediğim için buralarda vermeye çalıştım, yutmadılar. Evet, ikinci, yine bu büyük projede de yanımızda olan Celtis firması adına Nurdan Hanım'ı buraya davet ediyorum. Buyurun. Ve sen olarak altın sponsorluk ödülü. Gerçekten her zaman yanımızda büyük bir güçle durdular. Bütün ekibe teşekkür ediyorum. Menarini Grup, onun adına Aslı Hanım'ı buraya davet ediyorum. Evet arkadaşlar, şimdi günün en anlamlı anına geleceğiz ama ondan önce biz bu altın acil ödüllerini 7 yıldır veriyoruz ve çok değerli, şu ana kadar gerçekten çok değerli bilim insanlarına bu ödülleri verdik. Bakın, bu Gazi Yaşargil 2015'te ilk ödülü alan, şu anda da Milenyumun 100 yılın cerrahı, 100 yılın cerrahı, beyin cerrahisinde Türkiye'mizin gururu. Sonra Aziz Sancar'a verdik. Nobel'den sonra biz ona ödül verdik. Bakın neredeyiz yani, Nobel ödülü alıyor, sonra gelip bizden ödül alıyor. Ve ikinci defa altın madalyayı Aziz Sancar'a verdik. Üçüncü ödülü yine Amerika'ya gitti. Goldfrank, biliyorsunuz toksikolojinin babası kabul ediliyor. Dolayısıyla Goldfrank'ı getirdik. Ona da bu ödülü takdim etmiş olduk. Ve sonra Paul Kivera aramızdan çok büyük onur duyduk. Ve bu ödülü kendisine takdim etmek bizim için hayatımızda onur duyacağımız, gurur duyacağımız bir an olacak. Bunu da mümkünse Zeynep Hocam'la birlikte verelim. Zeynep Hocam buraya gelin ve Joseph Burgada'yı buraya davet ediyorum ayakta alkışlarla.
To share with you my conflict of interest, since I am a part of this startup organization, innovations and technology in emergency medicine. That is the only problem that I have as conflict. Now, in my 15 minutes talk, I will try to demonstrate that technology and telemedicine will be of great utility in the future fighting with the acute disease. And in fact, from this paper from New England, in July 2020 was very clear that from the COVID situation, pandemia, was really important to have this technology in order to monitor patients at home, but also at the end of the day, after this initial terrible pandemia, we got an opportunity, right? And in this paper is very clear how we can really see the possibility to also apply in the future with this technology, telemedicine, also in other diseases, especially acute disease. This is what we did in our institution, La Sapienza University in Rome, try to take people out of the emergency room, right? Because during the pandemic, I remember very well that many patients, they immediately came to the emergency room, but not all of them were really very serious to be admitted. So what we decided to organize this telemedicine concept with the patients that was selected by doctor based on some criteria of score of severity. And then there was a nurses station that was able 24 hours a day, 7 days a week to monitoring the patients with this smartphone. And this data were sent to a platform that the nurses was looking, and based on this criteria of news alarms, if the data were green or yellow or red, some decision was be made. And this would be very fruitful in order to reduce inappropriate hospitalization in the emergency room, and also on the contrary, to admit the patients before they become very severe and need for ICU. But let's see now, how can we really try to implement in our daily practice in the emergency room utilization of telemedicine? You remember very well that during the pandemic, many patients with other acute disease such as stroke or myocardial infarction or acute heart failure, they died at home because they were a little bit concerned to come in the hospital. But at the end of the day, we have to see now which are the consequences of the increase of many acute disease coming and expecting in the future in the emergency room. Therefore, cardiovascular acute disease, both because of neglect during the pandemic and also because of the consequence of the COVID, we will have in next decades a lot of acute cardiovascular disease as a tail of the COVID that will come to the emergency room. So my question today is, should we apply telemedicine in fighting with this tsunami of patients coming in the emergency room with acute cardiovascular disease? You see from this paper from Nature Medicine just published a couple of months ago that heart failure patients will be really increased number need for admission in emergency room, because even in patients that the COVID without severe lung disease, there is an expecting of an increased heart failure patients, because as you know, COVID-19 is not a lung disease, it's a vasculature disease. So I think at the end of the day, let's sit together, fighting with the most important reason to be admitted in the war, acute heart failure. How can we use telemedicine? I think this is just an example that definitely we can cooperate in the future in the network to see how can we really apply the experience of telemedicine in COVID, in acute disease in the emergency room. You know very well from this paper that we published as position paper of Association of Acute Cardiovascular Care, European Society of Cardiology, that first of all, we should distinguish between shortness of breath and when acute heart failure is suspected, we should definitely immediately approach in the emergency room by diuretics, oxygen, or nitrates, depending on what is the phenotype of the patient. I just want to remark that the job you do in the emergency room with acute cardiovascular disease always the most important one. I just want to take the opportunity to share with you this fantastic paper just published that in the emergency room with acute heart failure, we can have a best opportunity to immediately treat better the patients using not only furosemide, but adding acetazolamide, 500 milligram once daily IV is going to reduce the need for furosemide increase. Now, let's see how can we use telemedicine in try to reduce the burden of overcrowding in emergency room with the patients with acute cardiovascular disease, and especially with acute heart failure. In this position paper we published recently, it is very clear that what is important to immediately make a disposition, right? For acute heart failure patients, if the patient has cardiogenic shock, or has acute pulmonary edema, or is right ventricular failure, definitely you should admit to ICU. But you cannot admit all the patients. And now what is really important to see the possibility that you can send a tow or nurses home patients from the emergency room. And this is coming the importance of telemedicine. In fact, this is the criteria that we pointed out in the European Society of Cardiology guidelines to see if there is this concept of patients after staying in the emergency room, you don't need to admit if the patient has a heart rate below 100, systolic blood pressure greater than 100 milligram millimeter mercury. But most important, if it is adequate diuresis, no signs of a congestion, you can send it to more patients. And here comes the application in daily practice for telemedicine. But first of all, I think that this paper from the Great Network we published is very important to immediately in the emergency room adequately use ultrasound lung to evaluate the B-line and congestion. So all the patients that after treatment in the emergency room for acute heart failure should be decongested, you can really send it, because these patients should be monitored in order to reduce the hospitalization. And this is the issue. Could we use telemedicine to send these patients at home from the emergency room and then check how is the status? I understand that this is really one case, but I was trying to make a scenario that is really something that we are expecting in the future. A number of patients with acute heart failure, how can we manage with telemedicine? And this is the project. You see again, nursing station, patients are selected based on criteria of score, and they receive at home a weighting system with bioimpedance, blood pressure, glucose testing, saturimetry for oxygen consumption, and then every day the patient is sending once a day at the nursing station the data, and the nurse is in contact with the physician in the emergency room. So the patients that are sent by the emergency room can be connected by the emergency room in order to see, I have to come back, I can stay at home. And this is what we did already in our preliminary 200 patients in Rome, where you can see having this monitoring, you can have a lot of information to decide, especially if there is no, and even in the future, why not? Like they prepared recently in the UK to send at home even nurses and doctors to take patients at home, especially for let's say final situation and pay. So the final goal of telemedicine is putting people together, working in the interest of the patients and reducing the inappropriate burden in the hospital to move the health system from the hospital to the community when possible. And this will optimize the job of emergency physician that will only work with the severe patients and also for the hospital per se. Now, within the WASM, we really were able to point out in this paper after the COVID that you see many people from the WASM group that I'm honored to be part of, to show which are really the need for improving telemedicine program for emergency medicine. And at the end of the day, these are the most four important pillars that we have to realize in the future: patient safety and confidentiality, matrix analytics and reform, and this is also kind of institutional need, recording audiovisual data, and health record is very important to have the possibility that these data are going with the patient, with also electronic data, and also at the end of the day, lastly, the cost. And also at the end of the day, lastly, the cost and the possibility to make this kind of activity reimbursed. At the end of the day, this is the last issue that just come out today, New England Journal of Medicine. There are also a lot of ethics issues that we should solve. First of all, the possibility of privacy, right? We should make sure that these data are utilized properly by the patients, and also we should really make possible, as much as possible, the future of improving telemedicine in conjunction with the patient's need. At the end of the day, I was trying to demonstrate that thanks to telemedicine, we can definitely manage acute disease outside the hospital, making a good connections from the emergency room, from the hospital, with the community. And I was
Thank you very much, Salvatore, and please accept our condolences for you. This is in this time, and you can join us. It's very big honor for us. Thank you very much, Salvatore, and in next time we waiting you face to face, I hope, inshallah. Yes.
Thank you. Salvatore will have a discussion at the end all together with the three presentations. So now let me introduce Ariel Kibela, that will talk about the lessons learned from the pandemic.
Can you hear me? Okay, perfect. Thank you, Dr. Kandar and Dr. Brigada. It's really an honor to be introduced by two of the most influential cardiologists and emergency physicians in the world, and it's a bit intimidating as well. Nevertheless, thank you for having me, and thank you for joining me today. I graduated in May from Pitzer College in Los Angeles, California, studying international politics and East Asian studies. I wrote my thesis comparing East Asian COVID response model to the United States. So that's what I'm going to be talking with y'all today. Oops. So while world leaders have called the coronavirus pandemic a once-in-a-century crisis, there is no reason to expect that to be true with climate change in an increasingly interconnected world. The only thing that is certain is that once this virus is vanished, another will take its place. Pandemics are inevitable. However, the systematic policy failures that accompany the spread of a virus are not. So if you look at this map, you can see that mortality rates due to COVID-19 have varied substantially across the world. In particular, there's a striking contrast between the Asia-Pacific region versus the United States. In particular, the East Asian tigers, which are Singapore, Hong Kong, Taiwan, and the Republic of Korea, have received universal praise for their ability to effectively respond to the pandemic. Given their policy when market failure occurs. Also, they are not able to override politics in a time of crisis. So the East Asian tigers had a top-to-bottom approach. They started at institutions, and their institutions were made up of skilled technocrats and very educated elites. So these people made all the policies. Next, the institutions really partnered with had a public-private partnership, which means they connected with their companies and invested in companies to get things done. This created norm during this time, and they used masks a lot during COVID-19. So when word came out that COVID-19 had been spreading, institutions issued strict travel controls. And this was not recommended by the World Health Organization at the time. They then used transparent and clear messaging to the public through apps and websites. They instituted school closures and mandated mask wearing and lockdowns. Next, these government institutions banned private companies from exporting masks and look at institutional hurdles. The Center for Disease Control and Prevention, the CDC, and the US Food and Drug Administration, the FDA, made it illegal for private labs and even local public agencies to jump into action with their own solutions for test making. Instead of enlisting the private sector early on in the pandemic, like the East Asian tigers did, the US officials relied on test kits prepared by the CDC, and many of which proved faulty. So for at least 5 weeks, the United States had no idea where COVID-19 was. Another issue was that in the 10th Amendment, this made it impossible for the federal government to really have a Moreover, there was no universal mask mandate, and contact tracing efforts were only instilled recently. So if you see here, this is some of the reason why the United States prevails at the top for COVID-19 deaths. So quickly jumping over to vaccines, the United States was one of the first countries to develop a vaccine, However, this led to a lot of vaccine nationalisms. The United States basically hoarded a bunch of vaccines, and there was also a lot of vaccine hesitancy. So a lot of American citizens weren't very trusting in their government. On the contrary, East Asia in many different groups. So thank you for listening to me today, and let me know if you have any questions later.
Thank you very much, Ariel. I think we will take question and the last of discussion. Yes. And I want to invite the last speaker, Paul Kivala. He always part of our Intercontinental Congress. Welcome again, Paul Kivala, please.
Thank you, Dr. Kandar. It's always a pleasure and honor to be here in Turkey. This is definitely one of the best congresses that I attend every year, and I look forward to hopefully coming back and seeing you many times in the future as well. I'm going to be talking today about wearable technology in the emergency department and EMS, and this kind of goes a lot with the pandemic. It goes a lot with Dr. DeSoma's talk on telemedicine, because a lot of that has expanded very quickly over the last several years. My hospital does do something called mobile integrated health. And that's something where we use a lot of other providers to try to discharge patients home quickly, and oftentimes avoid admissions altogether. There's a program that our university is part of that has been at Johns Hopkins and Vanderbilt for many years, where it's called a hospital at home, where we'll discharge potentially 20% of the patients can be discharged at home rather than admitted. And we'll talk about the wearable technologies and things that are in there. I also have advised to several different technology firms and a member of the American College of Emergency Physicians Innovation. Many of you are probably too young, and I'm not sure if Star Trek was a big thing here in Turkey. Was Star Trek a big thing? All right, so if any of you remember this, you know, here was something that Bones McCoy carried around, and he was the doctor on there, but also Spock carried it around, and the Geo people. It was something called a tricorder, and it was this little handheld thing that you could basically diagnose a patient with. And so this was one of these really kind of futuristic things in the 1960s. Interestingly, in the US, there's a program called the X Project, where every several years they develop money to basically create a contest. And back in 2000, link in with breathing apparatuses that people have at their own home, and there's even remote fetal monitoring that is all being done on a remote basis, and in the United States it's being compensated for. One of the biggest challenges we've had in the United States is actually getting the physicians to actually use this. So certainly there's a payment methodology, but the payment methodology in the US was so low that the doctors didn't think it was worth their time. So one of the things that's happened over the last year is they've actually increased the payment rate for these services by up to 50%. So time will tell whether there'll be more physicians using this technology here in the near future. Then, of course, there's obviously these smartwatches. How many of you guys have an Apple Watch or a Fitbit or something like that? Yeah, just wait. It's coming fast. But, you know, this has changed very, very quickly. You know, one of the things that Apple And how many of you have had patients come in and said, I think I have atrial fibrillation because my watch told me so? Have you seen that here yet in Turkey? Well, we see it in the US, and so I'm figuring out how to download the technology from their watch to actually figure out if they were reading it correctly. So a lot of that is happening now and something you will see here in the near future. You know, the interesting thing about the smartwatches is this is the 8. It can have high and low heart rate notifications. It can obviously diagnose, or not diagnose, but record it well here, but the lead on the left is the anterior leads. And if I place it on the left side of the patient's chest wall, those are the lateral leads. So I saw ST elevation in the anterior leads and depression in the lateral leads, and I called for an ambulance, and it turned out the patient had a heart attack. So I was right in using my device. So these things are changing very, very quickly. The other thing that exists out there are portable ultrasound machines. These are becoming more and more handy, particularly in our younger physicians. We can use it to look at the heart. We can look at it to look at bones, joints, muscles. We can do it for a fast exam in the abdomen. We're using it to help start IVs. And we're now looking at it for more and more for lung assessment. So I can argue we could be looking at if somebody's at high risk and they want to go home, they could actually wear this and determine if they're having a myocardial event. One of the newest things that I saw at the latest ACEP conference is something, there's several different things, BrainScope's one of them, BrainView, there's many others on the market now, and these are instant EEGs. And this is something's placed, leads are placed on the head, and in a few minutes you can determine if there's asymmetry or irregular brain activity. So how could this work? You could sit there and say in the field, if someone had a severe headache or head trauma, you could put this on them, and if there was asymmetric activity, you'd be worried about a bleed. If there was hyperactivity, you could be worried about a seizure. All of those things could potentially, or whether someone had a stroke, can even be detected on these devices. So at our hospital, sometimes patients wait temperature changes, there's pH changes, which is one of the earlier evidence of infections, and they even are potentially looking at having certain antibiotics and everything being able to be infused by these. I only have a few seconds left here, but the last thing I'm going to talk to you about are the portables. These are happening very, very quickly. We used to send off lab. Now some of these portables, you can draw blood and put this in a little connectivity that you can have on your belt, and this can get you a hemoglobin or hematocrit in under a minute and get you a pH in a minute.
And in fact, probably in the last 3 years, one of the most frequent things I recommend to my patient is just to get rid of his watch, Apple Watch, or recording ECG, because they are constantly looking at it. So how do we use all this incredible technology in the real world to make life, let's say, more easy for physicians and probably more effective for the diagnosis, but not just because we want to do more?
Dr. Brugada, that is a great question. And I think this is one of this is, how do you get this off of somebody's Apple Watch if they have it? I don't know if too many of us have ever looked at that, and I think that's something that needs to be part of our training as we go forward, is how do we use this in an effective way? Did that answer your question?
Sure. If I can, How do you perceive that we are going to arrange the legal issues that will come with that? Because many patients, when we give them a home monitoring system, whatever that monitors them, they are strongly believers that we are watching them 24 hours a day and that we will react immediately if something happens. And this is not true. We are not doing that. We're not.
Which doesn't allow for people to make their own path and do their own thing. So I think creating laws and fines for everyone to have a sort of unified response would be the best thing.
Thank you very much. Yes.
I have a question.
Yeah, please.
Ariel, I have a question. If you are the President of the United States, suppose that you will be the next president, how do you fix it? Because the system shows of the rest of the world that the system isn't working well.
The important issue is not to record a lot of things, but just to have contact with them. So if you have a nurse that calls them every morning and reminds them that they have to take the pills and that they have to eat, let's say, healthy and exercise a little bit, and if you do that every morning, this is more powerful than any information you can get, except maybe for weight, okay? That's probably the only two things that have been demonstrated to be very, very effective. No control of weight, and if the weight increases, take more diuretics, and remember them to take the pills, because 50% of the patients do not take the pills appropriately every day. So how do you match that with the need of high technology?
Important solution is the satisfaction of the patients at home to have somebody, and in our group it is the central nurse station. You know, in our recovery fund in Italy, 55% of the funding coming from European community will be invested in nurses system. So these nurses call the patients can absolutely improve the adherence to treatment. That is one of the most important reasons for patients to come back of worsening heart failure. But also, it is also important that people are very satisfied. We sent a questionnaire to our patients. After 2 months, they say we are very...
Another question from participant? I didn't see. Dr. Ahmed, you have experience about application. What do you think for the future we can use in our practice? Technical.
I use scoring system apps mainly in my phone, but maybe in the future I was really interested about the glucose monitor without the pinprick, but I don't see how it's coming to the iWatch.
My thought is if you can envision it, with the young people out there doing the advances right now, it's just a matter of time.
Thank you very much. I think we haven't more time. We will finish. Thank you very much. We're waiting all to after 20 minutes for fantastic opening ceremony. Thank you very much for joining us.
That they have in different fields. Let me introduce one of our speakers is Dr. Hikman Amarov. He is from Uzbekistan, and he wants to talk about the stent graft in emergency, challenges and achievements. Thank you, Doctor, for being here.
Herkese günaydın, merhabalar. Esteemed Chairman,
Dear colleagues, thank you very much for having me here. It's a great honor and pleasure for me. And I would like just to present our small experience in stent grafting in emergency cases. So the frequency of the occurrence of the aortic disease continued to increase in our country too, and with an incidence of 5 to 10 cases per each 100,000 populations. So recently the global severity of the disease 2010 project has shown that the global case fatality rate for aortic aneurysm and aorta dissection increased from almost 2.5 to almost 3 per each 100,000 inhabitants within 20 years with a male prevalence. Okay, now it's good?
Yes.
Okay. By Stanford and by DeBakey, and mostly the aneurysm of the valsalva sinus, aneurysm of ascending, as I said, aorta, aortic arch, the descending aorta aneurysms, abdominal aortic aneurysm, and aneurysm of combined localization or general. And of course, it's caused to rupture and the very, very, very sudden death. So let me demonstrate some cases from our hospital. The 3 patients, mostly male, which referred us with several stages of the thoracic aortal aneurysms and what we succeed to do with them. So the first patient is a male, 40 years old. All the patients appeared to the emergency this year. So the male, 40 years old, with a periodic pain in the chest, increased blood pressure and infirmity. So, of course, it's male again and a beta blocker consumer and suffered in history chest injury due to the accident. This is just to be noticed. On the CT of the graft, and this is the final result. You see the stent graft, so we succeeded to use only one segment. It's about 30 centimeters long. And on the descending, so it's type B by Stanford. And here is CT angio after the implantation of the stent graft. So patient survived. The next patient is 47 years old, male again, with a pain behind the sternum, dyspnea for little physical, for very less physical exertion, increased blood pressure again, and general weaknesses. So I think the main clinical factors of this. So remarkable that the blood pressure was above the 240, and this was usual for them. So this is a chest CT again before the procedure. You see again the aneurysm of the descending thoracic aorta. Again, this is a type B by DeBakey, by Stanford. And this is angio, direct angio of the thoracic aorta. With a less physical exertion, increased blood pressure again, and so we diagnosed that there is a dissecting aneurysm of the thoracic aorta, type 2 by DeBakey, type B by Stanford, and sexual hypertension and abdominal aortic thrombosis. And the remarkable that he has the ischemia of the left limb and right arm. So here you can see the arch and the blocked the truncus. Now it's restored. Here is a CT angio after the implantation of the stent graft. Again, but here we couldn't succeed with only one segment. We used here, as long as the dissection was 50 centimeters long, so we used the 2 grafts here. So thank you, and it was very short presentation. Just would like to remind that the aortic dissection in emergency remain the main death cause in the quite young male population. Thank you.
You're welcome. We expect to make the question at the end of the presentation, okay? Thank you, doctor, for the presentation and the cases that you are here. Well, we want to continue with our speaker is Dr. Ayman El-Meyab. He's cardiology, and he's the Director of Clinical Research and Development in Trauma and Vascular Department in Hamad General Hospital in Qatar, and also is Associate Professor of Clinical Medicine in Weill Cornell Medicine College. He wants to talk about the topic in high shock index in the emergency room. What does it mean? Thank you, doctor, for being here.
Thank you. Good morning. I am going to speak about the concept of using shock index in the acute emergency situation, and this can be alone. You can depend on shock index alone as assessment tool. Some people can use the reverse of the shock index. They make it systolic blood pressure divided by the heart rate. Some people can use it as called delta shock index. Delta shock index means I will check the shock index now and after 1 hour and see what happened. The change is in positive or negative. And this delta or change is reflecting the severity and the outcome of the patient. Some people are using diastolic shock index. They are not using systolic. They use heart rate divided by diastolic blood pressure. But this one is especially important if you are looking for the vasodilatation effect, especially in the mortality of the patient. It increases the mortality 3 times. Other people can use the age-adjusted shock index because shock index can vary with age. It is not in young like adult, like old. So they multiply shock index by the age. And another people can use with the mean arterial pressure. But the last 2 need some calculation. So the use of shock index can be in the pre-hospital situation, in the emergency can do it, in the AMS, or on arrival to emergency, or also used in pelvic trauma. So in pelvic trauma, which is mainly due to bleeding around the fractured bone, the shock index can predict the need for transfusion, blood transfusion. And it can predict early shock and correlated with the saturation and lactate. So we divide our patient here, but using cutoff of 0.9. So patient with pelvic fracture and shock index more than 0.9, they need massive transfusion in 8%, and the mortality increase up to 13%. And the predictive value of shock index, we can see the negative predictive value is 98%. So we already published this in the World Journal of Surgery. The bioshock index, I said in brain injury, we link the shock index with the troponin because we found shock index is not predictor in traumatic brain injury. But when we link it to the troponin, we found the mortality is very high. So shock index in non-trauma emergency will take you now away from the bloody field in the trauma to the non-bloody area in the emergency, with like myocardial infarction, acute coronary syndrome, heart failure, and so on. So we have tested the shock index in 24,000 patients in our region, in the Gulf region, patients who presented with acute coronary syndrome. The idea that shock index is a predictor of microvascular damage and the extent of myocardial injury. It also predicts short-term and long-term mortality in ST elevation myocardial infarction. And also it increased the hospital mortality in non-ST elevation myocardial infarction with poor 5-year prognosis. Higher shock index may reflect the sympathetic overactivity, which is associated with fatal ventricular tachyarrhythmia, which is also a reason why high shock index can be associated with high mortality, because this means sympathetic overdrive, which can cause tachyarrhythmia and myocardial infarction, which is very serious. Elevated shock index is suggestive of more severe. We also tested the shock index in patients with acute heart failure, and this is also multi-center, multinational observational study. And this was done on around 5,000 patients admitted with acute heart failure. The cutoff of shock index here was 0.9, and we compared those who had less than 0.9 and more than 0.9. And also we found that the symptom of the heart failure or the manifestation of heart failure, each manifestation is a severe manifestation is going with the higher shock index. And you can see pleural effusion, basal crepitation, ascites. Each symptom or manifestation, there is a link. If the patient have beta blocker, for example, before the accident, the heart rate will not go up, so the shock index will be affected. How to overcome this? As I mentioned, to link with other simple tool, which can be done immediately. The point of care lactate, it can be done in 1 minute. So this is a simple guide to save time, cost, and lives. And thank you.
Thank you, Dr. Heyman, for the excellent presentation. And we want to continue with our next speaker. Is by Zoom. Is ready, Dr. I think is there. Well, our next speaker is Dr. Wang Shong from China. He wants to talk about what we are doing in the prevention sepsis campaign in China in the emergency department. Dr. Wang is actually working in the Changgun Hospital in Tsinghua University in Beijing. Thank you, Dr. Wang, for being here by Zoom.
Thank you for the President for your introduction, and thank you for invitation, and I'm very glad to share our work with all of you. In China, approximately 23 million people have to be treated in ICU for sepsis each year. With the development of infected disease, the hospital length and in-hospital mortality is increased significantly. Before sepsis, patients patient can be treated in emergency department. And if they had sepsis, the patient should be transferred to ICU. According to the survey, 18% of patients with infection initially present to emergency department, but only 50% patients with sepsis fully received emergency care protocols recommended by the Center of the Medicare and Medicaid Services. Based on this, the concept of PICC was proposed at the Nanjing Jinling Emergency Medical Forum in May 2018, and the expert group was organized to write an expert consensus on sepsis. But why I turned, but on my screen, perhaps I share it again. Hold on. 等一下，先把它关掉，能关掉吗？ Share
the screen and then click.
Yeah. Again. I'm sorry.
Okay.
I see.
I see.
Okay.
Okay.
要不就别全屏了，全屏我估计它是不是就
Is a change?
Now we are in the diagnosis of sepsis. Is the 8?
The diagnosis of sepsis?
Yeah, we are in the 8. Slide number 8.
Okay.
Yes. 8. Is correct?
Based on
Sir, is correct?
Okay, the 8 is correct.
Okay.
All members are located in model was created using multivariable logistic regression, is which consider of alcohol consumption, lung infection, temperature, respiratory rate, and so on, had excellent predictive performance with area and curve value of 0.78. Lastly, a nomogram of ease was developed to facilitate clinical use. And this is another research work that's with the advantage of ultrasound technology. We can use bedside ultrasound to evaluate the
Sir, can you open the screen, because you cannot pass the slides. This is because you are not complete the screen. If you open the screen complete 100%, and then you can pass the new slides, because you are talking and the slides is stopped.
Perhaps something wrong with the internet, because my slide is turning. So how could I use the blocking and molecular dynamic stimulation to measure the binding tightness of the stability of the quercetin and sepsis target molecules, and finally we found that the quercetin, one of the compounds of rezhuning, can protect endothelial cell with the PI3K AKT pathway acting on AKT1 in sepsis state. And as confirmed by Western blot and cellular fluorescence PAK2 and PI3K level increase, and apoptosis associated protein level cascade 3 expression, degradation of glycocomplex in endocellular cell. We have another research about involved PIRK1 and the iron death in DC cells in sepsis. So this is the Long River in China. We call it the Yangtze River. It's a very famous river in China. In our mind, the infection is the start of the response of the body, but it's small. According to the water down to the river to the sea is become very large. With the release of the sepsis 3 circulation, coagulation, and many other aspects. The main studies in our group currently include regulation of immune response, barrier protection of endothelial cells. In order to ensure the implementation of the program, we also structured a platform. We share our project philosophy with our colleagues through events such as Talking Inflammation Storm and Sepsis Prevention and Intervention Summit. Also, we have established a special research fund in Tsinghua University.
This one? Okay, go ahead.
Thank you, Doctor, for your nice presentation. I have two questions, one for Dr. Alimov and another one for Dr. Ayman. As you know, we are as emergency physician, still chest pain at emergency is a challenging, and we should exclude the life-threatening condition of chest pain. And as you know, Dr. Alimov, maybe aortic dissection, the gold standard, it is only by angiography. My question, after we excluded of acute coronary syndrome, it is from your experience as a stent graft, each patient with chest pain, he should to do CT angio, or it is dependent on the cases? This is my question for you. And for Dr. Ayman,
not about the chest pain and what it can cause too. Of course, firstly, we have to exclude acute coronary syndrome, and only after that thinking about some things about aortal dissection or the rupture of it. And exactly for these cases, the CT angio is, by our standard, is a first step.
We as a society, there's too many, we call them merit badges. It's everyone's another badge. And so philosophically, we believe that all of that training is already incorporated into our residency, so we do not necessarily require each one of these badges, so to speak. So I hope that answered your question, but yes, it's important that we're all doing the same thing. You know, we incorporate ATLS into our training programs. We obviously do ACLS, we do periodic up.
Ben de ilk defa bu proje vasıtasıyla yürümeyi ön plana çıkarttım. Ben çok teşekkür ediyorum. Çünkü projenin katkısı gerçekten çok önemli bir sosyal proje. O yüzden de yani böyle bir katkıda bizim de payımız olsun. Atuder'le birlikte böyle bir çalışmayı da yaptığınız için ben firmaya özellikle çok teşekkür ediyorum ve şükranlarımızı arz ediyoruz. Çok teşekkürler. Şimdi evet. Yürümek önemli, biliyorsunuz. Açılışta 2-3 defa yürümekten bahsettim. 20 yıldır beraber yürüdük biz bu yollarda. Çocuklar incelenmiş. Çok önemli. %50 erkek, %49 bayan. Yani hemen hemen eşit. Burada ciddi bir şey görüyoruz. Ve yine de hiç aslında tahmin etmedim. Mesela ben burada bir anket yapsam en çok hangi yaş grubu başvurur desek o kadar belki de tahmin edemeyeceğimiz bir şey. 10 yaş altı en fazla. Halbuki çocuk acil farklı bir konuma alıyoruz. Burada beklediğimiz yaş yüzdesi aslında bakarsanız yani biz geriatrik acillerin çok daha fazla olduğunu düşünüyoruz. Ama neden böyle oluyor? Çünkü geriatrik acil muhtemelen çok daha fazla zamanımızı alıyor. Yatak doluluğunu oluşturuyor. Yoksa burada bir anket yapsa eminim ki en çok nöbetçi olmuş oluyordu. İlk uygulayan benim yani bunu. Uzun yıllar önce tabii. Bunun dışında tabii hepimizin tahmin ettiği en çok yeşil başvurusu oluyor ve en az gerçek acil çok az. Binde 3 ya. Binde 3 gerçek acil. Çok düşük. Ama maalesef yeşil alan başvuruları çok ciddi boyutta. Bunun üzerinde de çok analiz yapmamız lazım. Çünkü acil servislerin eğitiminden tutun yapılanmasına kadar bunlara dikkat etmemiz lazım. Bir de çok önemli yine bahsettik mevsimsel aylarla ilgili başvuru oranları. Genellikle hep Ocak ayının yüksek olduğunu biliyoruz. Pandemiden önce, pandemiden sonra bunları da gördük. En sık karşılaştığımız gruplardan biri. O yüzden atak tedavisinde bazı ilaçların yeri farklı oluyor. Pek kullanmıyor olabiliriz. Ben burada atak tedavisini söylemeyeceğim ama özellikle asetilsisteinin askorbik asitle birlikte koah alevlenme oranını azalttığını görüyoruz. O yüzden bronşit vakaları çok fazla, kronik bronşit vakaları çok fazla, koah vakaları çok fazla, acil yığılmaları çok fazla. O yüzden özellikle C vitaminli formunu biraz ön plana çıkartarak. Çünkü 2 formu da var değil mi? Oradan gel, şöyle gel. Ama bunlar ikisi de faydalı. Ama N-asetilsisteinin burada koruyucu etkisi mutlaka irdelenmesi lazım. Çünkü hepimiz muzdaribiz. Koa hastalarını yatıramamaktan, ataklarıyla uğraşmaktan ve bizi böyle bir kış... Araya karışmış bir şey mi bu ya? Dur bir dakika, nereye gittik biz? Emre, biz nereye gidiyoruz? Geriye şöyle gidiliyor. Dur karıştırmayalım. Geriye gitmeyi buldun mu? Yardım alacağız her zamanki gibi. Başa kadar gittik, tekrar gözden geçiriyoruz. Ama şurada anlaşıldıysa bir sürü iş başına geliyor ama bu bir halk türküsü en sonunda bir nezle ya da grip götürüyor. O yüzden nezle veya gribi hafife almayalım. Tedavisini hafife almayalım. Gerçekten Covid de bize bunu gösterdi. Bakın onu bulursanız dinleyin. Gerçekten çok güzel bir halk türküsü. Her şey geliyor başına. Adamın akciğeriyle ciğer böbreğini de alıyorlar. Kanser diyorlar ama bir grip götürüyor. O yüzden kışa hazır gidiyoruz, gribe gidiyoruz. Gribi zaten Covid bize ne kadar bedelinin olduğunu öğretti. Ama şurada arkadaşlar ben hep şunu söyledim. Ya grip olunca gerçekten vücudun direnci çok önem kazanıyor. Bunu hatırlarsanız semptomatik tedavinin çok iyi bir şekilde yapılması lazımdı. O yüzden arkadaşlar burada grip özellikle ciddi bir hastalık, ölüme de sebep olabilir. Burada çok dikkatli olmamız gerekiyor. Bağışıklık sistemi zayıflamış kişilerde, kalp, akciğer, böbrek fonksiyonları bozuk olanlarda, tabii böyle pandemilerde sapasağlam durumlarda da bununla karşılaştık. Yani ben daha önce İstanbul'a giderken Ok Meydanı'nda çalıştım bir dönem, öyle haftada 2 gün. Sonra işte İstanbul'dayım. Hiçbir şey yok. Arabada bazı çizikler olmuş, maliyetinden görünüyor. Bunun dışında biliyorsunuz koah atak tedavilerinden bahsettik. Soğuk hava şartlarında bunlar artacaktır. Ayrıca kapalı ortamlar bizim zaten hepimizin yaşadığı şeyler. Bu yüzden de atak tedavisinde mutlaka neyi kullanıyoruz? İpratropium bromürle salbutamolu, tabii onu biliyorsunuz, hemen anlıyorsunuz ne dediğimi. Bunları diğerlerine göre daha etkin oldu. Hepimiz kullandığımız için biliyoruz. Sadece belki hani isimler aşina değil, onu da çalışmalarımızla isimleri de biraz daha aşina hale getireceğiz. Özellikle GNA 2022'ye göre solunum yolları enfeksiyonlarında antibiyotik kullanımı çok tartışmalı, biliyorsunuz. Ülkemizde hep gündeme geliyor ama özellikle üst solunum yolu enfeksiyonunda bakteriyel eğer düşünüyorsak mutlaka antibiyotik kullanmayı unutmamamız lazım. Antibiyotik kullanımını azaltacağız diye de hastaların hayatını riske atamayız. Yani şimdi gereksiz hastaya antibiyotik vermek ne kadar zararlıysa gerekli hastaya vermemek daha zararlı. Gerekli hastaya vermemek ondan da daha zararlı. Onu iyi ölçümlememiz mutlaka gerekiyor. Çünkü biliyorsunuz ki siz de çok iyi yaşıyorsunuz. Bizim sepsis vakalarımızın çoğu pnömosepsistir. Ve şeylerde görüyoruz arkadaşlar. İlkbahar aylarında özellikle atopik yapıda çok insanımız var ve bunların da ciddi bir şekilde tedaviye ihtiyacı oluyor. Yine burada söyleyebileceğimiz semptomatik konularda özellikle alerjik rinitte hapşırma, kaşıntı, burun tıkanıklığı ve rinore gibi birden fazla semptom var ve bunları kontrol altına almakta. Pseudoefedrin de içeren preparatların kullanılmasında fayda var ama biz bunları gripte de üst solunum yolu enfeksiyonlarında da semptomları kontrol altına almak için önerdiğimizi söyleyelim. Yine az önce bahsettiğim arkadaşlar, ilkbaharda ne olur? Stres faktörleri vesaire, mide kanamaları. Mide kanamalarında da mutlaka PPI'larla kontrol altına almamız gerekiyor. Ve burada da dikkat ederseniz acilde bir infüzyon tedavisi yapıyoruz. Bunu hep söylüyorum. Burada tekrar söyleyeyim. PPI'de infüzyon tedavisi ayrı bir önem arz ediyor. Çünkü acildeyken ne yapıyoruz? Mide pH'ini 6'da tutmaya çalışıyoruz. Neden 6'da tutmaya çalışıyoruz? Çünkü pıhtılaşma faktörlerinin en iyi çalıştığı şey o. Onu da ancak infüzyonla sağlarsınız. Onun dışında da mutlaka bir PPI ile tedavisini devam ettirmek gerekiyor. Burada da hızlı etki, uzun etkiyle rapipronazolun ön plana çıktığını söyleyelim. Peki yaz aylarında neler bizi bekliyor? İşte gastroenteritler hemen orada kendini gösteriyor. İdrar yolu enfeksiyonları biraz daha yaz aylarında önümüze daha fazla çıkıyor arkadaşlar. Bunlarda da neler yapabiliriz? Gastroenterit tedavilerinde özellikle çocuklarda bu daha ciddi bir sorun. Kaybettiği sıvının mutlaka verilmesi lazım ama işte semptomatik tedaviler orada da önem kazanabilir. İdrar yolu enfeksiyonları ise pielonefrite zemin açacak ve bunlar üseye gibi değil, yani hani viral olduğunu düşünmüyoruz. Burada mutlaka antibiyotik vermemiz lazım. Orada da yine cefpodoksimin etkin bir antibiyotik olduğunu burada iletebiliriz. Şimdi arkadaşlar, sonuç olarak bu da benim anlatmak istediğim, aslında yaşlara göre acil servisler değerlendirilmeli. Hasta başvurularına göre acil servisler yapılandırılmalı. Saatlere göre acil servisler yapılandırılmalı. Ve hastalıklara göre de bizim eğitimlerimiz planlanmalıdır. Mesela az önce verdiğim örnek, biz kış aylarında koahla uğraşıyoruz. Yaz aylarında ortopedi vakalarıyla uğraşıyoruz. Yaz aylarında femur kırığı 15 gün ameliyat etmeyi bekliyor. Kış Kış aylarında koa hastalarımız yer bulamıyor. Bunun için planlamaları mutlaka buna göre yapmamız, eğitimlerimizi de buna göre tazelememiz gerekir. Mesela kış aylarına girince bunun bir alışkanlık haline gelmemesi lazım. Mutlaka semptomatik tedavilere önem verelim. Gerekli hastalarda antibiyotik tedavilerine önem verelim. Ve bu konudaki yaklaşımlarımızı da mevsimsel olabileceğini, yaşlara göre farklı olabileceğini bilmemiz gerekiyor. Bu sosyal sorumluluk projesi kapsamında da uydu sempozyumunda bana konuşma fırsatı verdiği için ve bu önemli konuyu gündemimize taşıdığı için Seltis İlaç'a ben çok teşekkür ediyorum. Soru ve katkılarınız varsa buradayım Sayın Başkan.
Çok teşekkür ederiz Sayın Başkanım. Başkandan başkana diyor ya. Güzel sunumunuz için. Ben salondan katkı, destek ya da farklı bir şey olursa onları alabiliriz. Tam da bu kış öncesi bir dönemde kış hazırlığı diyor ya, kış hazırlığı açısından alert olmamız gereken hastalık gruplarıyla ilgili ve özellikle ülkemizin farklı bölgelerinde. Sinop'tan gelen var mı aramızda? Bir tane gelmeye yakalamışız. Bir acil uzmanı arkadaşımız söylemişti de Türkiye'de en yaşlı nüfusun olduğu şehir diye Sinop. Ne kadar doğru biliyorum da. Yani daha çok geriatrik hastaların ağırlıklı geldiği bir yer. Tabii ülkemizde çok farklı yerlerde çok farklı hasta profili olmakla birlikte acil servisler tüm hastalıklar için her mevsimde zaman zaman farklı hastalıkların gelebildiği, başvuru yaptığı yerler. Dolayısıyla farklı deneyimler de olabilir.
Bizde de keza öyle. Üniversite açık olduğu dönemlerde genç başvuru sayısı çok fazla artıyor. 20 ve 29 yaş arası. Muhtemelen aksayıda çıkma nedenlerinden bir tanesi de o olabilir. Üniversite gençlerinin malum en ufak nedenden dolayı yani, acillere başvurması o oranı değiştirme şeyleri yüksek hocam.
Evet. Sanıyorum çok önemli bir nokta çünkü biz bu konuda deneyimimiz oldu. Bizim aslında tabii ki çok merkezli yapacağımız çalışmalar bu konuda bize ışık tutar. Bunlar içinde de muhtemelen geriatrik aciller ön plana çıkacaktır. Ama şunu da unutmamak lazım. Gerçekten sayı olarak yeşil alan çok fazla sayıları etkilediği için muhtemelen yeşil alana başvurularda da değişik yaş grupları olabilir. Yani hani geriatri çok fazla yeşil
Katılımcıyı bulmak için bayağı bir karıştırdım şöyle. Biraz kendimi arıyorum. Evet arkadaşlar. Tek bir çekiliş yapacağız değil mi hocam?
bir tane yedek çek istersen. Önce yedeği çek olmaz. Bir tane çek olmazsa yedeği.
Şöyle en sıkı sarılmış bir tanesini çıkardım. Heyecanla bekliyoruz. Boşmuş. Pardon. Evet. Çalışayım.
Doktor yazsın herhalde.
Doktor Muhammed Çakas.
Muhammed Çakas burada mı? Tamam. Muhammed ne istiyorsun? İsteyeyim. Çekiliş sende. Ne istiyorsun? Sana özel hadi bak. İlk çekiliş olduğu için. Ama canım yani şeyli bir şey iste yani şimdi. Kurallara göre bir şey iste. Evet.
Kongre isteyebiliyor muyuz?
Evet.
Ya mümkünse kongre isteyebiliyor muyuz?
Ağanın eli tutulmaz. İstiyor. Evet. İstiyorsunuz. Seneye VASEM Kongresi'ne kaydınızı yapıyoruz.
Teşekkür ederiz.
Tamam. Not alalım. Bak unutturmayın bize o zaman. Menderes Bey'e ismini yazdır. Tamam. VASEM Kongresi'ne kayıtlısın. İlk üyemiz, ilk kongre katılımcısı sensin.
Teşekkür ederim.
İyi. Başka bir şey istemedi yani. İyi. Ne istese vereceğiz. Evet. Peki çok teşekkürler. Var mı hocam? Hemen şeye başlamamız lazım. Arkadaşlar burada
is a fantabulous ballroom dancer. So time to dust off those twinkle toes and get them up to the stage.
Thank you, Roger. It's always
a pleasure to be with you, and you being a moderator, it will be more active for both the audience as well as the speaker. So, hi everyone. It's a pleasure to be on this platform, especially a special mention to our professor and president, Dr. Bashar Kanda, who is always a kind friend and what else he was not recognized 30 years back or 40 years back, even before we have not been anything, before we were born also. And this is the whole platform you can see where all India, the EM is being recognized, and 27 as per 2019 data, that's what it says. And to develop any specialty, it is important that it faces through 3 phases. That's what every time we keep saying. That is a primary stage where the various specialties apart from the emergency medicine come together, they make a platform, they create the syllabus, they give it across. And then the secondary stage is the economic structure, because every subject itself has its own to place, and EM is the one which is the most important. And as such, if you see in Asia, apart from our illnesses, which Dr. Bashar was telling about, the influenza, COVID, everything, it is not the only one. We have the vulnerable continent as the disasters also. So these are the 10 top countries which has the disasters also. So hence the disaster medicine is also important apart from your regular medicine. And this data I have taken up from the Asian Society, where they have put up a good background of every country which has been developed as an EM as a specialty. So you can see Singapore was the one which got the earliest recognition in emergency medicine. And this slide will show you the whole of Asia which has a emergency care systems for universal health coverage. And this is how it has been developed, and with this one slide we can see that how a tertiary care illness or an acutely ill patient or an injured patient which comes to the ED department, and what happens in the ED department itself, and that is how the timeline, and that is where it is. And when I went into each and every country, it shows its own importance and its own problems which has been facing. And then the dispatch capabilities. Every country has a national ambulance system like 911 in US. So in our country, it started with 108 and it covers almost 32 states in the country as well as culture. So in Myanmar, we all are aware that there is a military coup. So even the emergency departments are over-flooded with the injuries itself, so that the Myanmar country has been looking after. And recently in Sri Lanka, we all know that there was an emergency which was being declared, and so many of the EDs were shut down, and the ED physicians had to flee the country, and also some of them who are there during the COVID also could not be able to manage the situation. And of course now, post-emergency, they have come up with a good plan. They're taking the support of the WHO, they're taking the support of all the SAARC countries and developing back their nation into normalcy. In Philippines, we see now and then it is the disaster. Substance is next common thing. The third one was the orthopedic injuries, trauma, high intensity traumas. These were the main things which we could see there, and that is how it has been looked into. And then EM in Japan and Taiwan, the population is growing. So they are more into the geriatric age group, and they are looking into how they can cope up. Like in Canada, again, the geriatric emergency services are getting ready, and when the population grows, the more intensivity falls on the EM physicians, because we are not only able to take care of there are 5 things which I always keep telling: A, B, C, D, E, airway, breathing, circulation, disability, and exposure. In the same way, it is nothing but we have to look into and mitigate our own plans. How can we do it? It's a very simple one. I just looked into. A, for aggression. Being in emergency department, we should be aggressive for the illness, look into the plan and detail it and do it. So B is for branding yourself, because most of the emergency departments feel that we are not being brandized, we are not being taken into consideration, we are not being looked into. So branding ourselves, like what Professor Bashar used to keep on telling in his communication skills, it's very important to communicate ourselves. That is what is C. So you communicate.
We're not going to take questions at this stage because we've got a segment scheduled for discussion at the end of the session. So if any audience members do have any questions, if I could ask them to hold on to them for the discussion period. But thank you.
Thank you.
I've realized that I don't walk across the stage with half as much flair as Prof. Kanda does. Yeah, that's picked it up now. Right, thank you very much. As I said, my name is Roger Dickerson. I am quite frequent at this conference, and it's wonderful to be back here once again. I am from the beautiful city of Cape Town. That is a picture of my hospital sitting in front of Table Mountain. But we are sitting in this beautiful part of the world at the moment. What I'm going to be looking at during this little while is looking at some of the concerns with regards to the future of emergency medicine on the African continent. And I'll be using some of the examples from South Africa and where they can be extended into the continent. Now, I just have to state from a declarations perspective is that I am an emergency physician. And because I'm an emergency physician, I do come with requisite warnings. I can do problem solving, I can do multitasking, but often I'm filled with bad language, and especially if I have not had coffee. So this appeared in a newspaper recently. And admittedly, when I saw this, my first thought was this at my hospital? When I found out that no, it wasn't at my hospital, I then started to look and I thought, only 3, knowing how much overcrowding is crippling emergency departments across the world. And then I looked at the waiting time of 12 hours and thought, in some instances, these patients are lucky it wasn't longer. But what really came to the truth was that it wasn't referring to emergency departments at all. And it was simply now that not only are there queues at emergency department doors, but there are literally queues to get to the summit of Everest. And I think that's the difficulty. We are all faced with large patient volumes. And you say, it's okay, we can handle this. It's okay, let me take a step back. Take a step back. So you do. And you take another step back. And another step back. And you realize these are the patients who are needing our care. And how do we, as emergency medicine, cope with this? And I think this is one of the big difficulties, is that if we don't cope with it, it's going to lead to death. And that is something that scares me. It's something that keeps me awake at night. It's not about the numbers of sick patients in my department. It's about the numbers of patients waiting to get into it, because they are really an unknown quantity. We don't know yet what's wrong with them, what their severity of illness is, and what we can do about it. So, If we look at most of our hospitals, I'm sure your emergency department looks like this. Squeaky clean, more beds than patients. Anyone? Certainly not like this on the African continent. In the African continent, this is what our hospitals look like, where we've got straight, because once we've got it, we're the nasty teenagers, and the nasty teenagers who can't learn from anybody. And so we've then got to say, we need to make a decision. We need to be able to see what are we going to do going forward to ensure that we don't make the mistakes that others have made in their development. The difficulty for emergency medicine is that our decision-making trees are never like this. Our decision-making trees look more like this. And trying to make an appropriate decision in the midst of chaos is never easy. We hope that we will make the appropriate decisions, and when we do, we get really excited. But we need to learn from the others, how others have done it. So what now? As we've seen the development of emergency medicine from its beginnings, and we learned from other disciplines, we grew up alongside other disciplines to a point that we were able to stand up on our own 2 feet and become recognized clinicians within facilities. But in our own minds, we are more than that. We are literally often, with our toys, the superheroes of the health system. We are expected to manage all cases at all times. And admittedly, I do consider myself a superhero, but I don't look as good in spandex as others. But that can be our own kryptonite. And our own kryptonite is what is going to destroy our specialty. And that is what makes me concerned on our continent. Because we need to look at the life after, and understanding that if we don't do something now, there might not be life after. Because many of our residents are starting to think, if I'm able to get through the specialty program and finish, then what? Is there life after my residency? And let's look at the realities that our residents are faced. Firstly, from a time perspective. Unlike most disciplines, emergency medicine has to function at a high level right round the clock against our circadian rhythms. But in addition to this, it has a tremendous impact. At this stage, I've just received the updated stats from my unit this morning. We are outnumbered by a 2-to-1 factor, so there are more than 2 patients per emergency department bed waiting for beds in the ward, let alone the amount of patients that we are trying to meet. And in all of this, our residents are needing to try and balance life and work. And this is generally what a resident looks like at the end of their residency. They start out young and eager, but they are often quite jaded by the time that they end it. And that is something that concerns me, is what exactly are we going to do to ensure that this does not happen again? And this is being reported all over the world with regards to the stresses that emergency physicians are feeling. And that makes me worry. It keeps me up at night. The burnout in emergency medicine in our country is extreme. And most of our clinical specialists are looking to exit the specialty after only 10 to 15 years practicing as a specialist, because they just can't balance it all. And it's also not knowing what's around the corner. In addition to your regular loads, there are things like wars. And there will be another war. And there will be another pandemic. And emergency medicine will need to cope. Because as was mentioned yesterday, emergency medicine is the front line. Finally, within our continent, job security has become a greater and greater risk. With financial meltdowns occurring all over, there are often not specialist posts for our residents to go into once they have graduated. And because of this, we see that many of these specialists that we've spent a lot of resources training are leaving the countries and leaving the continent simply in order to put food on the table. It makes me worry. This photograph is quite a unique one. This was the night shift welcoming the day shift and trying to impart their words of wisdom of what they'd learned overnight. So I've painted quite a bleak picture about emergency medicine on the African continent, that we are literally hanging on by our fingernails to keep services together. But it's not all doom and gloom. We are able to put band-aids on, and we can survive because of the spirit of emergency medicines. And what we need to ensure is that that spirit isn't extinguished. And this is when I start saying, I've spoken about the bad, let's talk about the good. So in South Africa, emergency medicine has just turned 20. It is almost an adult. But within the African continent, it is still a toddler in some areas, a teenager in others. But what has assisted is the formation of the African Federation for Emergency Medicine. It has helped societies get emergency medicine registered as and recognized as a base specialty. It is formed up by numerous national societies, and Srinath noted the importance of national societies in getting emergency medicine registered with authorities. But you can see across the African continent, those are the number of sites that there are now emergency physicians in place. And it's growing on a daily basis. What we're also seeing across the African continent is the sharing of resources. And these are not only from a financial perspective, but also from an intellectual one, where we are able to ensure that people have got a good training base, and residents are moved all over the continent in order to ensure that occurs. And then once they have been trained, they are assisted in the setup of more formalized systems in their base countries.
Next is Dr. Paul Kibela from the United States.
Next page.
Okay, perfect.
Next page. Laser.
Okay. Well, thank you very much. You know, I'm giving a report on the Americas, and I'm going to be more heavily influenced on what's happening in the United States. One of the things that's happened through the Americas, as I understand, the volume in Canada after the pandemic is actually up. The volume, the volume in Mexico is up, and overcrowding is a problem in every country. But as Dr. Dickerson has said and pointed out, you know, the African emergency medicine organizations are about 20 years old. In the US, we turned 50 a couple of years ago. And so we're reaching some unique problems that I think all emergency medicine organizations, whatever their age, need to address. And these are some of the issues that we face in the US. which will be very different than some of the issues that face elsewhere. So I'm going to concentrate not on the same issues of overcrowding, but really what's happening in the U.S. and this is concern to the emergency physicians there. The biggest issue that we have in the U.S. right now is a workforce issue. For many, many years, we wanted to train more emergency physicians. We projected that there was going to be surplus, or there's going to not be enough emergency physicians in the United States. But unfortunately now, we probably those volumes are still not necessarily back to 100%. And many, many people believe that we've plateaued in our volume of emergency department visits. I'm not so sure that's the case, but urgent cares have popped up, and telemedicine in the United States is becoming very, very prevalent. And insurance companies in the US, which is not an issue to much of the rest of the world, have scared patients from going to the emergency department, saying they're going to get a big bill, that was going to bankrupt them. So they're actually afraid to receive care. As I mentioned, there's these alternative delivery places. Telemedicine is taking off in the United States. It's amazing how many people will talk to their doctor on their phone now, rather than coming to the emergency department. You know, ED volumes are close, but again, it has to do with our nurses. Our nurses quit in huge numbers during the pandemic. And so now the reason that we have so much overcrowding is we don't have anywhere to send them after the emergency department. There are no beds in the hospital, or if there are beds, there's no nurses to staff those beds. So patients that are admitted are backing up our emergency departments. We have the capacity now in our emergency departments to see the patients if we could just get the patients out of the emergency department. An emergency physician. It's hard for probably many of you to realize, but many of our emergency medicine graduates, when they graduate residency, owe about 500,000 euros in tuition money. 500,000 euros or 500,000 US dollars is a lot of money to owe. And so oftentimes they can't get a job to support that. Sometimes it takes them 20 to 30 years to pay that money back, which is a problem. Medicine. Can they go into a hospital administration? Can they do something where they still enjoy and practicing medicine, but maybe not in the emergency department? In the US, we're looking at other options for how and where emergency physicians can practice. We are also looking for alternatives to nurses. Can we provide additional support staff in the emergency department besides nurses? Are there some type of assistant that the physicians can get that will make their job a little bit easier and help them do the jobs that doesn't require a physician? Can there be scribes or people that fill out your chart for you? Can they get your information for you, set things up for you so it doesn't require the emergency physician to do those jobs? And again, to continue to figure out what are the items that are currently stressing the emergency physicians and how do we correct them? One of the some parts of the world, but in every emergency department that we've all seen increased violence, that emergency medicine is the essential specialty of 2022 and beyond. And hopefully this will translate well, that we are the masters of the undifferentiated patient. And when I say undifferentiated patient, That's the patient that comes in with chest pain or shortness of breath or a headache that we don't know. It could be any diagnosis. We are the masters of anyone, anytime, soon any place, and the masters of doing more with less resources, less time, and less information. As I said, few have seen the challenges of the pandemic.
Thank you. Next is Dr. Eric Review from France. I think Eric is doing his lecture through Zoom, so.
Hello, everyone. It's a great pleasure to see you. I'm very terribly sorry not being with you because I have a lot of friends in Turkey, Roger, Paul Kivela, and it's a shame I won't be with you. One of the things is you discuss about a lot of things about the problem that we are facing, so we'll try to exchange. Can you see my slides now?
Yes, we can, Eric, thanks.
Okay, thank you. So let's take an overview of the situation about in Europe, not only in France, but in Europe. One other thing is, so I'm regretting not being with you because we have some friends, and emergency medicine is also that it's more than friendship, it's sharing experience and sharing a lot of things we have in common. So the situation in Europe, as we do have a rising number of ED visits for the past 20 years, and the situation is still changing, and we'll see how it could be changed. So we'll make a small tour of Europe, and through a questionnaire that can be made about the situation in Europe. You want to know how is the emergency department asked to the nurse, asked to the patient. In this study, we asked the European nurse how they can rate their own hospital and their own departments. And in these departments and in Europe, nurses said that the quality of care is really low in Ireland, it's really terrible in Greece, and it's different in Switzerland. They have the feeling that they treat quite well patients, and as you see, the burnout situation is quite high, not in the Netherlands, but more in Europe and in US. It's exactly the same situation where the job dissatisfaction is really quite high now, and is very similar Europe to US. So we don't have a lot of difference about that. And when you focus on Europe, it's really a poor quality of care that globally that comes through from the nurses, and the situation of burnout and job dissatisfaction is quite high. When you compare to, as Paul Kivela said, it's exactly the same, and we are facing this situation now everywhere. When you look in detail for some European countries, as you see, the worst situation for now is still in Greece, and we have a lot of colleagues from Greece just telling us that it's really terrible. They have a lack of nurses, lack of beds, job dissatisfaction, and a lot of doctors they want to leave. As you see, it's quite similar in different countries in Europe. We don't have all the countries, of course, but it is really terrible that we are facing. The situation is better in the north of Europe, in Finland, for instance, and why not in Switzerland? But that's globally just the exception that we are seeing. If you ask the patient trusts our hospital, patient trusts our emergency department, but they are still coming to the emergency department. And patient just when they we ask them to rate the hospital, it's exactly the same analyze that the nurses. They are very low, they trust and they don't trust in Spain. They are quite, they trust the hospital in Finland, and they will recommend the hospital. They won't recommend the hospital in some country. They recommend in Switzerland. They don't want to recommend their hospital in Greece. So as you see, patients and nurses are saying exactly the same. They are quite focused quality care, and the patient satisfaction is really quite low everywhere. And one of the things I remember, I gave a lecture 2 years ago in Turkey. We are in the day after the COVID. And as Paul Kivela said, it's exactly the same situation. It's really terrible because we are missing more than 20% of nurses in our hospital now. 20% of nurses, it's exactly the same number of beds we are lacking. So we are closing our departments everywhere in the hospital because of the lack of nurses. We need nurses. And it was due the day after, I could say day after, we are 2 years after the COVID, and it is the terrible situation. We had a congress a few weeks ago in Berlin with the USEM that was exactly the same situation in all over Europe. When you look at the old data about the situation, number of physicians, not a problem of number of physicians. I'm quite glad to see that they have a huge number of physicians in US. It's not the point in Europe because a lot of emergency departments don't have enough emergency physicians. So we are trying to find other specialty could work inside the emergency department. It could be family doctors, it could be internal medicine, it could be geriatrics. It's one of the main concerns that we should have in our emergency departments. And the second problem we are facing in Europe is the aging population. And the aging population, as you see, is quite different from place to place in Europe, but it will be a tsunami. The overcrowding problem everywhere. And as you may have seen, it was worse after the COVID period. So we have a lack of beds. And why our patients are coming? Here are the data from Europe. They're coming in emergency department because they trust. They don't have family doctors. They don't have a GP available. They have for financial reasons. They have many reasons for coming emergency department. But those patients are not responsible of the main problem of overcrowding. The other problem of overcrowding is the lack of beds, and it's the output patients, and as Roger said, it's access block also. So we have many reasons to have quite worried about the situation in Europe. And we have violence. We do have more and more violent patients in our emergency patient department because it's not a safe place in the emergency department. We have a lot of reason for that: alcohol, drug, and do not forget that the nurses and nursing staff are the higher risk of be harmed on the emergency department. We have a reason for that. Take, for instance, agitated patient coming in emergency in the waiting room. This patient is coming. He's getting agitated, and the other guys are quite under pressure. That the pressure cooker effect, and are waiting for hours. They waiting for long. And why the patient is coming in front of me? Why? With a better good work environment for nurses first, and we have to focus on nurse because we could have a better quality care. You can tell me that we need nurses also for that. If you take the example of Sweden, they are a teamwork organization program to organize and to make a safety program and a workplace environment for nurses, and the attitude, and they have quality care better organized with this in Sweden. So we could take the example of the Swedish hospital they have done. So the situation in Europe is not really quite high. We need to organize things together, and thanks to Bashar to organize an international conference, because we need to have our brains together, how we can face in a different way, because it's very important to work. We want to solve the problem very quickly for the overcrowding, of course, and the thing is...
Look at that, and I have to tell you, if you're looking for American emergency physicians that are well-trained, I think it's a matter of putting that out there and making sure there's a mechanism for that to happen. A lot of our physicians are young and incredibly intelligent, and many of them speak other languages as well. So I think there's that potential.
I was actually also referring to there are existing programs. I know the global emergency medicine programs like out of UCSF have been doing great work and assisting with setting up emergency training programs. So whilst it's a bit of a flippant comment on my behalf, I think there's already some of that in place, which has been well used. But I think
unquote, and really trying to figure out if we can make all of these jobs a little bit more attractive. And same thing with physicians, is take away some of the jobs that we don't want to do, that doesn't require our skill level, that we're forced to do. And I think that's what we're hearing from our younger physicians that are a little bit more insightful, that I don't want to do this anymore, or I don't want to do this job anymore. And I think we have to listen to them, and I think they have to speak up and make those suggestions.
Thank you. I just want to make a short comment on the availability of staffing and the future of emergency medicine. Basically, when people go through programs and they graduate and they train and they work in different sites, as we move along, throughout the years, some people they find that they have probably different interests, like in finance, in legal. But it certainly would probably have a better response in terms of disaster like flooding or pandemic, or even unify the scope for payment, for example. And that's just a thought.
If I can pick up on two things, I think there's been some really great points made. So in our nursing system, we already operate on a 3-tier structure where the RNs are the chief nurses. We have nursing auxiliaries and staff nurses, which range from a year to 2 years to 4 years of training, and then there's specialty nurses on top of that. The difficulty that often comes is that from a financial perspective, the hospital...
It's more difficult now that I'm in my mid-50s. And I still do them from time to time, but they're much more difficult than I recall them being when I was younger. So I think the issue here is there probably needs to be some type of seniority for the older emergency physicians, that they work less nights. And so I think I think that is probably the best solution. Maybe they work a few more weekends and a few less nights. I think that seems to be the right mix. That also takes off a little bit of the younger physicians that have time with their kids during the weekends. So I think that's the mix right there. It's, not a perfect system, but I think that's how I would address it.
Second, for example, Spain, 4 weeks ago, they go to the Congress, and they don't accept it. But they have fighting for 25 years or something like that. Eric, you know better than me how many years they're fighting, but they don't recognize. So we need to training that the people is working in the emergency room. I know many people is general practitioner, internal, but if you want to work in the emergency room, you need to resolve the problem for the emergency room. So
probably you don't want to be specialized, but you need to take the correct courses to improve your knowledge to resolve the problems, first of all. Second, who held how important is the emergency room? At the beginning, we save a lot of lives. At the beginning, we are heroes. 2 weeks later, 4 weeks later, the heroes was the ICU doctors. Excuse me, we take the care for the patients, but they don't remember exactly what's going on. So if we work together, we'll be stronger and better, and we can resolve many problems around the world because we are similar ideas, similar knowledge, and work together and be successful in the couple of days. We need to make re-engineer to create all. Like Paul say, when do you try to work in the emergency room? I think the best time to work is at the beginning, 20s, 30s, 40s. And then you need to take other positions, like training, like teaching, but you don't need to go out all the time because you are the values that you have, you need to teach for the new guys. The new guys need to understand better than us to advance quicker and in the best way. Because one of the things happen now is that many of doctors, like you said, the burnout around Europe and around the world they affected our population. So we need to create, don't go away the old doctors, support.
Lots of road traffic injuries, and we have patients dying before they come in emergency department. It's not the problem anymore. We reduce to 10,000 to 2,000 patients who die for road traffic injuries. But the main thing we have, with the exception of India and China, they still have a lot of concern, and Turkey, about the road traffic injuries. In Europe, it's mainly medical problems that are coming through emergency departments. But the thing we are facing for now is we still are pioneer of emergency medicine, and we live day after day a new concept. Take the example of the COVID. No one in the room and no one like myself have faced the pandemic like that. We were the first to face that, and we deal with that and we try to organize. So emergency medicine is also
and I want to give the mic to my close friend Hikmet from Atayurdu, Uzbekistan. We are in very good collaboration between Turkey emergency medicine and Uzbekistan. Yes, Hikmet, please.
Thank you very much. Yes, indeed, we are collaborating for more than 5 years, and it's a great honor and pleasure for us. It's quite challenging to start after lunch session as usual, and this is an endless battle of curiosity with physiology, but nevertheless, let's start. So, as Bashar Hocam has said, it's our really great pleasure and a privilege to invite here Professor Giuseppe Brugada for his topic, Sudden Cardiac Death. Por favor, tome la palabra.
Thank you very much, Dr. Andarov, Dr. Canterbury.
This one, next page.
Okay.
Next page, and laser. You
Please laser?
Push, yes. Hold push it. Yes.
Okay. Thank you very much. So I will talk in the next minutes about sudden cardiac death, and I will try, first of all, to remind you the definition of sudden cardiac death, which is a form of death which is natural, which is due to cardiac causes, unexpected in time and form of presentation that is always preceded by sudden loss of conscience, that happens in the next hour after initiation of symptoms, and this happens in someone with or without a known cardiac condition. As you know, the final rhythm that produces sudden death is, in the majority of cases, ventricular fibrillation. But there are other rhythms that might lead to the same situation, which is the asystole, complete AV block, or electromechanical dissociation. But basically, in our interest, the most important one is ventricular fibrillation. Practically any form of cardiac disease can, at the end, produce sudden cardiac death. But basically, we are dealing with ischemic causes, with myocardiopathies like hypertrophic, dilated, or arrhythmogenic, but also some electrical conditions like the long QT, the short QT, Brugada syndrome, but also when we are dealing with patients that have already gone through an acute myocardial infarction and have survived the myocardial infarction, in the chronic phase of the myocardial infarction, there is also a risk of having sudden cardiac death because of the occurrence of electrical circuits in the area of the myocardial infarction. The bigger the myocardial infarction, the most chances that during follow-up ventricular arrhythmia or sudden death might occur. Although in the last years we have learned that it's not only a matter of the size of the myocardial infarction, but you see here with hypertrophic cardiomyopathy, here we are dealing with a genetically determined disease that produces a hypertrophy of different parts of the muscle, and this hypertrophy produces arrhythmias, many of them ventricular, many of them polymorphic, and many of them lethal, that might kill the patient by sudden cardiac death. And remember that hypertrophic cardiomyopathy is the principal cause of sudden death in patients younger than 40 years of age, especially sport practitioners. We also have arrhythmogenic right ventricular cardiomyopathy, which again is a genetically determined disease that produces changes in the muscle, basically in the right ventricle, but also sometimes in the left ventricle. And these changes produce the occurrence of islands of tissue in this muscle, being the basis for the occurrence of ventricular arrhythmias and sudden cardiac death, again in young population and again in sport people. However, there are a number of patients, around 20%, who had sudden cardiac. Why we call that channelopathies? Because these are diseases which are familial, so they are genetically determined, but affect the channels that regulate the flux of ions across the membrane. And these channels, if they have a mutation, they will not work properly, and they will produce some signs in the electrocardiogram, but also might produce some electrical gradients in different parts of the heart. These electrical gradients leading to the occurrence of ventricular arrhythmias and sudden death. Again, we are dealing with a familial disease. This is a family with Brugada syndrome. This guy here died suddenly. There are other 8 members affected in this family, and this allowed us to identify a mutation in the sodium channel that was responsible for the disease. This is the first patient we ever saw with the Brugada syndrome. That was in '86. In '92, we published the first paper. We defined the characteristic electrocardiogram. We understood the mechanism leading to these anomalies in animal models. We understood that the patient should be protected with an ICD. We could define in 1998 the first mutations in the very abnormal giant negative T wave in left precordial leads. This is a very dangerous situation. This is a very high instability from the electrical point of view, and this patient might go into ventricular fibrillation at any time because of this very highly unstable electrocardiogram and repolarization defect that might produce certainly some arrhythmias and producing sudden death. So when we're dealing with the long QT, we have the long QT3, which is the one affecting the sodium channel, but then we have the 1 and 2 that affect the potassium channel. So the result at the end is the same by different mechanism. The result is that the repolarization is prolonged, so the QT interval is very much prolonged, and at the end, ventricular arrhythmias, sudden death can occur because of this gradient between different parts of the heart. Also, we described in the year 2000 the short QT interval, the short QT syndrome. We saw these patients, these first initial patients in the year 2000, especially this one here, that was a lady, 25-year-old. Familial form. Here you have some families with the short QT syndrome. Look at these very short QT intervals, very tall T waves, and very short QTs in families with sudden cardiac death. So probably this is the most malignant of all the channelopathies because of the very short QT interval. There is a huge window of vulnerability in these patients, and any arrhythmia, any extrasystole might produce ventricular fibrillation and sudden death. That's why probably there are very few patients described with the short QT syndrome all over the world, probably because they are dead. This is a polymorphic, bidirectional ventricular tachycardia, and this is specific from a condition called the catecholaminergic polymorphic VT. Again, a familial disease, genetically determined disease produced by a mutation in the ryanodine channel. The ryanodine channel is the channel that regulates the flux of calcium inside the cell. And during mental or physical stress, the flux of calcium increases. If the patient has a mutation in the ryanodine, this flux cannot occur, and there is an accumulation of the intracardiac calcium, and this produces an intoxication of the cell, and finally produce this type of arrhythmias that you see here appear during a stress test or mental stress test. This is the ryanodine channel and how the calcium accumulates inside the cell and produces this type of arrhythmias. Finally, the last situation described is what is called the malignant early repolarization, which occurs in patients having this abnormality at the end of the QRS complex, like an early repolarization that in some cases might be responsible for the occurrence of ventricular fibrillation. In some patients, there is an overlap between this early malignant early repolarization and Brugada syndrome, and still it has cases. But we know, and you know as emergency physicians, specialists, that time is what counts. So not everybody can be identified and can have an ICD implanted. The majority of patients that are at risk for sudden cardiac death do not have an ICD implanted because they have not been recognized. And we know that every minute that we have 10% less chances of surviving. So we need early defibrillation, and early defibrillation requires, of course, very good emergency systems, but also we need public access defibrillation that might allow for the general public to use these devices and to treat the patient waiting for the emergency system to arrive. There is a study in Japan that compares the number of public defibrillators installed in the countries and the number of patients that are shocked when they have a cardiac arrest. And of course, the more devices you have in the street, the more probability that you will be shocked by a bystander if you have a cardiac arrest. And this is my last slide. This is the number of deaths in car accidents in Spain all over the last years. And you see that they did a very good job, because you see that from the 60s we had an increase maximum in 1989, and since then the decrease is dramatical. So they did a lot.
Thank you very much for this great presentation. I think we can take the question, the last. Yeah, okay. Okay, thank you very much. We will take the question later. Okay. Yes. Now I want to invite the second speaker, Dr. Hikmet Anvarov, about aorta dissection.
Thank you very much. Herkese merhaba. So it's a really great honor to me to be here with you again. And as I've taught you this morning, the main focus in our hospital in Uzbekistan is on the ascending and descending thoracic aorta. Yep. Closer. Okay. Is it good now? Thank you. So some protocol things, I have nothing to declare, only I would like just to stress the contribution of my angio and cardiovascular department in designing these slides. So the dissections of aortic aneurysm is, as you know, all the condition characterized by a rupture of the inner wall of the artery intima with the formation of the false passage for the blood. And about 50% of patients with untreated aortic dissection will die within 2 days, maybe, as a risk of death within the first hour. For acute aortic dissection is about 1%. So time matters. In large medical study, including almost 1,000 patients with aortic dissection, and then we underwent for the surgical interventions, because the closed transcutaneous interventions has been described on the morning sessions. I would like just to stop more on the surgical ones. So 2 of these 6 patients had concomitant ischemic heart disease. In one case, we obtained grade 3 of aortic valve insufficiency, and in one patient also the intimal tear was located on the proximal part of the aortic arch. So all surgeries were performed using the method of the in the stopped heart or the own pump with the artificial blood circulation. Patients with ascending aorta and more than 50% in aorta arch. In type B, the presence of the complications mortality is the same almost, and the perioperative mortality is in between the one third and half of the patients. And other types of the surgery in ascending aorta
So this is my hometown of Cape Town, and I work at New Somerset Hospital, which was actually the first hospital built in South Africa, purpose-built, and was actually the first teaching hospital of the university in South Africa. It is positioned in the waterfront, and so it's a really difficult place to work. But when it was first brought about, it didn't quite look the same. And this was when they were still constructing it back in 1806. But let's talk about this afternoon. Now, it's an interesting topic, and I must admit, I have to declare that I was a substitute. It was a topic that one of our esteemed colleagues had chosen, and he was unable to make it. And I must admit it was a very interesting topic. And so I'm literally hoping that whilst I know Prof. Kande is a great fan of soccer, I'm really hoping that I don't score an own goal when I go through this topic. And what we're going to be looking at this afternoon is the what if. We're going to be looking at the what if our gold standard of managing patients is not available. And I hate what if scenarios, but it's something that we do need to plan for. Because unfortunately, we don't all work in scenarios that are often portrayed in Hollywood. I have never been in the situation where I have been able to park my high-heeled shoes under a bed, or where martinis are brought to me in an on-call room. But the one thing that Hollywood has shown is that in a golden standard environment, anything can be done. Now, I'd like to ask a question. If I look around the room and I ask the question, who here has access to PCI in their facilities? Can I ask you to raise your hands? Hold them up high. Okay, so it's probably about 5% of people in the room. Can I ask you to keep, for those who put your hands up, keep them up for me? Nice and high, wave them. I'm old. Individuals, it can certainly save lives. Now, if we think about the indications for thrombolysis, there are many applications. Some of them apply to acute cardiological emergencies, but there are many others that apply. So looking at the management of acute stroke, for instance, or for pulmonary embolism, or looking at peripheral vascular matters. But if we're looking at it specifically with regards to cardiological emergencies, they tend to become far more narrowed. So if we think about the concept of the acute coronary syndromes being a scale or a realm, a continuum, where it starts with something as simple as angina pectoris on the one side, it then progresses from angina, it will progress onto unstable angina. We'll then end up looking at something like a non-ST elevation myocardial infarction. And there we can make true interventions with regards to thrombolysis. We're looking at your true STEMIs. And so it really is a very small subgroup. That very small subgroup of the acute coronary syndromes that can, in fact, be thrombolized. But now the problem that we often run into in these scenarios is that we use it as our base therapy. But if we are not able to access it for our patients, we start getting ourselves into a bit of a quandary. Because as you're aware in medicine, it's never as simple as a yes or a no. Because if we look at the things like the contraindications, and if there are absolute contraindications, that makes a lot of sense. And you'll see contraindications listed on thrombolytic checklists in many organizations and published in many journals, etc. Those are fairly finite. Those we can accept. The ones that pose quite a difficult thing for us are the relative contraindications. Because here we are needing to apply our minds and balance risk. Balance the risk of an event occurring from the therapy that we are instituting versus the risk of a patient having a worse outcome from their primary pathology. And what it really does is that it ends up being a yes, a no, or a maybe. And it's the maybe group that gets us into a quandary. Because our decision making isn't binary. Our decision making often in emergency medicine is based on a lot of input with regards to how much information we've got at the time. And this can lead us to a vicious circle. We've got a patient who needs to be thrombolized, but meets a criterion that would be a contraindication. If we don't have access to PCI, what do we do? And if we look at all of the treatment protocols that have been published, it starts primary PCI is really the way to go. If you can't do that, then thrombolize. But now if you can't thrombolize, those patients should be going for PCI, but that's not available. And we end up getting ourselves into quite a vicious circle. I'm going to try and simplify this a little bit. And it's because I tend to operate best at 3 a.m. and when I'm operating at 3 a.m., I need to have things simple. So you've diagnosed a true ST elevation myocardial infarct. You ask yourself, do I have PCI available? And the 20 or 30 people in the room that have got PCI at their facility and have got easy access to it round the clock, that's the route that they will go. They will say to themselves, that's great, let's say yes, we've got PCI and we're going to proceed with PCI, and we know that that does have the greatest, better outcomes. So that's a green, that's good. The difficulty comes is that of difficulty. The green is the easy, the red is the easy. The difficult one is where we as clinicians are having to balance risk. Balancing the risk of an adverse outcome from our therapy versus the risk of an adverse outcome from the original pathology. And we can go round and round and round on ourselves trying to find a solution. But we know that in emergency medicine, there is something worse than a bad decision, and that is no decision. And that's often where we run ourselves into difficulties, that we're needing to make a decision with limited information at the time. And now there are a host of medical interventions which I'm not going to be going into here. We can look at the antithrombotic therapies, the good old aspirin, to try and stop that clot getting any bigger or propagating elsewhere. We can look at other medical therapies in an attempt to try and limit the damage, or if there has been damage, to try and improve the outcome. But it all comes down to that balancing of risk. Now, in the international session earlier this morning, Eric Review spoke about the pressure keg of the emergency department, and he very kindly put my head in a pressure cooker. And so, with tribute to Eric Review, who presented earlier today, I think we need to take an approach that I'm going to give his nomenclature. We need to evaluate the risk, the indications, and the contraindications. So we need to do an ERIC. And if you think about it, we're reviewing those factors, and we can do an ERIC review, or rather, an ERIC review. We need to evaluate the patient, evaluate the risk, and then make a decision. And it needs to be timeous. The longer we wait, the greater the pathology. The maybe group is the most difficult one that we have to manage. It is non-binary. We take risk ourselves, but at the end of the day, the patient takes the ultimate risk. Thank you very much.
Thank you very much. Baie dankie.
Dis 'n groot plesier, baie dankie.
Yes, thank you very much. I think we have time for the question or comment. Any question or comment for all speakers? Okay, we can start from Emre. We have question.
Hello, my name is Emre Atish from Karabük University. I have a question for Professor Brugada. Before your presentation, Professor Brugada, we had a patient who suffered long QT, and after we analyzed the ECG, we found that ECG axis was changing constantly. Is it a common sign?
Sorry, I can't get it. It's not the sound again. I'm getting close.
It's a personal consult.
Yes. I'm sorry. Before your presentation, we see a patient who had long QT and breathing attacks, and after we took the ECG, that the ECG axis constantly changing. Is it a sign of the long QT channelopathies, or is it a bizarre thing?
What was the sign? What the?
Axis, ECG axis changing constantly.
Oh, the axis. Yes. Okay. Sorry, I'm sorry for that. No, the T wave.
Patients must underwent to the ICD replacement before discharge, or can it be delayed?
Proper, got it.
Okay, so the first thing, we have to make sure that he has a Brugada. That's the first thing, okay? Why I say that? Because there are many patients that do have what we call a type 2 or type 3 ECG and not a type 1. And this should not be classified as Brugada. This is just an ECG which is suspicious, but it's not diagnostic, okay? So the first thing is that you need the type 1 ECG to make the diagnosis of Brugada. If the patient has a cardiogenic syndrome, if the patient has had a cardiac arrest and has been recovered, of course, you have to do whatever you have to do, and probably the patient should be on a defibrillator before it leaves the hospital. If the patient has a cardiogenic syncope, so syncope which is clearly cardiogenic with no prodromes, and you have a type 1 ECG, probably this is a patient that should receive an ICD. But be careful, because this is the minority of patients. The majority of patients do have a syncope, or do have a chest pain, or do have palpitations, and then they are diagnosed because they have a type 2 or type 3. Be careful. This is not yet a Brugada syndrome. This is not yet something that you have to treat as a Brugada. You have to do the test. Sometimes you have to do pharmacological tests to see whether you get the type 1 or not. And in our hands, you will always do an electrophysiological study to make sure that the patient is inducible before implanting the patient. You know that this is controversial in different departments, but we always do electrophysiological study.
If I could just, it pleases me greatly that you've got access in so many of your facilities to PCI. It's certainly not like that in other parts of the world, where we find that healthcare is very stratified, and cardiology, for instance, in the system that I work in, is considered a super specialty, and it's housed at the tertiary level hospitals. So it is a very small minority that will have primary PCI. And it's not only with regards to getting the patient to, and so if I look in working in the metropolis of Cape Town, we should be able to get a patient to a PCI suite within the necessary timeframes. The difficulty is that we've got large rural areas with long distances, and getting a patient to those facilities becomes problematic. I previously worked at Krithani Baragwanath Hospital, which is in a township called Soweto, a very large tertiary academic hospital, but with a cardiology department that I used to have to pull out of the emergency department because they would come hunting for patients to take to PCI. And what it meant is that none of my residents ever learned how to thrombolize because the cardiologists were so active, which is, it's not a complaint, it's great for the patients, but when I move to, and our residents go to other places, they've never had the exposure to the difficulties that thrombolysis can have. And it's easy when it's a true yes or a true no, that's easy. It's making that maybe call, balancing the risk of the relative contraindications versus the risk of the patient actually dying from the myocardial infarct. And also the difficulties of which thrombolytic to choose. Do you go a fibrinolytic or a thrombolytic, or what is going to be best for the patient? It also comes down to finances. In my facility, we have limited access to the true alteplase or any of the TPIs, but we've got free access to streptokinase. And so it becomes that difficult scenario of not only deciding whether the patient should get thrombolized or not, but then which agent to do it with. And I think it thrills me that you've got such free access. May I ask just to sign, who here has thrombolized myocardial infarct? Maybe that was a better question to have asked.
Okay, thank you, Roger.
Okay.
Any another question or comment? Yes, Dr. Ayman, please.
Okay. Thanks, Dr. Borogada, for this excellent presentation. Do you know sudden cardiac death is a disaster, actually, and it's common in poor country like South Asian. Do you have any recommendation to have a screening plan, for example, in the school, for the student to screen for ECG to pick up who has the channelopathy, and is this any patient who has channelopathy, the ECG finding, it's present since birth or it changed with the age? From this, we can know what age we can screen if it is possible. Thank you.
Thank you. That's a very good question. That's one of my fights with administration and politicians, is that everybody should have at least one ECG performed during lifetime. I'm a teacher, professor in the university, and I always ask my people in the room, I will say how many they are, 22, 23 years old, my students, and I always ask them, how many of you have ever had an ECG? And it's always less than 50%. Just like hypertrophic cardiomyopathy, that the abnormal ECG is only visible at a certain age when the heart is already big enough. It's true that you might miss some patients with some conditions before that, but normally if this is a patient with a genetic disease, normally you have some suspicion in the family, and then of course you do the ECG. But as a general screening, I think 14 is a good age. If you only have one valve, you only have one in your life, I would say 14 If I have 10, then I would say at 2, at 10, at 20. But if you only have one valve, I would say 14 is a good age. Here, whatever. So it's about between 3 and 4 ECGs per year or patients per year that has something that should be followed. Of course, we found Parkinson-White, which is asymptomatic. We found some long QT. We found some suspicion of cardiac hypertrophy, or patients that do have a lot of extrasystoles, ventricular extrasystoles, and then you have to follow them. We had one with a suspicion of how you call that, an abnormal coronary artery that we could suspect on the ECG, and it had to be operated, so we found things.
If you take those numbers and extrapolate them to a country's population, those become huge.
Sure.
And those are numbers of lives that could be saved.
Yeah, but if you do that, it is like, why should you not do that once?
Ortam. Çok teşekkür ediyorum. Burada bize verdiğiniz destek, kongrenin bir parçası olmak, burada bulunmak, hepsi her şekilde bize güç veriyor. İşte bu güç veren şeylerden birisi de uydu sempozyumlarımız. Bugün kardiyolojiyle başladık, kardiyolojiyle devam edeceğiz. Biliyorsunuz akut koroner sendromlar acil tıbbın en önemli kısımlarından birini oluşturuyor ve bizim uzun dönemde baktığımız acil vakalarında büyük oran kardiyolojik aciller olabiliyor. Yani %20'nin üzerinde, %25'in üzerinde gerçek acil vakalar için söylüyorum. Kardiyolojik aciller oluyor ve bunlara müdahale ederken çok daha dikkatli olmamız lazım. Çünkü gerçekten iyi tedavi, iyi sonuç. Yanlış, eksik tedavi, kötü sonuç çok belirgin olan bir hasta grubu. İşte bu önemli sendromda çok önemli bir tedavi, eski bir dostu
Daha fazla adım olsun diye biraz uzağa oturdum. Sahneye çıkmam zaman aldı. O arada adımlarımı da saymaya devam ediyorum. Ben kazanacağım inşallah diyorum. İndirdiniz mi uygulamayı? Evet, Başar Hocam zaten neredeyse benim anlatacaklarımı anlatıp bitirdi. Ben de size yine de kısa etkili nitratlarla, Başar Hocam'ın dediği gibi o eski dostla ilgili bir şeyler söylemek istiyorum. Yani çağları deviren, çağları yıkan, yeni çağ açan, orta çağın karanlığını sona erdiren kara barutun icadından sonraki en önemli kimyasal icat, ilk kullanışlı patlayıcı olarak icat edilmiş bir madde, gliseril trinitrat veya trinitrogliserin dediğimiz. Epey bir zaman geçtikten sonra daha birkaç sene önce Beyrut'ta yaşadığımız o kanlı patlamanın sebebinin de yine nitrogliserin olduğunu söyleyip insanoğlunun bu patlayıcı icadının, bu büyük keşfinin nasıl sağlığımıza faydalı bir şeye döndüğüne geçmek istiyorum. İlk kez William Merrill tarafından 1878 yılında anjina krizlerini tedavi etmek için kullanıldı ve aynı yılda Merrill bunu yayınladı, duyurdu. 1896'da ölümünden hemen önce de Nobel bir arkadaşına yazdığı mektupta, ki mektubu görüyorsunuz, orijinal halinin fotoğrafını da buldum. Dahilen kullanmam için bana nitrogliserin reçete edilmiş olması kaderin bir cilvesi anlamına gelen bir arkadaşına mektup yazıyor. Çünkü bu olaydan, özellikle de kardeşinin ölmesinden zaten çok etkilenmiştir Nobel. Nobel Barış Ödülü'nün de bu yüzden konulduğu söylenir. İnsanoğlunun bu patlayıcı icadı 130 yıl süren, Başar Hocam'ın söylediği gibi çok anjinadaki, daha doğrusu akut koroner sendromlardaki yolculuğumuzda Başar Hocam zaten ufak bir giriş yaparak başladı. Bu konudaki en son kılavuzdan aldığım bir cümle ile ben de sunumun en can alıcı bölümüne başlamak istiyorum. Nitratlar yalnızca arterleri ve arteriyolleri genişletmekle kalmayıp aynı zamanda seçici venöz dilatasyonunu da indükledikleri için hem art yükü hem de ön yükü azaltan benzersiz vazodilatatörlerdir diyor. En son 2020'de yayınlanan Avrupa Kalp Cemiyeti'nin kılavuzunda, akut koroner sendrom kılavuzunda. Bu özelliklerini de ve çok kullanışlı bir preparat, farklı farmakolojik şekillere girme gliserin kullanımı o kadar fazla etki eder. O kadar çok etki eder. Burada erken kullanımın altını çizmek istiyorum. Ne kadar erken başlanabilirse, bu erkenlik saniyelerle, dakikalarla ölçülen bir erkenlik düzeyi. Onu saniyeleri, dakikaları geçtiğiniz zaman da günler içerisinde başlanabilmesi, mesela stabil anjinada bir an evvel reçete ediliyor olabilmesi çok çok önemli. Eskiden kullanıldığı, artık kullanılmadığı bir yer var, güncel kılavuzların vurgu yaptığı. O da tanı amaçlı kullanımı. Eskiden göğüs ağrısının tipik vasfını değerlendirmek için nitrogliserin verilip, eğer nitrogliserine cevap veriyorsa bu ağrının aslında belli. Translingual spreyde gördüğünüz gibi doz 400 mikrogram sprey 1-2 metreden puflanacak şekilde 5 dakikada bir tekrarlanabilecek şekilde ağrı iyileşinceye kadar verilebilir. Sublingual sprey için söylüyorum. Acildeki önemli kullanım alanlarından bir tanesi de acilin yine mayor hasta gruplarından birinde akut hipertansif kalp yetmezliği ve pulmoner ödemde tabii ki. Bildiğiniz gibi akut hipertansif tedavi ve pulmoner ödem, akut hiperler. Evet, peki aort diseksiyonu ve anevrizması yine mayor kardiyaklarımızdan, korkulu kardiyak hadiselerimizden bir tanesi acil servis için. Biliyorsunuz tipik olarak tip A ascendant ve tip B descendant diseksiyonlar başlıca diseksiyon tiplerimiz. Tip A tamamen cerrahi bir diseksiyon tipi ama tip B'de başlangıçta süreç medikal olarak yönetilebilir. İşte bu medikal tedavi hasarlı aort duvarındaki kan basıncını azaltmaya ve hemodinamik stabiliteyi sağlama amacına yönelik olacağı için burada bir vazodilatatörün işimize yarayabileceğini kabaca tahmin edebiliriz. Bu guideline'da aort diseksiyonu ile ilgili guideline'da önceliğin labetalol ve ezmalol gibi beta blokerlerde olduğunu, çünkü aynı zamanda derlemeye yayınlıyorlar. Bu özelliği açısından diğer tokolitiklerden daha üstün değil. Fakat nitrogliserinin yan etkileri, olumsuz etkileri daha az olduğu için yine de kullanılabileceği yönünde kafamızda bir işaret oluşuyor. Burada gördüğünüzde ne yaptık? Dozlarla devam ederken. Tabii ki.
Evet, alttakinden.
Evet, yanlış yerde kaldığım için. Burada da dozlarını, eklemsi ve preeklemsideki dozlarını görüyoruz. Son olarak acil serviste hipertansif inmelerde, ensefalopatide ve sempatik krizlerde acaba kullanılabilir mi? Ne derece yeri var? Sonuç olarak ben şunu söyleyebilirim. Birçok farmakolojik molekülün aksine zaman geçtikçe modası geçeceğine, değerden düşeceğine, değer kazanan 130 yıldan beri devam eden kullanımımızda olan sarsılmaz bir yeri olan bir molekülden bahsediyoruz. Ve bu molekül sublingual sprey formuyla kolay taşınır, çok çabuk elde edilir. Yanınızda taşıyabileceğiniz, o anda yanınızda olabilen bir form halinde çok özel bir kullanım alanı sunar size diyorum. Ve çok teşekkür ediyorum.
Evet, çok teşekkür ederiz güzel sunum için. Tabii konu hepimizi ilgilendiren çok önemli bir konu. Çünkü hepimiz kullanıyoruz nitratları. Hatta bir ara son slaytlardan nitrat hipertansif ensefalopatide de kullanmaya başlandı tekrar diye kafam karıştı. Sonra yaptık, yani hızla değişiyor, bir kullanıyoruz bir kullanmıyoruz. Ama özellikle sprey formu bu konu daha gündemimize geldi. Biz de bunu anlatalım istedik. Burada şimdi yönetici pozisyonda hocalarımız var, dekanlarımız burada. Hem Mehmet hocamız hem de Ayhan hoca da geldi, sağ olsunlar. Şimdi biz bunların acil servislerde kullanımını O yüzden direkt onlara şunu kullanın demeden önce bizim acilde önce bir şeyimiz olsun da kullanım alanımız olsun. Ondan sonra oluşturalım diye istiyoruz ama her halükarda sprey kullanımının avantajlı olduğunu görüyoruz. Nitratların kullanımının herkesin bir deneyimi var. IV nitrogliserin kullanmayan yoktur aramızda acilci olduğumuz için. Bir de böyle alternatif formların çıkması çok iyi. Soru katkı alabiliriz salondan. Pek soru katkı yoksa biz soralım falan diyormuşum. O zaman çekilişi getirin bari. Çekiliş yok mu? Kimse sormuyor. Çekiliş yapalım. Nitratlar tanıdık. Onu da söyledim. Bak bu soruya ödül ver. Trinitrin de hatırladın mı Mehmet hocam? O sarı kutu. Bir de o vardı. Yaşlı amca alıyordu böyle göğsüne alıp iyileşiyordu hemen.
Size hediye ediyorum.
Teşekkür ederim hocam. Sağ olun.
Mecit hocam, yanlış anlamadıysam siz hediye ediyorsunuz. Bizi karıştırmıyorsunuz değil mi? Tamam. Tamam. Tamam. Mecit hoca hediye ediyor. Tamam. Ona göre. Tamam, peki. Teşekkürler arkadaşlar. Şimdi arkadaşlar bugün performansınız için teşekkür ediyorum. Burada olduğunuz için teşekkür ediyorum. Daha fazla vaktinizi almayalım. Diğer şeye geçelim. Ama bakın bugün Avustralya'dan gelen bir konuğumuz var. Kaç saatte geliniyor? En uzak uçuş herhalde Yeni Zelanda ve Avustralya. Yani lütfen arkadaşlarımız, özellikle buradaki arkadaşlar öyle hani bu ne demek istediğimi hemen anlıyorsunuz. Bu misafirlerimize bilimsel saygımızı gösterelim. Ve burada onları dinlemeye çalışalım. Gerçekten elimizden geldiğini biliyorum. Bu çalışkan bir ekip var. Her tarafa koşturuyorsunuz. Bildiriler, A salonu, B salonu. Bir de diğer ekip var. Ona da bir o havuza, bir diğer havuza, bir şunun da tadına bakalım. Bir de şuraya bakalım. Ama ne yapalım? Biz böyleyiz işte. Onlar öyle, biz böyle. Bu taraf onun. Biz eninde sonunda kazanan çalışan olur diye düşünüyoruz. Onlar da yadırgamıyoruz. Yani ne yapsınlar onlar?
Department and Poison Center for taking any kind of an help. So with this, I thank you all very much for giving me an opportunity, and I welcome you all to MCON 2022, which will be happening from November 24th to 27th in India, in Trivandrum. It's a God's own country, it's called us. So welcome you all. Thank you very much.
Thank you, Doctor, for interesting lecture. Thank you.
Thank you.
Next speaker will be by Dr. Ahmed Dhoum. Dr. Ahmed is a Lieutenant Colonel in the Royal Medical Services, Emergency Consultant, European and France, Emergency Fellowship Lewis, Pasteur University, ICU and Critical Care Training, Basket University, Director of NIMSIC. He will speak about the role of the NIMSIC Training Center at Royal Medical Services to improve the quality of the emergency medicine. From Jordan. Thank you, Doctor.
Good afternoon. It gives me a great pleasure to be among you. Thank you, IBAD colleagues, for invitation. And thank you, Professor Bashar, also, and the organizing committee. It's give me honor and great to introduce my organization, Jordanian Royal Medical Services in a few slides. As you see, we have around 24,000 Royal Medical Service personnel, 11 or 12 institute and military hospitals, 4 military hospitals. Our Royal Medical Service mission, it's multi-focus organization working under the mission of providing, improving and developing efficient by optimal using of available resources. As I informed, the RMS Jordanian rules, military rule, national rule, international humanitarian rule, crisis and disaster management. Our Royal Medical Service structure, we have around 12 hospitals from north to south, east to west, 6 field hospital, 4 military battalion hospital. This is our King Hussein Medical City, the largest and most disciplinary medical institution in Jordan. It contains around 6 special hospitals and preventive medicine, also nuclear medicine and ophthalmology center. The capacity of beds around 1,400 beds. Also, we have 4 military academy, Prince Muna Royal Medical Service College and Institute Biomedical and my National Emergency Medical Service Training Center. With pleasure to share with you our experience. I am the director of the National Emergency Medical Service Educational Center at the Royal Medical Services, and how we have the courses to increase the efficiency for emergency physicians. Our vision, excellence and leadership nationally, regionally and globally. Our mission to provide state-of-art training program that keep evidence-based guidelines through optimal use of available resources, including well-qualified instructors, modern technology, and appropriate setting. In 2009, our training center, NIMSIC, was accredited by American Heart Association, and we started to conduct basic life support, advanced cardiac life support, pediatric advanced life support, pediatric emergency recognition and stabilization, in addition of neonatal station program. And also our training center, at NIMSIC has ability to conduct different type of courses to cover all target group in the community. It's not also for doctors, for nurses, for midwives, across designed also for non-healthcare providers. As the models of emergency medicine, we know there is 2 models of emergency medicines, stay and play philosophy or scoop and run. So that in our center, we started to have both of them, to have a courses pre-hospital and also in hospital. It is our accreditation from training center. This slide, it gives us information how many participants in our training center. It is not only for emergency physician, but also GPs. And what we are did that the all medical or Royal Medical Service doctors, they didn't have promotion from rank to rank to rank, or from, for example, specialist to senior specialist or consultant if he didn't pass some of these courses. As you see, basic life support around 150 per 1 year. We have advanced cardiac life support, PULSE, PEERS for pediatrics, NRP also for program of neonatal, emergency triage, also basic life support, advanced life support for doctors. They are working as pediatrician or gynecologist, advanced trauma life support, emergency or at the field. The importance of courses that conducted at our training center, that they provide conscious of easy to remember framework for the medical personnel who involved in the courses. When they come across with any medical emergency, they will be able for optimal using of available resources and teamwork dynamics. Others courses we have like Diploma of Emergency, Neonatal Triage also, and tactical courses for non-medical health provider. This is the average of our courses during the
Thank you for the opportunity. So I'm going to talk about the journey of pre-hospital care in India since a decade. And the good news is I'm going to talk within 10 minutes. And I'm going to keep my lecture short as possible. Well, not this short. So who said the thank you slide has to be only in the end? So I take this time to thank the organizers for giving us the kind of opportunity. Professor the President, EPAT, and all his team, our SEMI team, and all the organizers for giving us this wonderful opportunity to speak on the platform, which deserves this kind of topic. Is this topic important? So most of my presentation will have this slide as a mandate, where I'll usually engage the participants about whether the pre-hospital or the topic what I'm going to talk is important. So here, the pre-hospital care, probably after some slides you'll understand whether the pre-hospital care is important or not. So these are all some of the statistics across the world, where we see 80% of the deaths occur outside the hospital. So please note that it is not the deaths which is happening only inside the hospital. In a developed nation or a developing nation or in the Western countries, we come across more deaths outside the hospital. And this is a statistics which was taken 5 years before the COVID. So it is still rising. Right, so this is a trauma statistics. This is our country, India. Most of you all know. So by the time I was talking, I was talking for the past 2 minutes, a death would have happened by now. Death related to trauma and other medical emergencies would have happened. So every 2 minutes a death is happening because of trauma or related to it. And these are the various state-wise representation of deaths which is happening inside our country. So how do we prevent or how do we reduce the chances? So we need to improve the pre-hospital care. As I said, the first peak have to come down because of the good pre-hospital care. The second peak, we need to improve the knowledge of our emergency physician, improve the basic structure, and improve their skills with regards to treating those critically ill patients, and you need to form a good team in our critical care units and the wards to reduce the third peak. Whether we have done it is not a one-day process, it is a gradual process. And so as it has been mentioned in AHA's chain of survival, you need to follow this interlinked chain of survival without any break. Any break in this interlinked chains reduces the chance of survival for patients. So now you guys tell me, based on the statistics, is this topic important? The pre-hospital care, what we are doing for the past 10 years? Definitely yes. So I'm going to talk a little bit about the journey of our pre-hospital care for the past 10 years in our country. And I'm not going to include, I'm unable to include all the people's work here. So we have included maximum what we could do for this objective. In short, the short objective would be to save lives. So a typical scenario on Indian roads, a road traffic accident. So what do you think people would be doing there? Or what do you think a healthcare professional would be doing there? A good summation, ADMAX even now would try to ask for an ambulance, to try to call for an ambulance. Why they are not coming forward to help these victims? Of course, there are places where people are helping and people are doing resuscitation. People are trying to help each other, but not everywhere it is happening, particularly not only in our country, almost all the countries. Why? when we assess the reasons, we found that it is lack of awareness, because people are scared when somebody is fallen, collapsed, and with a lot of blood, and somebody screaming or screaming next to the patient. Somebody has fallen unconscious because of various reasons. They do not know what they exactly need to do. So it is lack of awareness, fear about the loss. People think that most of the time the bystanders are also harassed after the incident, and they fear about the loss. We don't have a good communication system. The transport ambulances are all short, because I'm from a country where about 1.4 billion people are there in that single country, as Dr. Srinath was telling. So we and China together large volume, high frequency, large volume, low frequency, and as well as low volume, high frequency training is what we aimed at to create awareness to the general public as well as to the other people. So this is, ladies and gentlemen, this is a red letter day for throughout all the emergency physicians in India. On April 7, 2016, we trained about 50,000 people. Can you all imagine? We trained about 50,000 people in CPR, and it has been in the Guinness World Book of Records. We as a society have participated, and we have done it in the institution where I was working. So we identified the end users, the school, college students, police, fire, and district officials, and we started training for them too, which has been happening for the past, from the time we established as a society in emergency medicine. Each and every physician is doing their part to do the same, and we are also doing the same. So this is the present hospital where I was working. Of course, every hospital, every emergency physician are donating AEDs to make AEDs available in different parts of India, and we are training people to the first aid thing. And this is the integration of first aid and school curriculum. Most of the emergency physicians across the world go to the school, train them in CPR, and then come back. Instead, what we have made in our group is, what we have made in our places, we have integrated. So these two, Dr. Srinath and Dr. Sarana Kumar, are the program directors who developed the group of people and organized the team to teach each and every medical colleges. So we are doing this for the past 2 years. We have trained about 15 medical colleges in across Tamil Nadu. As it is again like an advanced trauma life support 3-day course with interactive lectures, hands-on training, Kahoot online quizzes, and pre-test and post-test. On the completion, they will be given a certificate. So we didn't do just the course, we assessed the outcomes also. As the graphs clearly mentioned, the knowledge post this NTLS course was very high to the participants, and this is what exactly we wanted at the end. So when it comes to the ambulances, of course, the drone ambulance is coming into the picture, which I'll be talking in the newer advances. We have road ambulances. Of course, we have pioneered the air ambulances across India, and we have separate teams to take care of air services as on date. And we have what is called as bike ambulances, which we introduced a decade before in our country, to assess the narrow roads to help the victim as soon as possible. So of course, we cannot be expecting everyone to be a good Samaritan. So we have, approached the government to look after a few guidelines to help the victims. So in that way, we have suggested that, the bystander, so there is no I in teamwork, right? Everyone can be a superhero if they combine together when it comes to emergency medicine. Once again, thank you for the opportunity given to me.
Thanks for all speakers at this session, and it was interesting lectures, and they have enough time to listen to your comments or if you have any questions to them.
Thank you very much. This is Dr. Behçet from Istanbul. Each speech was really very nice. Great. Thank you to everybody, to all speakers. Just my first question to Dr. Srinath. Can we hope for new antidotes in toxicology? This is for you, infection especially. And for the Dr. Ahmed, is it necessary to have all these trainings in Jordan? Is it must? I just want to learn it. Then for the last one for Raja, thank you very much for your sharings. Just firstly, I want to appreciate and say congratulations to the Savitri University in India for their basic life support and first care that they teach to the community. But the photo should be specific to India. It must be really very difficult to teach basic life support or first care to 1,000 people in stadiums. But it is specific to India. As you mentioned, over 18% of the deaths happen in also hospitals. So I'm really agreeing with you. Your question is really very important, definitely, very important. As you mentioned about the dreams, I think all the reality should be given from the dreams. You know, there is a philosopher in your country, one of your previous presidents, he says, the dream is not the thing that you saw while in your sleep. The dream is thing that doesn't make you to sleep. So that's why I want to appreciate you. You are teaching the community about the first care, first aid in India. This is one of my dreams. I just have a suggestion. Can we achieve it? To teach all the students graduate from the university, and it could be must to teach the basic life support or first care to all the couple that are going to marriage. Thank you very much.
Second question.
Have become a biggest poisoning in most of the countries today in Asia. So there we have started using the methylene blue, and it has shown much results, and the patient outcome is also good. And regarding the training, what Dr. Rajdari was mentioning, it was a mission which he took it for almost 6 to 7 years. And then he ensured that all the people come together, and it was being done, so that it gave an impact of emergency medicine in the whole country. That is all. Thank you.
Thank you. Thank you, Professor Bahjat, for your nice question. Really, we are share a knowledge. Our technical training department.
We as a society, there's too many, we call them merit badges. It's everyone's another badge. And so philosophically, we believe that all of that training is already incorporated into our residency, so we do not necessarily require each one of these badges, so to speak. So I hope that answered your question. But yes, it's important that we're all doing the same thing. You know, we incorporate ATLS into our training programs. We obviously do ACLS. We do periodic updates for all of our doctors, not just our doctors in training, but our doctors beyond training. And so once they get certified in emergency medicine, you know, every 7 to 10 years, they have to recertify. This used to be a big
It's quite an exciting session. My name is Atar Ali Mohammed. I'm one of the ED physicians from Australia, and I have got Dr. Ahmed Al-Joom with me. So there's a slight change in the program. I think the first session we will be kind of starting with the pediatric ocular trauma by Dr. Hesham Kaftan. Thank you, Dr. Kaftan. So Dr. Kaftan works in the emergency trauma team at the King Hussein Medical Services in Jordan, and he works in the head and neck emergency trauma division.
Next page. Next previous page. Laser. Okay.
Good evening. I'm glad I'm here with you. Our lecture is about the pediatric ocular trauma and emergency. Pediatric ocular trauma is the preventable causes of the visual impairment in the world. Up to 40% of the all injury occur in the person less than 17, especially in the small age. Why it is important? Because as we know, trauma to the eye in the first 6 years is critical because it leads to lazy eye, amblyopia, as we know. So eye injury are leading causes to the visual disability and non-congenital unilateral blindness in children. Very commonly, eye injury occurring during the sport and even when at the home or school, anywhere. Speak fast about the anatomy of the eye. You know, our eyelid, lower eyelid, the cornea, sclera, and the retina and cornea and iris, everything. The most important thing we know about the orbital wall is the lamina papyracea. Lamina papyracea, which is the thinnest bone in the orbital wall. Approach to the eye examination. The history, the details of the mechanism and time of the injury, where, when, how, and with what, chemical or alkaline. Change. First, we ask about the change in the vision, flashes, floaters, or any shadow. Symptom: pain, visual loss, double vision, photophobia, or any other symptom. The eye examination, the vital sign, as we know, is the visual acuity, external eye anatomy, look for trauma, foreign body, or any other. Pupillary response, equal rounded, reactive, full, visual field, extraocular movement. If there's any limitation, we must keep in mind, because there is trauma make me the fracture to the orbital wall, so the entrapment for the muscle. Fundoscopic examination is the last, and levator muscle, and maybe lead to the apoptosis and that canaliculum, the medial canthus. The latter need tubing technique to prevent it before after healing. Check for associated foreign body or globe injury. Treatment: primary closure or delay closure after 12 to 24 hours if a human bite or contaminated wound. Tetanus prophylaxis for all any skin injury. Full thickness, this is a picture like this presented to our emergency. Okay, maybe trauma lead to the subconjunctival hemorrhage. As we know, this is treated with a cold compressor and artificial tears of the symptomatic, and avoid aspirin or NSAIDs and heavy lifting. And this take to 1 or 2 weeks or maybe more to resolve. And maybe trauma lead to corneal or conjunctival foreign body, which is the patients complain of the pain, tearing, photophobia, blepharospasm, and foreign body sensation. We must avert the upper eyelid to look for any hidden foreign body or any entrapment. Treatment: topical anesthesia and remove with the foreign body by the needle or cotton, triangular swab, or topical antibiotic drop or ointment. We must avoid patching in children because it leads to the lazy eye. Like this foreign body, maybe in the upper eyelid, on the inner surface of the upper eyelid, or in the cornea directly. Corneal abrasion ulcer. It's an epithelial defect due to the trauma occurring by the pain. Foreign body sensation, tearing, blepharospasm, and decreased vision. Dramatic response with installation topical anesthesia because it's pain relief. The ulcer could be sterile or contaminated or infected. If you have the upper eyelid, always as foreign body maybe it is the causes of the ulcer. Treatment: lubricant and topical antibiotic and cycloplegic to relieve the pain. Like this ulcer. Orbital anatomy, as we say previous, the most important is lamina papyracea, which is the thinnest point in the orbital bone. Orbital wall anatomy, orbital wall fracture, orbital floor fracture, maybe blowout fracture. The most common, as the floor is the weakest part, the roof of the maxillary sinus, usually due to blunt trauma. Symptom and sign: eyelid swelling, diplopia, restricted eye movement, especially upward, due to entrapment of the muscle. Enophthalmos, hyperesthesia over the cheek. Imaging study: plain X-ray or CT, observation with the tetanus prophylaxis prophylactic antibiotic with a broad spectrum, and nasal decongestion by 2 for 2 weeks. No nose blowing, because this is increase the air. As this picture of the hyphema, blood in the AC. Okay, retrobulbar hemorrhage, as we know, retrobulbar from the most important and cases presented to the emergency can result in the rapid elevation of the orbital pressure because of the orbit is a relatively closed compartment. Untreated orbital compartment syndrome may result in the optic nerve ischemia and irreversible vision loss and less than 90 minutes. This is maybe spontaneous or traumatic. Signs temperature of the globe may be result from the trauma. Full thickness laceration of the globe as a result of the trauma that may be within blunt or penetrating or perforating object. Can be corneal scleral or combined corneal scleral. Symptom: pain, greatly decrease in the vision, diplopia. Sign: low IOP, teardrop pupil, prolapsed iris, hyphema, maybe with normal or high IOP, 360-degree subconjugal hemorrhage all over. Management: if suspected rupture, minimize manipulation of the globe and apply the protective eye shield. CT orbital or brain axial, coronal with thin cut, coronal thin cut to evaluate for the intraocular foreign body. And this is rupture of the eye, like this picture presented to our hospital. Okay. The most important, again, ocular chemical burn. Being irrigation immediately before complete history and examination. We must directly start it by irrigation, especially if alkaline, because alkaline is more detergent than acidic. Alkaline burn are worse than acidic burn. Acidic burn lead to coagulative necrosis, denaturation of the tissue protein, act as a barrier to prevent further diffusion and further penetration for the acid, as battery fluid and chemistry lab solution. Alkaline later. Do before checking VA or hospital or a history or an examination or fluorescein, and recheck pH 5 minutes later in order to be sure that his pH is normalized. After irrigation, check the visual acuity and complete the examination. Treatment: give any ointment like erythromycin 1 to 2 hours with cycloplegic atropine, and may need IOP lowering or steroid. Eye infection in ophthalmic is conjunctivitis within the first month of the life. Common causes is chlamydia, and this is from the cases presented to the emergency because this small baby and her parent is very fair, like chlamydia, trachomatis, and staphylococcus, strep, Neisseria, gonorrhea, and herpes. Sign: purulent gonococcal and or mucopurulent discharge, conjunctiva injected, and eye edema, chemosis. Management: conjunctival scrubbing for gram positive and stain. chlamydia antibiotic test, culture, blood and chocolate agar, and viral culture for treatment with topical antibiotic, eye drop, and or ointment, and guided by the result of the gram and negative. If chlamydia trachomatis, treat with the systemic erythromycin, orbital cellulitis. Picture. Treatment of the cellulitis. Mild preseptal cellulitis, oral antibiotic may be enough. Severe preseptal or orbital cellulitis, you must admit the patient and start on the IV antibiotic with a broad spectrum until the infectious agent is identified. Can add a topical antibiotic ointment. So we must ENT consultate if the sinusitis or mucopurulent, and if the patient is immunocompromised, consider mucormycosis and severe fungal infection with a black Jar's sign in the nose or roof of the mouth. Immediate surgical debridement and antifungal treatment. Thank you for attention.
Thank you. Thank you very much, Dr. Hisham, for your presentation. All the questions, it will be after the finishing of the session. We are, as emergency physician, really we are looking to deal with these cases in ophthalmology. With the pleasure to introduce our next speaker, Major Dr. Arij. She is family medicine specialist, training fellowship in community medicine, master degree, working as representative of infectious disease at the Royal Medical Services. She will talk about public health emergencies in our Royal Medical Services. Please, Dr. Arij.
Good evening, everybody. Thank you, Dr. Ahmed, for introducing me at this sweetie way. And also thanks for organizing committee for kindly invitation to me. And I'm really so happy and proud to be here with you today as a guest speaker. Today I'm going to talk about public health emerging disease, and I will give more details or focus on one disease of it, which is seasonal flu. And really I have chosen really flu, this topic, because I will give more details about influenza, seasonal flu. It's RNA enveloped virus. It's related to family called Orthomyxoviridie. It's very, very, very small. This picture, it's under microscope. It's about 80 to 200 nanometers. We have more than 400 types of viruses, but we will focus mainly on the 3 types, A, B, and C. And about the B and C, we have not genetic mutation over it. More the mutation we can see with the strain A. So also we will focus on the serotype A. About the A, it have something which is called glycoproteins over the surface of the virus, glycoprotein antigens, which is called H and how its mutation or that mutation happen. It through something which is called antigenic shift and drift. What we mean by antigenic drift and shift, at what's the main differences between it. About the antigenic drift, it's a slow change, it's a slow change, and the main difference between the antigenic shift and drift, it's a slow change in the viral genes due to replicating error or random mutations result in the new virus strain, and that's what happened with seasonal flu every year. But about shift, it's rapid and large antigenic change in a virus and requires at least, we need 2 different types or serotypes or strains to combine to form a new viral serotypes. Also, we have another name for it, which is called phenotyping. Now, let's give you some information about seasonal flu. As we know, seasonal flu incubation period about an average from 5 to 7 days, and average about 4 days. We have symptoms appear about 2 days before the patient patient will be infectious to others about 2 days before appearance of signs and symptoms. And about signs and symptoms, all of us are familiar with it, which is general weakness, headache, low back pain, also low-grade fevers, and بالإضافة اللي هي عندنا اللي هي respiratory symptoms such as productive cough. About the treatment of it, as we know, antibiotic is not effective for treat because it's viral, so we use antiviral. And the most important prophylaxis side effects, maybe we have side effects, and we can classify it into local and systematic side effects. Local side effects such as swellings and fevers, and also we have the most dangerous side effects, but also it's very rare, which is anaphylactic shock, and it's need emergency. Not all pathogens have a vaccine. For example, still now malaria, it doesn't have a specific vaccine for it. The benefits outweigh the risk, so vaccines are given to people. We must give it, and also scientists work to make and improve vaccines. We will give more details about the flu vaccine. What's the absolute and relative contraindication for the vaccine who should not get vaccinated? People who have severe allergy to chicken eggs, and because the vaccine is prepared at chicken embryo, anyone who had known allergy to chicken pox, it's absolute contraindicated, so we must take a good history from the patient before give him vaccine. People who had a severe reaction to the vaccine in the past, people who develop Guillain-Barré syndrome after prior dose of the flu vaccines, and people with moderate or severe illness. People with moderate or severe illness, it's not, it's relative contraindication. We will wait until the patient gets well, and after that, give him the vaccine. Adults 50 years of age and older, or children from 6 through 23 months of the age, children younger than 5 years with any of this condition, asthma or one or more episodes of wheezing within past years, the pregnant lady, because as I said, it's life attenuated, injectable, it's safe for pregnant lady at any stage of the pregnancy. She can receive it from the first stage, from the first trimester of the pregnancy. People who have certain long-term health problems, muscle nerve disorders or weakened immune system. Also anyone in close contact with someone whose immune system is so weak because it's, I said, life attenuated and they require care in the protected environment. Also children or adolescents on long-term aspirin treatment. Does the shot cause the flu? It's the most common questions we received from the patient. The answer, no, the flu vaccine doesn't cause the flu. Maybe it causes flu-like symptoms, but it's not a flu. The viruses in the vaccine are weakened, as we said, it's attenuated or killed, inactivated, so the shot and the nasal spray won't cause you to get the flu. The vaccine will prompt your body to develop the antibodies necessary to fight, and it's the mechanism of action, as we said, of the influenza viruses, and a slight reaction to the shot, such as soreness, redness, hotness at the site of the injection, and maybe we have mild muscle or fever may occur. Thank you for listening.
Thank you, Dr. Arich, for your nice lecture. All the questions as I said before, at the end of the session. With the pleasure to introduce our last speaker today, Dr. Attar Ali Mahmoud. He is consultant of emergency medicine, clinical lecturer, University Melbourne, director advanced life support in Australian Station Council, emergency medical service trauma, advanced trauma life support instructor, stream lead clinical service of clinical governments, and also Australian of emergency medicine. He will talk about transformative scenario planning in healthcare.
Next page. Previous page.
Change. It's a diagnostication tool. When we are actually stuck in a situation, it's actually it works. We'll go through that later. So, unfortunately, with the growing demands for the healthcare systems and our limited resources, we are faced with the change management all the time. So when we actually have this systems change, processes change, or whatever that's happening, we either actually faced with this choice. Either we actually accept it, adapt to the situation, or we challenge the situation to change it. Unfortunately, there's not much room to say, I don't want to change, because then perhaps we may not be part of the system anymore. I found this maxim very helpful at times to me. Niebuhr was an American theologist of the 19th century. And he said, Lord, grant me the serenity to accept the things that I cannot change, the courage to change the things I can. Transformative scenario planning. Adam Canlı, he used to work first in the scenario planning division of Royal Dutch Shell Company. So Royal Dutch Shell Company was the 7th largest oil producing company at the time, and they had a division. This division of team would actually write different scenarios. So what would happen? What could happen? What may happen? And they would write these scenarios globally, across regions, governments, political, geopolitical, wars. So what the Australasian College of Emergency Medicine did is, they took Cahan's work, saying it's been applied in societies, it's applied in various big institutions, it's applied in the country transitioning. Why can't we use that in our healthcare? And they developed this changing module, leading change module. And I was fortunate enough to be the part of that module. That led to a second opportunity that we worked on that, to use those kind of principles into my next major project. So conventionally, whenever we are actually talking about change, we actually see, whereas most of the social change the conventional process uses is the horizontal facilitation. In horizontal facilitation, when the organization says we have the right answer, the people say we each have our own answer. We need to agree. And the people say, we each need to keep moving. They say, we'll each find our own way. We each decide for ourselves what we need. We must each put our houses together so that for change to happen. The problem with this is it could be too lateral. Sometimes containing could be quite difficult, because everybody wants to be in Melbourne. So this is kind of a detailed map, and I'd just like to point out, so I work at this place called Ballarat, which is about an hour from northwest of Melbourne, and we are the second largest regional receiving unit. So we were faced the task that we take this region. That's a huge region. Okay, please do not compare Australian population to the size with any European nations, because our population size is a lot smaller than for our geographical areas. So the 4 health services, which is the Ballarat Health Services, was where I'm primarily based, and we were actually had to bring another 3 health services under a single entity of Grampians Health. just a 2020 snapshot that actually when we looked into our service, that was the population in the first column. And then the second column actually talks about how much admission rates that we had. So what are the service challenges we were getting? The Wimmera Health Group, which is our second biggest hospital in there, we almost spend about 10 million for the year on locums. And so we had to form kind of a massive project team. I don't want to dwell into much into that. And I was leading the clinical services and governance structure of this team. So we have to make one governance structure, we have to make one clinical services plan. And there are a lot of factors, a lot of players in this. And the biggest thing what happened, the smaller units felt threatened, saying, oh, we're going to be actually, the big guy is going to come and tell us what to do because they are from a bigger unit. And the other hospital which was struggling, they were just taking any. To bring these people, you need to actually kind of build a very strong container, not a physical container, but it's a form that they feel safe. They can come and tell anything they want. And you have to have some processes developed, how you want to kind of manage these people. You start with having a few people to start a convening team. Don't go more than 10. Probably 10 is a bit useful. And then you want to construct from that 10 members, you want to discuss with them, and you want to have a large team. So what we're going to do, we're actually kind of bringing people together who are influential, insightful, and interested for you listen to them. Let them tell their stories.
Try, Dr. Attar, to finish in 1 minute, please.
Okay, so sorry guys, I have to just kind of, so towards the end, once we actually kind of have listened to the stories, once we have actually found out what's happening, you start building some relations. Unfortunately, I had some couple of good examples, but I have to kind of let it go. So what we do is, then once people have felt comfortable, they share their stories, there is a bit of relationship building up happening. People in the systems, they birth very slow. So really change doesn't happen. You look at these likely scenarios and use two different analogies here. So you want to kind of start kind of a adaptive process. So if this happens, what I need to do? Whereas you look at a transformative process, in transformative process you say, hey, this is the possibility, which one I want? Which one is in my best interest? But once I know which one is my best interest, I want to write that scenario. So it's like, what are my threats?
As usual, Professor Bahjat, please. Please give microphone to Professor.
Thank you very much to all three speakers for their nice speech. I have a question for Dr. Hisham and one for Arish, and a comment for you, Dr. Akhtar Ali Mohammed. To me, in emergency department, the most difficult examination of physical examination of the patient is ocular emergencies. For example, I am working in emergency department since 23 years. 2 years as GP, 4 as residents, and the remaining as physicians. But I'm still afraid to examine a patient with emergency, ocular emergency, because it involves a very small area, and there are so many different disease. So really, as I said, I'm working in EDs since 23 years, but it is a scare for me. Do you have any suggestion for me to be much more better to examine the patient and care and do their management? And please let me finish my question. And one question for Dr. Arish. In your third slide, you mentioned we have 450,000 deaths, annual deaths, and 650 hospitalization. According to this knowledge, the average of the mortality is over 70 for the hospitalized patient. We may mention about it, and changeable. Everybody should be prepared as changeable, change their mind, their skills, practice, and like this. And we may know about our limitation, knowing or aware about the limitation. Nobody is a hero alone. Nobody is here alone. So you shared and philosophy sentence. I want to share one of my. There is a problem. You have a problem, and it needs a solution. If you have a solution, do not wait. Do it immediately. This is the first step. The second, you have problem, but there is no any solutions. There is no.
Estimated from CDC, and the total number of deaths, it's among complicating cases. From complicating cases, not from all the number of of total cases over the world. So it will be less than the world. You have any that else?
No, I think. Do we have time for Dr. Akhtar to share his story? Dr. Ahmed, do we have time for Akhtar to share his story?
Yes.
He has a story.
Thank you. I think one of the things that is, as you said,
Thank you.
Any questions, please? Any more questions? Okay, thank you very much. At the end of the second day of our sessions, we wish you good luck and success. And tomorrow we will meet with another speakers. Professor Bashar, please.
Okay, no. Thank you very much. Okay, time is very very hot, and we have only lotto. Bir çekilişimiz var. They wait for the lotto. Okay. Çekiliş yapıp öyle göndereceğiz.
We have a sweep scare. Sweep scare. There are so many names written in the piece of the paper. And one person, I think Dr. Akhtar is going to get
Take one person, please.
What is the gift, Professor Bashar?
I will say later. Okay, after name.
So it's Apollo Ozan Döndü.
Okay.
Ozan Döndü.
Ozan. Okay, I will extend the gift. Tiran sempozyumunu veya gelecek ilki kongre arasında seçim yap. Kayıt olarak.
Hiç sevinmedin lan.
Teşekkür ederim öncelikle. Gelecek kongreyi seçeyim ben.
Okay, adam bilimsel ya. Tiran gideceğine okay. Choose for the next kongre
another scientific feast with more than 50 associations from more than 40 countries. On this meaningful day, now I would like to invite Professor Paul Kivila, past president of the Acil.
It's affected ourselves, our patients, our families, our communities in a way that none of us could possibly foresee. It's an honor to be here with you today, to be with you, to share ideas once again face to face, without masks and with masks, but here again face to face, which I think is the most important thing. You know, a couple years ago, I always wait for this video and I smile every time because it's always a special video presentation. A couple years ago, I was portrayed as a cowboy. And you know, a cowboy is a good thing. A cowboy is self-sufficient. A cowboy is strong. A cowboy is a leader. And right now, you know, I here with you. Thank you.
Thank you, Paul Kivila, for your opening remarks. Now I would like to invite Professor Srinath Kumar, past president of the Society for Emergency Medicine, India, SEMI.
Srinath Kumar.
Good evening, everybody. It's always a pleasure to be here in Turkey along with Professor Bashar Kanda. There is no words to express tonight that last 2 years how much we missed each other. And then every time when we come here, it's a great experience. It's just not only exchanging our ideas, but meeting the people and getting to know each other. And every year by year, you meet a lot of leaders across the world here in Turkey. It's always blessed to meet the tallest leader in emergency medicine in Turkey. There is no competition. He has come 3 times to our country, and it was always a pleasure to be with him in our country also. Many leaders we have met, many leaders are come, many leaders will go. But what we never forget is emergency medicine, which brings together all of us. I would request Professor Bashar Kanda to come onto the stage to receive a memento from India. And I also request my secretary, Dr. Saravana Kumar, Society for Emergency Medicine, to join and give away this memento, which is very particular. And you can see what it is. It's nothing but we had sent a that is the Society for Emergency Medicine India emblem to NASA, which was been taken all the way to Mars. And there we dedicated this to each and every emergency physician across the world.
Thank you, Surenet Kumar, for your opening remarks. Now, I would like to invite Eric Review, co-chair of the pre-hospital section of USEM, co-chair of the Clinical Practice Committee of IFEM.
Donnez-moi une suite au Ritz, je n'en veux pas. Des bijoux de chez Chanel, je n'en veux pas. Donnez-moi une limousine, j'en ferai quoi? Offrez-moi du personnel, j'en ferai quoi? Un manoir à Neuchâtel, ce n'est pas pour moi. Offrez-moi la tour Eiffel, j'en ferai quoi? Je veux de l'amour, de la joie, de la bonne humeur. Ce n'est pas votre argent qui fera mon bonheur.
Eric Revue! Alkışlarla sahneye davet ediyoruz.
Allons ensemble découvrir ma liberté. Oubliez donc tous vos clichés. Bienvenue dans ma réalité. J'en ai marre de vos bonnes manières. C'est trop pour moi.
Thank you. I didn't have a present, I gave it already to my friend Bashar. 2 years, it's too long. I miss you guys. And just let's have 5 minutes, about why we are here and why we love emergency medicine. This emergency medicine is the most interesting 15 minutes of every specialty. Who has the best story to give? We do. We are the good friends when we have dinners to speak about that. We give lots of funny stories about that. We are always on the front line, always. We are in terrorist attack, in overwave, in COVID. We do have always our EMS system, emergency department, physician and nurse. We are always here. That's why we are. Brazil had Neymar, Argentina had Messi. You had a team. Not anymore. We have a team now, a soccer team. I know that Bashar loves football. You have an excellent team. But you in Turkey, you are the first in the world from emergency department. No one has more than 1,000 to 2,000 patients per day. No countries has got. You have it. So that's the thing. I'm very proud to be here and to learn a lot of you and your experience. One of the things is emergency medicine, that's it. Normally, our part of life, home, work, community, and self. That's normally that we have to do. It's not always like that. Our job is bigger and bigger. It takes more and more for us. And we are far from home, far from our family, far from our friends. It's dangerous. And all of the colleagues from all over the world speak about the burnout system. The thing is, we know that.
Thank you, Eric Raviu, for your opening remarks. Now, I would like to invite Professor Daniel Alimov, Director of the Republican Research Center of Emergency Medicine.
Danyar Alimov and Hikmat Amarov.
Herkese merhaba. Thank you very much. It's a really great honor for us to stay here again and again. We wish to come here, and we came here again. Professor Bashar Jander, sorry for disturbing, but I would like to ask you to come and join us here on this stage, please, too. On behalf of the Health Minister of the Republic of Uzbekistan, I had a great honor first to greet this esteemed society, the excellent auditorium, and you as a leader who gathered all of us here in these very crucial times. It's my honor and pleasure.
Thank you very much. Thank you.
And a small gift from our society to you. Thank you.
Thank you, Daniel Elimov, for your opening remarks. Now, I would like to invite Professor Luis Garcia Castrillo Riesco, past president of the USEP.
Si el ritmo te lleva a mover la cabeza, ya empezamos como es. Mi música no discrimina a nadie, así que vamos a romper. Toda mi gente se mueve, mira el ritmo como los tiene. Hago música que entretiene. El mundo nos quiere, me quiere a mí. Toda mi gente se mueve, mira el ritmo como los tiene. Hago música que entretiene. Mi música los tiene fuerte bailando y se baila así.
Luis Garcia.
Estamos rompiendo la discoteca, la fiesta no para, apenas comienza.
Thank you, thank you, thank you. I say this 3 times. I should have said 5 because this is the 5th time I am joining you, and I am really honored and pleasure. But in this occasion, for me, this situation is more emotional. After 2 years of very bad moments that you know better than me, to see old friends, to see that things seem to be improving worldwide, and to have the expectation that in the future we are going to have more meetings like this is something that touches my heart. And I have the best wishes for this meeting, and I suppose that in the future this is going the normal situation, not the past. As USEM past president, I would like to thank the organizers and of course Bashar Kander for his effort, not only for this Congress. This is an historical Congress, and you all know that to organize just one meeting is something really difficult. But to keep this historical activity year after year and having the attractions for so distinguished guests and participants in these meetings is something exceptional. So I will thank Bashar for organizing this for many, many years, and I give my best wishes, my personal best wishes, and the wishes of USEN as an organization to keep this, that is the life of emergency.
Me gusta cantar el son, mariachi me acompaña cuando canto mi canción. Me gusta tomar mis copas.
Daniel López Tapia.
Tequila blanco con su sal le da sabor. Ay, ay, ay, ay, ay, ay, mi amor. Ay, mi morena de mi corazón.
Sorry, Dr. Rebu, I'm very bad to dance. Well, all my colleagues told all about this conference. I just can't repeat. Dr. Bashar Kander, thank you very much for this invitation. For me, it's really a honor to be here. When the people ask me if it's a long trip, yes, 28 hours to be here. But it's nothing because be here is a great experience. Congratulations, Dr. Bashar. I'm sure it's one of the most conferences in the world. Thank you very much. And congratulations all of you, because we were the front line the 2 years. We lose many people, but we are here again. Congratulations all emergency physicians in the world. Dr. Bashar, I don't have a gift, but my gift is all the heart of the emergency physician from Mexico for you. Thank you very much.
Thank you, Jesus Daniel, for your opening remarks. Now I would like to invite Professor John Louis Vincent, Professor of Intensive Care Medicine, Université Libre de Bruxelles, Department of Intensive Care, Erasmus University Hospital.
Alors, qui dit études dit travail, qui dit taf te dit les thunes, qui dit argent dit dépenses, qui dit crédit dit créance, qui dit dette te dit huissier, lui dit assis dans la merde, qui dit amour dit les gosses, dit toujours et dit divorce, qui dit proche te dit deuil car les problèmes ne viennent pas seuls, qui dit crise te dit monde, dit famine dit tiers-monde, qui dit fatigue dit réveil, encore sur de la veille, alors on sort pour oublier tous les problèmes. Alors on...
John Louis Vincent.
I have been professor of intensive care medicine for many years, and this included teaching of emergency medicine, at least in the most severe aspects, the aspects that concern the critically ill patient, cardiac arrest, polytrauma, and septic shock, and other real emergencies. The other aspects of emergency medicine were covered by the teachers in the various specialties. And indeed, personally, I am less interested in minor cases. I like the real stuff. And I like to see emergency medicine department or from the floor, and we work together. Emergency medicine teams and ICU teams together in a very good atmosphere, and we all love it. We all love to do that. And I think it's a little bit of a model. In too many institutions, people are far away and the emergency department is there and the ICU is there. It shouldn't work like this. We need to break the walls.
Evet, 2,5 yıl. Bu arada ben Türkçe konuşacağım. Kulaklıkları verdiniz değil mi arkadaşlarımıza? 2,5 yıl. Nasıl geçti? Aralık 2019. Ne hayallerle girdik Aralık 2019'a ve çok farklı bir dünyayla karşılaştık. Şu anda biz tarihi anlar yaşıyoruz. Tarihi anlar. Neden? Çünkü 100 yılda bir olan bir pandeminin şahitleriyiz. Biz daha önce söylemiştik ama. Ne demiştik? Sağlık böyle önemlidir demiştik. Acil servisler önemlidir demiştik. Acil tıp uzmanları önemlidir demiştik. Görülen süreç dünya düzeninin sağlık üzerinden yeniden dizayn edildiğini gösterdi. Bunu bir teori olarak değil, yaşadığımız süreci tarif için söylüyorum. Bakın hayatımızda olmayacak şekilde değişiklikler oldu. Kim bizi bu kadar evlere kapatabilirdi? Çocuklarımıza sarılmadan 1 yıl geçirmek zorunda kaldık. Bunları hangi güç yaptırabilirdi? İşte hiç hesaplanmayan bir süreç bizim en iddialı olduğumuz kongreden 2,5 yıl ayrı kalmamıza sebep oldu. Ama şimdi her şeyin bir sonu, her gecenin bir sabahı olduğu gibi 2,5 yıl sonra çok özlediğimiz insanlarla bu büyük organizasyonda birlikteyiz. Hepiniz hoş geldiniz.
Mükemmel. Görüyorsunuz. Anlatmaya gerek yok. Konuşmuyorum. Görüyorsunuz. Anlatmaya hiç gerek yok. Görüyorsunuz.
Görüyorsunuz.
Vay şöyle olmuş, böyle
çok
olmuş. Konuşmam. Kesin. Görüyorsunuz. Ve ilerliyoruz tam yanına doğru görüyorsunuz.
Şimdi Sayın Erik de bahsetti. Biz hep ön saftayız dedik. Ön saf. Evet. Front of line. Ön saf. Ama burada görüyorsunuz. Ön saf değil bizim artık yerimiz. Bizim yerimiz ön safın en önünde komuta eden kahramanların yerine yerleştik. Zaten öyleydik de biraz daha süreci yönetecek bir yere geldik. Ve bu süreci böyle yendik. Şimdi arkadaşlar tabii ki acil tıp bu dönemde ne kadar önemli olduğunu gösterdi. Gerçekten özellikle pandemi döneminde biz bütün pandemiyi acil servisler içinde yönetmek zorunda kaldık. Karargahlar acil merkezler oldu. Acil servisler merkez oldu. Türkiye'de yoğunluk o kadar çoktu ki biz biraz sağlık sistemi olarak bunu daha iyi idare ettiğimizi söyleyebilirim. Tabii doktorlarla konumuz yani düşünün ya biz böyle bir konumdayız yani. Aradayız yani. Birisi yakalar, biz onun hayatını kurtarırız. Bizim işimiz hayat kurtarmak. Doktorluk. Tabii acil tıp için beklentilerimiz hiç bitmiyor. Bu 100 yıl gelecek ve bu benzersiz branşı hep birlikte bu kitle olarak, bu tarihi anları yaşayan kitle olarak ileriye taşıyacağız. Tabii bizim bu pandemi şartlarında bütün çabalarımıza rağmen güvenlik problemi hiç bitmedi. Sayın Genel Müdürümüz burada, Sağlık Bakanlığı yetkilileri burada. Güvenlik biliyorsunuz bizim müdahalelerin hepsinde ilk öncelik güvenliktir. Artık biz kendi güvenliğimizi korumak durumundayız. Yakında böyle kıyafetlerle acil serviste hizmet vermek zorunda kalmayız umarım. Bir türlü bütün işlere rağmen virüsle savaşalım mı? Virüsle mi savaşalım? Hasta yakınlarıyla mı uğraşalım? Gerçekten sıkıntılı. Tabii bunun İngilizcesi yok maalesef ama tercüme ederler. Yani şiddetin sebepleri böyle analiz edilmeye ihtiyaç olan sebepler. Tabii en sonunda da bu şiddetin sonu herhalde buraya gider. Tabii biz şiddet konusuna ATÜDER olarak en çok eğilen sivil toplum kuruluşu olduk. Ve bu dönemde, bakın pandemi dönemine rağmen biz daha önce hazırlıklarınızı yaptığımız bu kısa filmi şiddet konusunda gösterime sunduk. Tabii süremi biraz daha uygun kullanmak adına şu baştaki konuşmaları biraz geçeyim, onu internette takip edin. Evet, kurtarmaya çalıştığınız
Yapabilirsin.
bir can.
Yapmalısın. Bak ben senin yanındayım. Hadi tut elimi. Hadi kardeşim hadi. Hadi yapabilirsin. Hadi kurban olayım hadi. Bırakma. Evet. Aynen böyle. Uzat. Buradayım ben. Hadi. Tut elimi.
Acilin önünde kalabalık olacak. Hastalar, hasta yakınları, meraklı bir kalabalık. Ailenden haber alıp gelenler. Onları aşarken de tut elimi. Bırakma.
Görmedin mi diyorsun? Ya olacak şey mi? Burada ne yapıyorsun sen o zaman?
Üzgün ve sinirliler. Kabul edemiyorlar olanı biteni.
Annem doktor. Doktor kızım yaşıyor mu? Ne olur?
Bir suçlu arıyorlar. Acılarını çıkartacakları birileri.
Hanımefendi. Hanımefendi alır mısın?
Burada bulamazlar ki. Doktor kızım yaşıyor mu? Ne olur söyleyin.
Buluyorlar. Hasta bakıcılar, hemşireleri, doktorlara. Kimi bulurlarsa, kime güçleri yeterse.
Ama siz bana yardım ediyorsunuz. Elimi tutuyorsunuz benim.
Sen sakın elini bırakma.
Hayatla ölüm arasındaki o ince çizgide fedakarca çalışıyorlar. Sağlık ordusunun isimsiz kahramanları onlar. Acil tıp uzmanları ve çalışanları. Beni siz hayata bağladınız. Kendim ve sevdiklerim adına hepinize minnettarım. Ben şanslıydım. Ama sizin anneniz, babanız, eşiniz, çoluğunuz, çocuğunuz, akrabanız, arkadaşınız bu kadar şanslı olmayabilir. Ne olursunuz unutmayın. Size rağmen olmaz. Ama sizinle iyi olur.
Evet. Şimdi baktım ki film çevirmek kolaymış. Aradan beni sıkıştırdılar. Senaryoyu da yazıyoruz. İkinci bölümde artık düşündüm ya bu hastalar genelde kendini kurtaranlara böyle aşık falan olabiliyorlar diye. Böyle kolaymış bu film çevirmek yani. Emre bunu nasıl götürüyoruz?
Fakat öncesinde sağlıkta şiddet meselesine bir
Görmekle
göz atalım.
kalmadık.
ATÜDER yani Acil Tıp Uzmanları Derneği son günlerde sıkça tartışma konusu olan sağlıkta şiddet meselesine dikkat çekmek için sosyal medyada bir etkinlik
CNN'de
düzenledi.
haber
ve etkinliğe
olarak bunu-
tüm hekimler davet edildik, görelim.
Bunu verdik. Yine hızlı geçeceğim. Bu daha da ilginç. Yani güzel bir haber. Türkiye bu filmi konuşuyor. Evet.
Tüm Türkiye bu filmi konuşuyor.
Uzun sürecek mi?
Evet.
Burada da müsaade
Koronavirüs
hızlı geçeceğim.
savaşında en
gerçekten
büyük
medyada rahat bir şekilde yer aldık bu dönemde. Tabii bununla ilgili bir de kamu spotu yapmıştık. Onu belki izleyebiliriz. Bir de kamu spotu. Çünkü şiddet gerçekten bizim en çok hani üzerine odaklanmamız gereken konuların başında. O yüzden bunu iletmemde fayda var. Acil tıp uzmanlarına ve sağlık çalışanlarına yöneltilen şiddet, hastalara, hasta yakınlarına, topluma ve tüm insanlığa yöneltilen şiddettir.
Ne olursunuz unutmayın. Size rağmen olmaz. Ama sizinle iyi olur.
Evet, yani bunu mümkün olduğunca Türkiye gündeminde tuttuk. Görüyorsunuz TT olarak da herhalde burada 3. olmayı başardık. Burada bir kamera arkası görüntüleri var nasıl olduğunu bilin diye. Burada da 2 yönlü oyuncu. Biraz da Erik'e takılalım. Ya futbol yine farklı ya. Film endüstrisi iyi falan ama ne varsa yine futbolda var. Burada göreceksiniz şimdi. Kim atıyor? Evet. Garcia da burada tabii İspanya'ya atılan bu golü izlettirelim. Evet, gayet güzel bir gol. Tabii Ronaldo'nun neler yaptığını hep biliyoruz. Ronaldo ve Messi arasında büyük bir rekabet var. Biz genelde Ronaldo tarafını tutuyoruz. Mehmet hocam sen Ronaldo'cu muydun? Ronaldo. Biz biraz Ronaldo'yu seviyoruz. Görüyorsunuz golün güzelliğini. Burada da böyle bir şey var tabii ki. Okuyorsanız. Tedaviye de Ronaldo'yla Messi'ye gidin diye burada özetlenebilecek bir şey görüyorsunuz arkadaşlar. Dolayısıyla biz de bu konuyu iletişim konusunu da böyle gündemde tutmamız lazım. Şimdi acil servislerin çok önemli başka bir konusu da özellikle Türkiye'de yoğunluk. Bakın Türkiye'de yoğunluk. Pandemi bu yoğunluğun ne kadar önemli olduğunu bize gösterdi. Çünkü pandeminin ilk dönemlerinde özellikle İspanya'da, İtalya'da, İngiltere'de, Amerika'da sistemin çok zorlandığını gösteriyorlardı. Türkiye'de sistem zorlandı mı? Zorlanmadı. Çok fazla zorlanmadı. Neden? İşte Abdelbello aramızda değil, o da Covid olmuş. Kendisine selamlarımızı iletiyoruz. Bu yazısında gizli. Bakın diyor, başka bir sağlık sorunu olmasına gerek yok. Bununla acile başvurabilirsiniz. Tabii bu da Hindistan'dan herhalde. Konstipasyon için acile gelenler. Ve Amerika'daki yatak da acile gelenler. Ve Amerika'daki yatak durumu. Bak ben takip ediyorum. Yatak en gelişmiş Amerika kabul ediyor. Paul bilir şeyleri. Evet yatak yok. Yani hani Türkiye'de yatak yok da Amerika'da da yatak yok. Bakın aynı benzer şeyler. Hani şuraya buraya gideyim diyor arkadaşlar da. Sayın Genel Müdürüm bunları not etsin. Hocam bak yoğun bakım dolu, servis dolu. İAR 20 kişi bekliyor sırada. Yoğunluk sorun. Ama yoğunluğun çözümle yöntemleri var mı? Var. Bakın bizim asistanlar için bunu aldım. Bakın Amerika'da çalışma şeyleri 12 gece 13 gündüz yani 25 gününüz öyle. Yani bu da bizim hastanenin kedisi. Hani o da geliyor. Hatta Japonya'dan bir şey aradı. Kedi yavrusunu getirmiş acil servise. Onu internette görebilirsiniz. Böyle bir şey var. Acil tıp ve acil servislerde. Tabii TUS'lar açıklanacak. TUS tercihleri var. Şimdi bu oftalmolojist, radyolojist, dermatolojist bunların off day yani tatil günü. Bu da acilcilerin tatil günü. Genel olarak böyle bir yapıyla karşı karşıya kalırız. Tabii böyle olunca
Si tu laissais un peu ton âme, mousquetaire, la fortune et la gloire.
Que faudrait-il faire? Chercher un protecteur puissant? Prendre un patron? Et comme un lierre obscur qui circonvient un tronc et s'en fait un tuteur en lui laissant l'écorce? Grimper par ruse au lieu de s'élever par force? Non, merci. Dédier, comme tous ils le font, des vers aux financiers, se changer en bouffon dans l'espoir vil de voir aux lèvres d'un ministre naître un sourire enfin qui ne soit pas sinistre? Non, merci. Déjeuner chaque jour d'un crapaud, avoir un ventre usé par la marche, une peau qui plus vite à l'endroit des genoux devient sale, exécuter des tours de souplesse dorsale? Non, merci. De trouver du talent comme Mazette, être
pas le chêne ou le tilleul. Ne pas monter bien haut peut-être, mais tout seul.
Fais tout haut l'orgueilleux et la mère. Mais tout bas, dis-moi tout simplement qu'elle ne t'aime pas.
İşte burada ben konuşuyorum yani. Evet. Öyle geçelim. Evet. Bakın buradaki aslında acili seçmek için çok sebebimiz var. Bu sebepleri USM'de paylaştık, başka yerlerde paylaştık. Ama bu cümlelerin hepsini ben Türkiye'de duydum. Aslında biz de bunu söylüyorduk. Hepimiz bunları bilerek seçiyoruz acili. Yani mesela her gün birbirinden farklıdır. Ama burada özellikle şu cümleyi ben çok seviyorum çünkü çok kullanmıştım. Sen acili seçmezsin, acil seni seçer. Ve biz hep böyle seçilmiş kişiler olarak hizmete devam ediyoruz. Yani sonuç olarak aynı dili konuşanlar değil, aynı duyguyu paylaşanlar anlaşabilir. Ve Erik'e yine ithafen söylüyorum, o da aynısını söyledi. Biz aynı duyguları yaşayıp aynı hizmeti veren Şimdi biz buna güldük hep değil mi? Covid'de bu gerçek oldu biliyor musunuz? Ateşi olanı aldık, hepsini bıraktık yani. Demek ki hiçbir şeye gülmemek lazım. Önümüze çıkıyor. Tabii futboldan bahsederken bu da aşı karşıtları için bunu anlamak lazım. Burada Burak mı var? Onun gibi bir şey yani. Anlayan anlamıştır. O Kanuni'de dolu dolu gösterdiğim şeylerin fotoğrafını çektim Covid'de. İlk dönemde bakın. Gerçek acil diye bir şey yokmuş. Bomboş koridorlar. İnanılmaz. Kanuni'nin boş koridorları. Benim çalıştığım hastane. O 3000 gelen hastane. Covid'den sonra. Bomboş. Şimdi sunumun bu tarafında tabii ki bir de başkanlık sistemiyle ilgili bir şeyimiz var. Bunu istikrar her zaman önemlidir diyoruz. Burada
ya kardeş ya bahtımız ne kara avara elimde olsa avara gezer miyim yar avara gezer miyim yar avara gezer miyim.
Bu da Türkçe versiyonu. Evet. Şimdi Roger Dickerson'ı andık törenden. Hemen Roger Dickerson üşenmemiş, mesajını yollamış. Onu dinleyelim.
From the southern tip of the African continent. I'm greatly saddened that I'm not able to join my friends and colleagues in person in Antalya this year and participate in this fantastic conference. Unfortunately, visitors from South Africa are not permitted entry to Turkey under the current COVID-19 regulations. I have been fortunate to participate in previous years, and I know the quality of the presentations will be excellent and the organization of the conference exceptional. And of course, the warm hospitality of the Turkish people unparalleled. And so on behalf of the Emergency Medicine Society of South Africa, I wish you everything of the best for the conference.
Toplamaya çalışıyoruz. Bütün kıtalardan ama bu takılması olmazdı zaten biliyoruz. Takılmamız gerekiyordu. Ne yapacağız Emre? Hemen devreye girebilir misin? Hı? Tamam. Evet, bu arada ben hemen şunu söyleyeyim. Arkadaşlar çok uzatmayacağız, rahat olun. Birazdan bitireceğiz. Sonlara doğru yaklaşıyorum. Öyle terk etmeyin salonu falan. Biliyorsunuz dronlar İHA'larda çok geliştik. Biz de dronlarla takip ediyoruz şu anda. Dışarı çıkınca hemen drone yakalıyor. Onun için tabii bu işin şakası. Biz aranızda olmaktan çok mutluyuz. Pandemi dönemi biz biraz da kontrollü yaptık bu işleri. Özellikle burada fırsat bulmuşken onu da söyleyeyim lütfen. Pandemi kurallarına uyarak kongreyi geçirelim. Ben 2,5 yılda hiç sarılmadığım kişiye bugün sarıldım yani. Kişilere yani o kadar sayıya. Akşam evet inelim. Buradan evet gel buraya. Ben buradan hemen geçeyim de bir daha takılmasın. Aman geçelim. Çin'in şeyi vardı. Oradan mesaj alalım. Biliyorsunuz Çince'de vardı geçen kongremizde. Rusçayla birlikte. Onların da mesajı, bir dakika, mesaj burada değil mi? Uzun değilse okuyalım. Çünkü yani güzel, tabii bizim açımızdan bütün ülkelerin bu duyarlılığı göstermesi.
I am Professor Wang Zhong from China, the chairman of the Chinese Society for the Promotion of International Communication. I am very pleased to be invited by President Basa to participate the Turkish Emergency Medicine Annual Congress. Unfortunately, due to COVID-19, we cannot go to the beautiful Antalya to attend this wonderful meeting face-to-face. But emergency medicine will contact us, no matter how far away we have. Thanks again for the invitation of President Basa and the conference. I hope to meet
Türkiye'de planlanıyor. Daha doğrusu aldık. Vasemi Türkiye'de yapacağız. 100. yılınızda yapalım dediler. Allah nereden biliyorsunuz 100. yılımızı diye sordum. EPAT aracılığıyla biliyorlarmış. Evet, fiziki kongremiz. Bu videoyu göstereyim arkadaşlar. Bir geçen şeyi hatırlayalım ki bu yıl için bir şey olsun. Daha videoda göstermem fazla. Evet. Geçen kongremiz, evet. Altın Acil ödülünü son olarak sonra Bingür Sönmez almıştı. Çin'den gelenler, Yunanistan'dan, Hindistan'dan. Tabii satranç turnuvalarımız, yarışmalarımız, gala gecemiz. Ve futbol turnuvasıyla çok güzel anlar geçirmiştik. Özellikle galada yine sizi güzel, eğlenceli bir geceye bekliyoruz. Burada arkadaşlarımızla birlikte. Böyle bir resimle bitireceğiz. Şimdi online Covid'in bizi çok etkilediğini söylemek durumundayım. Covid bizi çok etkiledi çünkü çoktan çok gider denir ya. Onun için bunları geçeceğim. Ama biz dünyadaki ilk şeyi burada yaptık. Bakın şurada. İlk Covid online sempozyum Mayıs'ta. Yani Türkiye'de Mart'ta Covid göründü. Nisan'da tedbir oldu. Mayıs'ta biz kongre yaptık. Sonra ilk acil online kongresi dünyada yine 23-25 Temmuz'da yaptık. O kongreden yine görüntüler. Ve bu kongremiz yine haberlerde, CNN'de. Bunları geçmek zorundayım. TRT'de. TRT'yi geçsek şöyle dur. TRT'yi bir verelim.
Koronavirüs salgınıyla mücadele sürecinin de değerlendirildiği 16. Ulusal Acil Tıp Kongresi başladı. Bu yıl online olarak gerçekleştirilen kongreye pek çok ülkeden alanında uzman akademisyenler katılıyor.
Bir kongremizin daha arifesindeyiz.
6 kıtadan 250'yi aşkın konuşmacı.
Yani bu kongremiz Türkiye'de büyük haber oluyor. Onu da geçelim. Bunlar da teşekkürler. Paul'dan, Abdülbeli'den, Avdi'den, Sagar'dan. Bunlar hep bize yapılan gerçekten teşekkür konuşmaları çok bizim için değerli. Biz EPAT olarak biliyorsunuz uluslararası çalışıyoruz. Onunla hemen devam edelim. İstanbul, Katar, Kitahani burada sonra olacak inşallah diye umuyoruz ama olmasa da temas kuracağız. İstanbul, Katar, Amman, Mısır, ondan sonra Sonos School'da yaptığımız çalışmalar ve 6 Nisan. Burada da Mehmet Gül hocamıza atfen Yahya Kemal Günaylı'ya da olabilir. Paradan 6 sürü atabilir. Tarihte aslında bu da bizim 6 Nisan aktivasyonumuz. 6 aktivasyonu aynı günde 6 aktivasyon yapmıştık. Bunlar da uluslararası yaptığımız bakın Sri Lanka, Kıbrıs, Ukrayna. Ukrayna'ya teşekkür ediyorum. Burada onları da çağıracağım. Wait, please. Makedonya, ondan sonra Azerbaycan, Gürcistan, Kazakistan, Hindistan, Katar'ı söylemiştik. Burada Kıbrıs'ta arkadaşlarımızla yaptığımız çalışmalar. Evet, kurs yani 15 başlıkta kurs veriyoruz arkadaşlar. Bunları söyleyeyim. Ama ATLS için ayrı bir teşekkür yapacağım şimdi. Çünkü ATLS'yi 1,5-2 yıl uğraşarak Behçet Hoca, Mehmet Hoca ikisinin çalışmalarıyla bunu ülkemize kazandırdık. Arka arkaya 4-5 tane yaptık. Bu yüzden Behçet Hoca'yı da Mehmet Hoca'yı da burada alkışlıyorum. Evet, Behçet Hoca'nın bununla çok emeği olduğunu tekrar ifade edeyim. Behçet Hoca bu da senin için. ATLS görüyorsunuz. Bu hızla devam edecek. Genel müdürümüz de burada. Onların da desteğiyle pre-hospital'ı da yapıyoruz. Çok iyi gidiyor. Yani bu çok önemli. Sonos School uluslararası 6 ülke, şu anda 7, 8, 9. ülke sırada. ATOK. Burada da Mehmet Okumuş hocamıza teşekkürlerimi sunuyorum. Mehmet Okumuş burada mı? Onu da alkışlayalım. ATOK için. Ve İKYD kursu çalışmalarımız, bakın İKYD çok önemli. Bunu daha önce gösterdim. Burada tekrar göstereyim ama kısaca. Bakın. Adama zorla masaj yapma. Evet, geçelim. Değişik hastalara bile bazen öğretmek zorunda kalıyoruz, gördüğünüz gibi. Kendi kendini solutması lazım. Bıraktığı anda gidecek. Bunu geçeyim. Evet, atüder olarak bir sürü aktivasyon yapıyoruz arkadaşlar. Biliyorsunuz yangınlardan sonra hemen biz yapabildiğimizi yaptık. Ağaçlandırmalar yaptık. Bu dönemde çok kitaplar arka arkaya. Kitaplarımız burada görüyorsunuz. Çok önemli kitaplar arka arkaya ama bu textbook'umuz 4000 sayfa. Yabancı uluslararası yazarlarımız da var. 400 bölümden 400 yazar, 4000 sayfalık bir dev textbook. Acil tıbbın geldiği yeri gösteriyor Türkiye'de. Ve bunlar haberlerde çok güzel yer aldı ama ben geçeceğim çünkü sizi sıkmayacağım daha fazla. Şu anda da bu Sayın Vincent'in bahsettiği acil kritik bakım birlikteliğini gösterdiğimiz bir kitabımız. Bakan Bey'imizi ziyaret etmiştik ve 2 müjde demiştik. O müjdeleri söyleyelim mi? Kimse sormuyor. Şimdi söylüyoruz o zaman. Birincisi az önce bahsettiğimiz, aslında çok kişinin de tahmin ettiği yan dal. Yan dallar için bizim yanımızda Sayın Bakanımız sadece yoğun bakım değil, bunun dışında spor hekimliğinden tutun birkaç yan dalı inceledi. Ama yoğun bakım için derhal talimat verdi, çağırdı. Ondan sonra yoğun bakım yan dalı acilciler için gerekli ama bürokraside biraz biliyor şeyimiz, biraz patinaj gibi bir şey olunca Bakan Bey hemen tepki gösterdi. Sonra sağ olsun Eray Hocam bize destek oldu. Onun yanına gittik ama Eray Hoca'dan öncesi var onun. Birisi itiraz edince ya nörologlar oluyor, enfeksiyoncular oluyor, acilciler nasıl olmaz diye Bakan Bey ifade etti. Onun da takipçisi olacağız inşallah. Bu birinci müjdemiz. İkinci müjde de bana kalsın. Yani burada Eray Bey siz gözlerinizi kapatırsanız da olabilir ama Sağlık Bakanı ile ilişkimiz böyle olmasın tabii. El sallayıp şey yapmayalım yani. Koronada çok gündemdeydik. Hakan Hoca'yı da görüyorsunuz. Hep her yerde yer aldı. Bak Mehmet Ceyhan şu anda şey yapıyor tabii. Biraz işte teke tekten tutun CNN'de. Bu özellikle dikkatimi çekti. Ben bu yani bu nasıl denk geldi onu anlamadık ya. Tam yakalamışlar. Bir de benim medyam değil bu, anlamadım yani. Hemen ilk yüz yüzemizi Belgrad'da yaptık Haziran'da. Geçiyorum bak, hiç durmadık. Ve kongremize geldik. Çok uğraştık bu kongre için. Bu kongre için çok uğraştık. Ama sonuçta gerçekten son güne kadar bu kongrenin şey olması için ne oldu? Canım yani konuşma bitsin diye mi ödülü konuşmayı bitirmek için. Peki tamam. Tamer Karadağlı'nın hareketini burada destekleyelim. Ya teşekkürler ama biraz hemen bitireceğim.
Sabaha kadar buradayım bugün. Sabaha kadar burada.
Onun için hiç çevesinlenmeyin, sabaha kadar buradayız bir daha bak.
Sabaha kadar buradayım bugün.
Ödüller bizim için çok önemli. Ödül alıyoruz. Çok teşekkür ediyorum. Gerçekten çok güzel ödüller. İşte Özbekistan'da Hikmet'e ve ekibine çok teşekkür ediyorum. Daniel'e. Ve Ürdün'de, Katar'da bakın bunlar hep Sağlık Bakanı. Yani burada Hindistan'da, Suudi Arabistan'da, tabii meclis başkanımızla, bu da Romanya'nın İçişleri Bakanı olması lazım. Çok şey yaptık, ödüller aldık. Ama şimdi bu ödüllerden sonra biz de ödül veriyoruz. Şimdi gelelim, biz kendi ödüllerimizi verelim. Bitti yani bu. Bitme manasına geliyor. ve gümüş. Gümüş sponsor Menarino. Şimdi 2 tane özel ödülümüz var bu dönem içinde. En çok gelişim gösteren firma olarak Ebot firmasını buraya da ve şimdi en önemli ana geldik arkadaşlar. Şimdi dikkatli olun. Şimdi dikkatli olalım. Evet, bu kongrede en önemli an. Şimdi biz şu ana kadar Altın Acil ödülünü verdik. Kimlere verdik? Mesela ilk ödülü Gazi Yaşargil, sonra Aziz Sancar, sonra Gold Frank, Paul Kivela, Bingür Sönmez. Ve şimdi bu ödülü vereceğiz. 7. Altın Burgada'ya da vermiştik. Pardon, online onu geçelim. 7. ödülü veriyoruz şu anda. Sema gelir misin? Evet. Sema CV'sini okumak üzere ama ben şuradan bahsedeyim. Luis şimdi Sema evet sizini alalım. Hemen kısa bir CV'siyle tanıtmaya çalışacağız. Çünkü baktık 300 sayfa mıydı CV? 300 sayfa CV vardı. Evet. Evet.
He is professor of intensive care medicine at the University Libre de Bruxelles and intensivist in the Department of Intensive Care at Erasmus University Hospital in Brussels. Specialist in internal medicine, he spent 2 years training at the University of Southern California with Professor Max Harry Weil. He obtained his PhD degree at the University of Brussels in 1982. He has signed more than 900 original articles, some 400 book chapters and review articles, and more than 1,000 original abstracts, and has edited 102 books. He is co-editor of the Textbook of Critical Care, Elsevier Saunders 7th edition, and the Encyclopedia of Intensive Care Medicine. He is
bitiriyoruz. Mayıs'ta buradayız. Kongre bitiminden sonra Mayıs'ta tekrar bir arada olacağız. Ve şimdi 2 tane şeyimiz kaldı. Bir, Ukrayna'dan çok değerli bir misafirimiz var. Hemen onu alacağız. Sonra da genel müdürümüzü çağıracağım. Biraz daha sabredin arkadaşlar. Biliyorum çok uzun bir
I am sure that our Congress will be held at a high level. Success to all of us.
Thank you very much. Nice meeting in Turkey. Welcome again. Thank you. Evet Sayın Genel Müdürüm bize bir selamlama konuşması lütfederseniz çok mutlu oluruz. Acil Sağlık Hizmetleri Genel Müdürü Sayın Eray Çınar hocamız, buyurun.
Öncelikle kıymetli başkanım, kıymetli hocam, Başar hocam, sizleri, Acil Tıp Uzmanları Derneği Yönetim Kurulu üyeleri, kıymetli hocalarımızı, yine yurt dışından buraya gelerek bu kongreye büyük katkı sunacak kıymetli hocalarım ve aynı zamanda ülkemizden gelen bu ümit ordusunu yetiştiren, sağlık sistemine katan kıymetli hocalarım ve siz değerli acil tıp uzmanı ve asistanı meslektaşlarım, hepinizi saygıyla selamlıyorum. Konuşma esnasında bir ümit ordusu kelimesi kullandım. Yani gerçekten öyle. Çünkü bizler hekimiz, ben de göğüs cerrahisi uzmanıyım. Çoğu zaman evet hasta tedavi ediyoruz ama siz hem kriz yönetiyorsunuz, hem hasta tedavi ediyorsunuz. Üstüne üstelik bir de çoğu zaman titreyen cümlelerle kurulan soru cümlelerinin, bir tedirgin bakışın, bir stresli duygunun, o stresli bekleyişin çoğu zaman ümidi oluyorsunuz. O yüzden yaptığınız iş gerçekten çok kıymetli. O yüzden bir kez daha vermiş olduğunuz hizmetlerden dolayı teşekkür ediyorum. Bir göğüs cerrahisi uzmanı olarak bu kongre ortamına, alanına geldiğim andan itibaren o kadar çok selamlaştığım, tokalaştığım meslektaşım oldu ki, gerçi benim için biraz geç artık bu yaştan sonra uzmanlığa girip tekrar acil tıp uzmanı olmak. Ama gerçekten aynı ortamda sizlerle
Mustafa Hoca'yı buraya davet ediyorum. SEFMİ projesi için. Tabii Nuri Bozdemir hocamızı da katkılarından dolayı alkışlıyorum. Nuri hocam.
Hi, from Romania. So fourth one is Atuder, IPAT. So IPAT is our partner also. We have 5 organization also. So our budget around of 140,000 euro around of we have a grant awarded. So also it will be the first. We have 8 outputs for the project. We have to prepare to the booklet for the training for geriatric EM medicine, and we had some application for polypharmacy. We checked all the patients' medicines with interaction each other. So we have to at least medical article at least 2 of them, and then we had then trainees, especially nurses, our colleagues, our personnel in our hospital, with also pre-hospital section. We have 10 beds in our hospital with a separated area. We are planning with this physical areas. So this is my summarization.
Ben hepsinin ismini saymak çok olacağı için benim ismim de geçiyor. Biz bir takım olarak bunu yapıyoruz. Yönetim kurulundaki arkadaşlarımıza çok teşekkür ediyorum. Onları da alkışlayalım. Ve en son olarak da teşekkürü, gerçi bunu son gün yapmak lazım, 3 gün daha bekleyelim ama öncesi muhteşem diyelim, işte bu dediğimiz Orkun, Emre ve Osayin Mahis'e yapıyorum. Teşekkürler. Evet arkadaşlar, bir sayın başkanları buraya ve onlarla birlikte burada olan herkesi bir toplu fotoğrafa çağırırsak işimiz bitmiş olacak. Photo together.
shadows, just enjoy the ride. If you close the door to your house, don't let anybody in. It's a room that's full of nothing, no blood underneath your skin. Your face against the window, you can watch it fade to gray, but you'll never catch the fickle wind if you choose to stay. But oh, the road is long, the stones that you are walking on have gone. With the moonlight to guide you, feel the joy of being alive. The day that you stop running is the day that you arrive. And the night that you got locked in was the time to decide. Stop chasing shadows, just enjoy the ride. Stop chasing shadows, just enjoy the ride.
Welcome to Turkey. Welcome to Intercontinental Emergency Medicine Congress in Turkey. Okay, thank you. After 2 years, it's very big memory for us. After 2 years, more than 2 years, this is the first face-to-face Congress. We are like big family and we miss each other very much. Paul, you can start. We haven't had 4 days full old truck 4 days till evening. Okay, we can start, Dr. Paul. I miss you. Yes.
Well, I miss you and I miss everyone. I miss you, Bashar, and I also missed all of you here in Turkey and all my colleagues from emergency medicine around the world. It's great to see everybody's face-to-face. I know we're wearing these masks sometimes, and hopefully soon we'll get past that as well. I know there's a lot of things that we can all learn from each other, and I'm excited to be here. I'm excited to learn from all of you, and I'm fortunately or unfortunately looking forward to presenting how poorly the United States did in managing this pandemic from our side. But I think there's a lot we can all learn from each other. And again, very, very happy to see all of your faces and look forward that all of you have survived this pandemic. And I'm looking forward to thoughts about how we can do better going forward. Thank you.
Thank you very much, Dr. Paul. And we will start because we haven't enough time. And I want to invite everybody to a very wonderful, fantastic opening ceremony. We will prepare for this. I think we tried for this more than 6 months. And we can start. I want to invite first speaker, Dr. Arif Karagöz. He is topic about role of ultrasound in airway assessment and management. Please, Dr. Arif.
My presidents, my colleagues, it's very beautiful to see you after 2 years in here. I am Dr. Arif Karagöz from İzmir Çiğli Training Hospital, Emergency Department, and I will talk about point-of-care ultrasound for airway management in Emergency Department. First of all, I have nothing to declare, no conflict of interests. I will talk about basic anatomy of our upper airway and pros and cons of ultrasound for airway management. Talk about indications, technique, and basic bedside ultrasound applications for airway management. As you all know, airway starts with mouth and nose, and then continues with larynx. And larynx is the most important part of airway for emergent airway procedures, as you know, correct or not with ultrasound. And we can predict the optimal size of our endotracheal tube for our patient with ultrasound also. And we can even see if there is vocal cord palsy or not in our patient with ultrasound. And let's talk about technique. Our patient is laying supine in center sniffing position, neck is extended, we will use high-frequency linear transducer, and we will use depth approximately 3 to 4 centimeters. And we will do imaging in two manners, first vertical and then horizontal manner. Let's start with vertical scanning. When we put our probe on the thyroid triangular shape, just like a mount, it's thyroid cartilage. We can see also thyroid gland on the cartilage. And inside, there are two lines, hypoechoic lines, representing vocal cords. And they are lying between the apex of thyroid cartilage and arytenoid cartilages. And if our patient is conscious, we want him or her to emit sound, and we can see both of the vocal cords coming together at the midline and vibrating to produce sound. So this image shows us there is no vocal cord paralysis. But if one or two of them doesn't, it's simple and fast method for correcting the placement of our tube. It's sensitive and specific. Expert sonographers reach more than 95% correctivity, but novice sonographers have also more than 90% sensitivity and 95% specificity. There are two methods to use ultrasound for this indication. First, direct method. Put your probe to cricoid cartilage level in a transverse manner and look. And the second is indirect method. Indirect method is to see the lung movements by lung ultrasound. And direct method does not require ventilations. It's an important advantage because we can avoid our patient to have gastric insufflation or delay in the
section. Okay, you can invite.
Yeah. First of all, great presentation. And how often do you use this in evaluating airways? Do you use this 100% of the time, 50% of the time? How often do you use this?
Okay, Arif, go.
Sorry, I thought we will talk about in discussion time. Sorry. Especially for endotracheal tube placement correction, we use this method more than 70 or 75%. But for my expectation, for airway interventions, we started to use ultrasound, but we are novice, in fact. But we are trying to get expertise around this area also. But for placement, we are doing it, and we have also wrote a paper for American Journal of Emergency Medicine. We have a paper there, and we have shown that it's very easy to learn also. We
Who's going to talk about the importance of proper positioning for airway management? Dr. Kumar.
Very good afternoon to all, and I am Dr. Sarvana Kumar. I represent Society for Emergency Medicine India as its secretary. And it's my pleasure to be here, and thank you so much to EPAT and Professor Bashar for inviting me over. I was so happy. This is my 8th trip to this event and to this Congress. So now Turkey is my second home. So extremely happy to be here. When I got this invite, I was quite happy. At the same time, I was also a bit worried. Happy because I got an opportunity to come again to meet all of your friends in physical event, but a bit worried whether the suit and pants would fit me, because I haven't worn them for 2 years. So we were all on our scrubs. But really feels good to be here. intubation. Manual ventilation skill with proper equipment is a fundamental premise of advanced airway. So this is my suggestion to all the residents, especially those who are starting your career in emergency medicine. Never forget these 3 golden rules throughout your career in emergency medicine. So the 3 positions which are very, very important for us to have a successful airway placement. 1, how do you position yourself? 2, the patient's position. And the 3, where do we keep your laryngoscope blades? Or slightly above that. So that's about how do you position the bed and how do you position yourself. Let's quickly look at how do you position the patient. The aim of the patient positioning is basically to align 3 axes together. They are oral axis, pharyngeal axis and laryngeal axis. And they have to be aligned, allowing the line of vision to fall at the laryngeal inlet. And this was described actually in 1936 as 3-axis theory, and we call it as sniffing position. So I'm going to show what is a sniffing position rather than trying to read what a sniffing position looks like. In position has a first pass success rate of about 85%. So when we say upright, this is placing your patients above 45-degree angle. It may not be feasible in all your patients in ED, especially with trauma and other patients, but however, it does help certain times. And if anybody who's learning intubation, if you have an opportunity to try it, you may. So let's come to pediatrics. Is it any different from adult positioning? Yes, there are certain anatomical considerations you need to remember. We all know the occiput is quite large in pediatric age group. They have a large tongue. The tonsils and adenoids are larger. The vocal cords are placed much higher. They've got a weak hypoepiglottic ligament, floppy epiglottis, a short and a narrow trachea, and also master the art of bag and mask first. Keep the patients as high as possible. Ensure the bed is at least to a level of your umbilicus and above. Keep the patient's head in the trolley closer to you or closer to the head end of the trolley. Don't have any space in between. Align the 3 positions, 3 angles. That's a sniffing position. Stand back and don't flex your elbows too much. If you don't get your airway or vocal cords, don't go closer. You should rather go backwards, trying to align those 3 ankles. You can try ramp or stack position in obese patients and ensure that the tip of the blade is also in the right position, where in adults it's in the vallecula, whereas in pediatric age group, you will actually include epiglottis as well when you are trying to do a scopy to see the vocal cords. And if you are a resident learning intubation, try upright intubations. Thank you, Professor Burchett. I'll answer the second one first, and yeah, hopefully I'll get it next year. And with regards to your first question, I think it's a very important question because at the beginning of Corona, we all tried using those intubation shields and the hood and various fancy-looking transparent equipments, and that did complicate the process a little bit. We also tried that, and clearly many a times it was a bit difficulty to maneuver using the small space which you have got there. But again, as time passed by, we also got a lot of study and research which said using those boxes is clearly not going to be helpful in preventing the spread of COVID. So rather, a full PPE for the operator is a much better option. So that's what most of us moved towards. And we in fact stopped using any intubation boxes.
Yüksel Facan. Her topic about awake intubation in ER.
Hello everyone, my name is Göksu and I'm from Istanbul. I try to summarize your awake intubation in ER. Awake intubation is a placing endotracheal tube in trachea while the patient continues to breathe. The principal advantage over rapid sequence intubation is that you not take away the patient's respiration or airway reflex, which makes the process safer in many circumstances. The disadvantage is that the patient's personality, movements, as the patient's airway reflex must be managed, and it may take time. And even when done well, the review won't be yet as good as in paralyzed patient. Instrumenting the back of the throat may cause gagging to possibly vomiting. Throat is quiet and unlikely to lead clinical significant 3 times. Let it go away. Anesthesia should only be induced after 2-point check. The visual confirmation and capnography has confirmed correct tracheal tube positions. And also, all departments should support emergency medicine residents to attain competency and maintain skills in awake tracheal intubation. They only really talk about awake intubation for anatomically difficult airways, but I actually think that the physiological difficult airway will be more common indication in emergency medicine routine. And also, I wouldn't be trying an awake approach in the emergency department with an uncooperative patient. This is the difficult airway intubation and difficult mass ventilation table, but improves the interprofessional communication, teamwork, and patient's outcomes. A cognitive aid such as checklist before and during performance and awake tracheal intubation is recommended. So, we have to use the awake tracheal intubation in 4 things. The first is oxygenate, then topicalize, then sedate the patient, then perform. A lot of things about awake intubation technique. We firstly use anti-CLOX, then dry all of the area, then use topical-like agents, then choice. The topical lidocaine should not exceed 9 mg/kg, and practitioners should recognize that that is not a target but a maximum dose, and in practice it's rarely required, just because you aid your procedure with a little bit sedation with midazolam. And with all local techniques, local anesthetic toxicity will be in mind, and you have to do something for toxicity, including lipid emulsion should be in place. Regardless of the techniques used, they are demonstrating any clear benefit over the other agents. And we also use the tube confirmation as a 2-point check. First, get a waveform and enter the carbon dioxide. Second, and the most important one, see the direct intubation via the vocal cords. Anesthesia should be induced only when the 2-point check has confirmed the correct tracheal tube placement. Then, complications and failure. It's life. It's always been a complication. You can afford this likely attempt at intubation. You get 3 attempts, then stop. You can have a 4th attempt only if it's done by a more experienced operator, just like the direct intubation. If you are not successful, immediate actions should include real listening.
Thank you very much. Does anybody have any questions? Then I'll ask one question.
Yeah.
Dr. Acil, how often do you do awake intubations versus fully sedated?
I don't prefer it.
Yeah, that's pretty much becoming the standard everywhere. So maybe perhaps we need to consider this again. But thank you very much. Any other questions?
Okay.
Thank you.
Thank you, Dr. Göksu. We can close the section, but I want to say anything because this intubation is very important for all emergency residents. And I want to advise that please be sure, please be sure, please be sure, because if you aren't sure for the intubation, right intubation, correct. Emre zili çaldınız değil mi canım? Dronları hareket ettir. Dronları hareket ettir bakalım kim var. Evet değerli arkadaşlar, bugün ilk satelit sempozyum, ilk uydu sempozyumumuza başlayacağız. Yani ben şunu ifade edeyim, aslında şu anda yaptığınız her işlem, her iş tarihi bir iş. Yani 100 yılda bir pandemi olmuş. Ondan sonra ilk face to face kongre, ilk bölümüne geçtik. Şimdi ilk uydu sempozyumunu yapıyoruz. Yani 100 yılda bir olacak bir olayı birlikte yaşıyoruz. O yüzden bu anın kıymetini hepimiz bilelim. Tarihi şahıslar olduğumuzu burada anlayalım. Derslere katılma konusunda da gayretlerimizi gösterelim. Dediğim gibi 6 aylık bir belki hazırlık periyoduyla bizim için yapabiliriz.
Uzun Covid döneminin bu bizleri bir şekilde kısıtlayıcı yaşam tarzına itmesi neticesinde bazı değerlerimizin farkındalığının oluştuğu bir süreçten geçiyoruz. Bu anlamda ben bu kongrenin eskiye özlemden çıkıp yaşanması adına çok değerli olduğunu düşünüyorum. Bu anlamda bu kongrenin hepimiz için her anlamda doyurucu geçmesi dileğimi de bu arada sizlerle paylaşmak istiyorum. Hepinize tekrar hoş geldiniz diyorum. Öncelikle heyecanımı ifade etmek istiyorum. Bu benim yanlış hatırlamıyorsam ilk satellite sunum. Bu anlamda vereceğim acemice davranışlar için şimdiden özür diliyorum. Sunum aktivasyonu. Öncelikle şunu sorayım. Kliniğinde intravenöz alfa blokeri kullanımı konusunda deneyim olan arkadaşımız var mı? Türkiye'den Fransa'da kullanıyorsunuz siz. Evet.
Yani Türkiye'de de kullanıyoruz hocam. Biraz Tuğba sizin deneyiminiz yok mu?
Ya benim gözlerde acaba biraz sıkıntı var galiba. Arka taraflarda el kalktığını göremedim.
Tuğba kullanıyoruz değil mi? Nasıl bir tecrübemiz oluyor değil mi bizim hastanede de? Başka hastanelerde de biliyoruz Sayın Hakan Hocam. Sizin hastanede de tecrübelerimiz olduğunu düşünüyorum. Onu da herhalde paylaşırız sunum boyunca. Sunumu mu bekliyoruz acaba bu arada?
Bizim de. Buyurun.
Merhaba. Doktor Ali Karakuş Hatay MK Tıp Fakültesi Acil Tıp Anabilim Dalı'ndan. Biz alfa blokörleri hipertansiyon için kullanmadık ama klinik deneyim açısından bilgi vermek istedim.
Evet.
Özellikle akrep sokmalarında, akrep ısırıklarında, kalp yetmezi olan vakalarda ve çocuk vakalarda kullandık 2 vakamızda. Etkili olarak prozasin kullanmıştık o vakada.
Evet.
Daha sonra prozasini de piyasada bulunması zor. Onun yerine doksazasin de kullandık bir vaka üzerinde. Ve yetmezlikte de kalp yetmezi bulguları pozitif fenotropların yanında klinikte düzelme gördük. Ama hipertansiyon için kullandığımızı söyleyemem.
Evet.
Teşekkür ederim.
Çok teşekkürler katkınız için Ali Hocam. Tabii Hatay'da bu tecrübe biraz daha fazla. Hatta Behçet Hoca'nın da bu konuda bu akrep sokmalarıyla ilgili yayınları, ödülleri falan vardı değil mi Behçet Hocam? Şimdi onlardan biraz bahseder. Evet.
Teşekkür ederim. Ali Hocam'ı desteklemek için evet. Akrep sokmalarında fırtına döneminde sempatik aktivitenin arttığı dönemlerde gerçekten faydalı oluyor. Hatta elimizde bulunan en iyi ajandır diyebilirim. 0.03 miligram kilogramdan IV formu olmadığı için oral su içerisinden erittikten sonra nazogastrik küçük çocuklara bile verilebilir rahatlıkla. Fırtına dönemi bastırmak için gerçekten faydası görünüyor. Yani bundan ilk önce bu konuda Hindistan'da başlamışlardı. Biz de Türkiye'de şu anda kullanıyoruz onu.
Şimdi arkadaşlar tabii ki tansiyon tedavisi bizim açımızdan çok kritik bir tedavi. Bazen mesela hiçbir şekilde düşüremediğimiz tansiyon grubu oldu. Biliyorsunuz üçlü, dörtlü özellikle kronik böbrek hastalarında bu konuda sıkıntılarımız oluyor. Tansiyon düşüremediğiniz vaka gruplarında bazen ilaçlar yetersiz kalıyor. Bir başka konu da burada özellikle mesela hipertansif emergency dediğimiz yani stroke'la birlikte tansiyon veya akciğer ödemiyle birlikte tansiyon olduğu durumlarda biraz daha tansiyon belirleyici oluyor. Tedavisi hasta seyrinde belirleyici oluyor. Tabii bütün bunları tartışacağız. Vaktimiz de var. Hakan Hocam bu konularda açıklamaları yapsın. Sonra da biraz da tartışmaya zaman bırakırız değil mi Sayın Hocam?
Tabii ki ben aslında birkaç dakika içerisinde genel bir değerlendirme yapacağım. Sonra birkaç vaka örneği ile sunumumu tamamlayacağım. Daha sonra tartışma için uygun bir boşluk kalacak diye düşünüyorum başkanım.
Tabii.
Evet, acil servise başvuru anlamında gerçekten önemli bir sıkıntıyı oluşturuyor hipertansiyon vakaları. Dünyada nüfusun popülasyonun önemli bir oranını hipertansiyonlu hastalar oluşturuyor. Belki de dünyada en fazla hastalık oluşturan problem sıralaması olursa ilk 3'e giriyordur diyebilirim. Çünkü net bir istatistik veri tüm dünyayı kapsayacak şekilde sağlıkçıların elinde yok. Her yıl milyonlarca insanda ölüme sebebiyet verebilecek ve dünya genelinde morbidite ve mortalite anlamında ciddi sorunlar oluşturan bir hastalık olarak gündemdeki yerini Covid'e rağmen devam ettiriyor kanaatindeyim. En son sınıflamalardan bir tanesi bu. JNC 8'de biz hem prehipertansiyonu hem de evre 1-2 şeklindeki değerlendirmeyi görmekteyiz. Bu anlamda bizim çok basit bu tanımlamayı zihnimizde yer tutturarak acil servise başvuran hastanın anemnezini netleştirdikten sonraki süreçte evrelemeyi rahatlıkla yapabileceğimizi düşünüyorum. Burada dikkat edilmesi gereken diastolik kan basıncı ve sistolik kan basıncı arasındaki regülatif değişikliklere bizim değer vermemiz gerekiyor. Hasta geldi. Tabii ki biz bu hastanın hipertansiyon kliniğiyle ilgili değerlendirmeyi yaparken alt gruplar oluşturmamız gerekiyor ki bizim tanı ve tedavi anlamında daha spesifik nokta atışları yapabilelim. Bu anlamda bizim kalp hızı ve ritminden, EKG değerlendirmelerinden önceki aşamada jugüler venöz dolgunluktan hem dinleme hem palpasyondaki pozitif verileri netleştirmemiz gerekiyor. Bunun dışında bize katkı sağlayacak en önemli unsurlardan bir tanesi de laboratuvar parametrelerinin sonuçları, hem kan testleri hem idrar testleri hem de bir acilcinin kendi kimlik kartındaki bilgiler gibi EKG'nin tüm değişikliklerini bilmesi sonrasında yorum yapabilmesini gerektiren örnekleri bizim çekmemiz gerekiyor. Benim şahsi kanaatim bir acil tıpçı, bir kardiyolog direkt bağlantılı bir durum arz edeceğinden dolayı bunu netleştirmesi gerekiyor. Kalp, böbrek, beyin, buna gözü de ekleyebilirsiniz veya nörolojik açıdan başka sıkıntıların olup olmadığını da ekleyebilirsiniz. Yine periferik sıkıntılar da bu grupta değerlendirilebilir ama 3 ana organ bu anlamda hasar oluşturma açısından araştırılmayı gerektiriyor. Hipertansif aciller eğer son organ, hedef son organ hasarı ile birlikte kan basıncının yüksek olduğu bir durum söz konusu ise işte biz bu durumu hipertansif acil olarak tanımlıyoruz. Daha önceden normotansif olunabilen hipertansiyonu olan hastalarda da gelişebiliyor. Burada şunu vurgulamak istiyorum. Eğer bir kişide hipertansiyon varsa bu hipertansiyonun sayısal, rakamsal yüksekliğiyle end organ hasarı arasında da doğru bir orantı yok. Yani yükseklikle hasar arasında doğru bir orantı olmadığını da özellikle vurgulamak istiyorum. Tansiyonun az bir miktar rakamsal yüksekliği kesinlikle bir acil tıp doktorunda rehavete sebebiyet vermemeli. Sıklıkla hastaların kan basıncı sistolik 180 mm civa veya diastolik 120 mm civa üzerinde bulunsa da tanı için az önce söylediğim sebepten dolayı reel bir tanımlama yapmak çok da doğru değil kanaatindeyim. Evet, neticede diastolik kan basıncının 120 mm civanın üzerine çıkması da hipertansif kriz için belirteç arkadaşlar. Amaç az önce de söylediğim gibi son organda hasarı önlemek, yani bu hipertansif krizlerde acil tıpçının amacı son organlarda hasarı önlemek veya önleyebilecek bir süreç içerisinde hasta karşısına çıkmamışsa oluşabilecek olan hasarı sınırlayabilmek aklımıza getirmiyoruz. Ya birçok problem, end organ hasarı organlarını söylemiştik. Birçok problem oluşturuyor hipertansif durumlarda. O anlamda belki de biz spesifik bazı vakaları da vereceğim. Zamana karşı yarışıyoruz. Oldukça geniş spektrum var arkadaşlar. Beyne, kalbe ve böbreklere kan akışını düşürmeden sistemik vasküler direnci azaltmalı, kardiyovasküler kontrol mekanizmalarının korunabilmesi için barorefleks mekanizmalarını etkilememeli. Düşük yan etki profiline sahip olmalı, inme ve koroner rahatsızlıklar gibi kardiyovasküler hastalıklar riskini azaltarak hem morbidite hem de mortaliteyi azaltmalı ve refleks taşikardi yapmamalı. Biz hekimler genelde bir ilaç vermeden önce olası yan etkilerinin ilk planda akla getirilmesiyle bir şekilde kullanacağımız ilaçta zihinsel kendi background'umuza karşı bir sınırlama yapıyoruz. Bence bu sunumdaki ideal antihipertansif özelliklerini bilmemiz başka yaklaşımların da önüne geçerek daha rahat karar verebilme açısından bizlere fayda sağlayacaktır diye düşünüyorum. Yaşam tarzı önerileriyle birlikte ki bunun içerisinde beslenme alışkanlıklarının değiştirilmesi, sağlıklı beslenme, sigaranın bırakılması, düzenli fiziksel aktivite ve kilo verme ve bu Covid döneminde maalesef tabii ki bunlardan kaçını rahatlıkla yapabiliyoruz? Soru işareti. Ve bu riskli durumlarda kardiyovasküler hastalık, kronik böbrek yetmezliği söyleyebiliyoruz. Katekolaminlerin vazokonstrüktör etkilerini azaltıp direkt kendisi dilatasyon yaparak kalbin kontraktil fonksiyonlarına çok fazla müdahale, çok değil, tamamen yakın, genel anlamda bir müdahale olmadan ciddi anlamda bir katkı sağlıyor. Alfa blokaj etkisi bu. Buna ek olarak ikili etkinin ikinci ayağında ise sempatik sinir sistemi tonusundaki refleks artışı önlüyor, azaltıyor ve dolayısıyla da refleks taşikardi yapmıyor. Bu anlamda aslında hem Dünya Hipertansiyon Derneği'nin hem de diğer sağlık kuruluşlarının önerdiği hem algoritmalara hem de tablolara kendini yerleştirmiş olan bir ajan bu anlamda urapidil. Ve bu ilacın hem hipertansif krizlerin hem de perioperatif hipertansiyon, yani cerrahi branşlarda da biliyorsunuz ki arkadaşlar, hipertansif hem öncesinde hem de sonrasında ameliyatın ciddi bir sıkıntı oluşturuyor. Bu anlamda bu kesitsel dönemde de yine bu ilacın etkinliği ile ilgili önemli verilere sahibiz. Bir diğeri ise preeklamsinin tedavisinde etkinliği olduğu. Akut inmenin yönetiminde de potansiyel bir rol olduğunu yine biz bilimsel veriler ışığında söyleyebiliriz. Özellikle hemorajik enfarkta biz bu konunun daha etkin bir şekilde gündeme getirildiğine sahibiz bilgi anlamında. Evet, az önce söylediğim tablolardan bir tanesi. Avrupa Kardiyoloji Derneği'nin 2018 kılavuzu. Burada hem böbrek yetmezliğinde hem akut hemorajik stroke'da hem de akut kardiyojenik pulmoner ödemde alternatif olarak aslında birinci sıradaki çizgideki tedavi ajanlarının bir kısmının Türkiye'de olmadığını da biliyoruz. Bu anlamda ikinci sıradan birinci sıraya geçiş durumundan da söz edebiliriz. Nazmine Hanım, Fransa'yı sormayacağım. Yine labetalol'un intravenöz formu var mı diye. Var mı sizde? Labetalol etken maddesinin ticari intravenöz formu var mı sizde? Aklınızda değil, evet. Ülkemizde bu ajanların bir kısmı var, bir kısmı ise Sağlık Bakanlığı tarafından isim vermek istemiyorum ama kısa zaman önce toplatıldı. O anlamda urapidilin burada alternatif olarak sunulması sanki birinci hattaki tedavi ajanına geçişine de bu yaşanan olaylar katkı sağlayacak gibi görünüyor. Bu da arkadaşlar Uluslararası Kardiyoloji Derneği'nin 2020 kılavuzu. Burada da yine aynı çizgili değerlendirme yapılmış. Böbrek malin hipertansiyonda yine kanamalı serebrovasküler olaylarda ve akut koroner olgularda bu ajanın alternatif şekilde hekimler tarafından kullanılması tavsiyesinden bahsedilmekte. Ve bunların ışığında tabii ki Türkiye Cumhuriyeti Sağlık Bakanlığımızın da hazırlamış olduğu, kardiyolog ekipleri tarafından hazırlamış olduğu kılavuzda da bu ajan yine yerini almış. Aynı hem hipertansiyon derneklerinin tabloları hem de kardiyoloji derneklerinin önerileri doğrultusunda benzer çizgide endikasyonlar ifade edilmiş durumda. Tabii ki bunu tekrar edecek olur isek akut kardiyojenik pulmoner ödemde, koroner olaylarda ve böbrek yetmezliği olsun veya olmasın, birlikteliğinde veya birlikte olmaması durumunda yaşanacak malin hipertansiyon olgularında alternatif tedavide bu ajan önerilmekte. Bununla ilgili birçok çalışma var arkadaşlar. Ben bunların detaylarına girmeyeceğim ama netice itibariyle bu çalışmalarda etkinliği ile ilgili verilere sahibiz. Sunum zaten daha sonra derneğimizin veri havuzunda sizlerin değerlendirmesi ve incelemesine sunulacak. Oradan daha detaylı değerlendirebilirsiniz. İnteraktif konuşma adına ben hızlandırıyorum. Bu ajan arkadaşlar intravenöz anlamında başkanımızın da ilk başta ifade ettiği gibi Türkiye'de en azından şu saate kadar benim bildiğim anlamda tek ajan olduğunu söyleyebiliriz. Bu ajanın hem bolus hem de infeksiyon nereden çıktı? İnfüzyon şeklinde, içimiz dışımız Covid olduğu için neticede öyle bir dil sürçmesi oldu ama sürekli infüzyon şeklinde de bu ilacın kullanıldığını söyleyebiliriz. Pozolojisinde arkadaşlar dediğimiz gibi iki farklı uygulama durumu söz konusu. Birincisi bolus, ikincisi ise arkadaşlar bir perfüzör veya perfüzör olmadan drip infüzyon ile iki farklı uygulama şeklinde biz bu ilacı kullanabiliyoruz. Burada vurgulamak istediğim aslında en önemli cümle şu: siz ilacı uyguladıktan sonra hangisinde olursa olsun fark etmez ama çok kısa zaman aralığında bir tansiyon değişikliğini gözlemliyorsunuz ölçümlerle. İşte bu zaman aralığını ben kendi gözlemlerimde 5 dakikadan daha az da gördüm ama genel olarak enjeksiyondan sonraki 5 dakika içerisinde kan basıncında azalma olması bekleniyor diyor. Gerçekten realite anlamında da biz bu rakamsal değişiklikleri görüyoruz. Tabii ki tedaviye verdiği yanıtın regülasyonlu kontrolü ile gerektiğinde siz bu ajanı tekrarlayabiliyorsunuz. Eğer siz etkin doz aralığına yakın bir sürece eğer sahipseniz infüzyon tedavisine geçiş anlamında da süreci devam ettirebiliyorsunuz. Tabii ki bunların rakamsal karşılıklarını detaylı bir şekilde prospektüsten görebiliyoruz. Bu ajanın iki farklı formu var arkadaşlar. 10 mililitrede 50 miligram veya 5 mililitrede 25 miligramlık infüzyon ve bolus formları var. Ve doz planı. Siz intravenöz bir enjeksiyon yani çok kısa bir zaman aralığında damar içerisine direkt ilacın uygulanmasını yapabiliyorsunuz. Ve bu yapıldıktan sonra ajanın uygulanmasından sonra 2 dakika sonra arkadaşlar bir kontrol yaptığınız zaman eğer kan basıncında istediğiniz düzeyde bir düşüklüğü size ilaç sağlamışsa infüzyon tedavisine geçebiliyorsunuz. Ama regülasyonda biraz daha devam edilmesi gerektiği kanaati sizin zihninizde hasıl olmuşsa ikinci bir veya üçüncü bir uygulama tekrarlarını yapabiliyorsunuz. Ama sonraki infüzyon sürecini de yine ihmal etmemek gerekiyor. Burada bir örnek var arkadaşlar. Ben olgularda da yine bu tablo eşliğinde sunumlar yapacağım. Gördüğünüz üzere tabloda eğer siz uyguladıktan sonra, bolus uyguladıktan sonra 2-3 dakika sonra eğer istediğiniz düzeyi sağlayamamışsanız tekrarlayabiliyorsunuz. Evet, ben istediğim aralığa hastanın tansiyonu ulaştı diyorsanız gönül rahatlığıyla infüzyon sürecine geçebiliyorsunuz. İnfüzyon hızında arkadaşlar maksimum, ideal ve minimum değerleri burada görmektesiniz. Ama İdame dozunun da ortalama 9 miligram saat dozunda ki bu kabaca arkadaşlar 250 miligram rapadil ilave edilmiş 500 mililitre infüzyon. Bunu sabit olarak aslında ben klinikte düşündüm. Bunu total olarak kullandığınız zaman 550 oluyor. Hem ajanı hem de SF'i kullandığınız zaman SF şartı yok, onu başta da söyleyeyim. Glukozun düşük oranda olduğu o sıvı ajanları da bu şekilde siz bu ajanla birlikte kullanabiliyorsunuz. Ve dolayısıyla saatte minimum 9 miligram, maksimum ise 120 miligram olacak şekilde bir dizayn ile etkin değerlere ulaşmanız sağlanabiliyor. Neticede bu ajanın arkadaşlar %81 ile %100 arasında değişken bir pozitif etki sağladığını söyleyebiliriz. Koroner sinüs kan akımına, miyokardiyal oksijen tüketimine ve miyokardiyal laktat salınımına etkisi yoktur ve kafa içi basıncını da artırmıyor. Yan etki oranı oldukça düşük arkadaşlar ama kesin olan şu ki şu ana kadarki araştırmalarda çok ciddi sıkıntı oluşturabilecek yan etkiden bahsedilmiyor. Hipotansiyon, baş ağrısı ve baş dönmesi de akla getirilmesi gereken oranı çok düşük ve agresif olmayan yan etkiler olarak sıralanabiliyor. Bu ajanla ilgili birçok ülkede çalışmalar yapılmış. Avrupa'da işte zaten pratiğini de Nazmine Hocam'da az önce gördüğümüz üzere Fransa'da kılavuzlara dahi girmiş. Avustralya'da yine bu ilacın önerilmesiyle ilgili kardiyoloji dernekleri tarafından öneriler algoritminde etkili olan anne veya fetüs üzerinde çok az ikincil etkisi olan bir antihipertansif ajan gibi görünmektedir diye sonuç bağlamış bu 2012 yılındaki yayın. Ama yani çok az etki dediğimiz ciddi bir kalıcı hasarın olmadığı basit yan etkiler şeklinde düşünülebilir. Bir diğeri perioperatif hipertansiyondu. Bu anlamda cerrahi operasyonların özellikle de koroner arter cerrahisi ve abdominal aort cerrahisindeki hususlar var. Emzirme döneminde kullanılmaması gerekiyor. Yaşlı hastalarda kullanılmaz değil ama önlemlerin alınmasının ilk planda akla getirilmesi gerekiyor. Simetidin kullanılan hastalar, karaciğer yetmezliği hastalar, çocuklarla ilgili henüz yeterli bilimsel datalara sahip değiliz. Bu anlamda bu konularda dikkat etmek gerekiyor. Aort veya mitral kapak stenozu gibi mekanik bir fonksiyon bozukluğundan, pulmoner emboliden veya perikardiyal bir hastalık nedeniyle kalbin işlevinin bozulmasından kaynaklanan bir kalp yetmezliği konusunda da yine uyarılar yapılmakta. Şimdi bazı olgular var. Bu olgularda tabii ki ürapedil tercih edildiği zaman başarılı olduğumuz vakalar var. Bunların birkaçını ben örneklendirme yaparak sizlere sunmak istiyorum. Erkek hasta 48 yaşında nefes darlığı ve progresif bir nefes darlığı şikayetiyle başvuruyor ve bu arada da tam yokmuş ve kan basıncı yine yüksek. EKG'de sağ dal bloğu izleniyor ve bu anlamda bu ilacı tercih ettiğimiz zaman arkadaşlar 152'ye 88, 25 miligramlık 5 mililitrelik bolus dozundan bahsetmiştik arkadaşlar. Bu uygulandığı zaman 60 dakikada, ki bunun zaten az önce sizlere maksimum, ideal ve minimum dozlarından bahsetmiştik. İdeal doz aralığına göre hesaplandığı zaman hedeflenen seviyeye kadar infüzyona devam ettiğimiz zaman arkadaşlar bu hastada da biz 146'ya 82 milimetre civarlık değerleri gördük bu olguda. Önemli endike olduğu durumlardan bir tanesinin de intrakraniyal hemorajiden söz etmiştik başlangıçta. Bu vakada o regüle edip daha sonraki aşamaya teslim etmiş olduk. Farklı bir hasta daha, aslında çok geniş spektrumları olan hastalar var ama bu kısa zaman aralığında bu sunumu hazırladım. O anlamda eksiklikler için tekrar özür diliyorum ama bu hastanın da yine endorgan hasarı açısından değerlendirilmesi yapılmıştı. Biyokimyasında da çok böyle ciddi anlamda bir sıkıntı olmadığını hatırlıyorum. Risk faktörü sigara, zaten kullandığı ilaçları olan ve uzun süreli yıllardır tansiyon olan bu hastada muhtemelen yine düzensiz kullanmaydı. Yüksek bir tansiyon arteriyel ölçüm, manometrik ölçümle ideal şartlar sağlandıktan sonra yüksek olduğu saptanınca bu hastada hem bolus hem de infüzyon anlamındaki süreç kurallara riayet edilerek sağlandı. Altta zaten yine o kullanım aralığı ile ilgili algoritmik verileri görüyor, tablo yapılarak rapidilin kardiyak yükünün daha iyi azaltabiliyorcu ve EF artışını teşvik edebildiğini ve sonuç itibariyle konjestif kalp yetmezliği semptomlarını hızla giderdiğini ifade etmişlerdir bu çalışmada. Akut sol kalp yetmezliği olan yaşlı hastalar için de güvenli ve etkili bir vazodilatör olarak sonuç bölümünde açıklama yapıyorlar. Böbrek problemi olan, ki gerçekten o yaş grupları böbrek açısından da sıkıntı oluşturuyor ve metabolik problemler olan bu kişilerde ek fayda da sağlayabilir. Demek gerekiyor ise kalp atım hızını değiştirmiyor. Çünkü kalbin fonksiyonları üzerine çok etkin bir sıkıntı oluşturmuyor. Refleks taşikardiyi özellikle birkaç slaytta vurguladım. Tolerans gelişmiyor. Hem 5-hidroksitriptamin 1 hem de direkt postsinaptik alfa 1 blokajı ile ilgili etkinliğinden bahsetmiştim. Kılavuzlara girdiğinden bahsettim. Türkiye Cumhuriyeti Sağlık Bakanlığımızın da bu anlamda tablolarında yer almış bir postsinaptik alfa bloker. Sodyum içermiyor ki bu sodyum probleminin zaten hipertansif hastalarda düzensiz bir beslenme alışkanlığının da ciddi bir sıkıntı oluşturduğunu ifade etmiştik. Sodyum diyetine uygun, heparinin etkilerini değiştirmiyor. Az önce de söyledim, ikili etki mekanizması iki farklı şekilde sağlanıyor. Birincisi bolus intravenöz, diğeri ise driplioya perfüzatör ile infüzyon şeklindeki bir uygulama avantajından bahsetmiştim. Fiyat anlamında da gerçekten bir farklılık oluşturuyor diye bilgiye sahibim. Yani hipertansiyonun o geniş spektrumlu ajanlarının fiyat değişkenliklerinin de aynı spektrum şeklinde yorumladığı bir ligde fiyatının da avantaj sağladığı bir reel durum. Sunumumu biraz uzattım, affınıza sığınıyorum ve bu anlamda sözü tekrar size veriyorum Sayın Başkanım.
Çok teşekkürler. Öncelikle. Şimdi arkadaşlar, konu biraz bizim açımızdan önemli yani. Hipertansif acillerin çok önemli bir bölümünü teşkil ediyor ve çok dramatik hasta grubu da bazen de dediğim gibi çaresiz kaldığımız hasta grubu oluyor. Ben şöyle bir hastamdan bahsedeyim. Bu hasta grubu çok önemli. Özellikle orta yaş, yani orta yaş diyeceğimiz 40-50 diyelim. Ona orta demiyorlar. Şimdi genç diye söylüyoruz ama o gruplarda baş ağrısı çok ciddi bir patolojidir. Hep söylerim, o yaşlarda baş ağrısından çok çekinin. Çünkü bu sakın habercisi olabilir. Özellikle 47 yaşlarında pik yaptığını biliyoruz. Şimdi bu hastalarda sak ilk kanamada kendini toparlayabilir. Nitekim böyle bir hastam olmuştu. Artık geri dönüş bekliyorduk. Ekstübe edecektik. Ama bunların 24 saat içinde ikinci hipertansif kanama durumu var. O hastada tansiyonu kontrol etmek hayati bir önem arz ediyor. Onun için özellikle bir grup hastamızda bize çok önemli bir alternatif getirdiğini görüyorum alfa blokerleri. O da iskemik değil de hemorajik stroke'ta zaten elimizde en güçlü şeylerden biri Hakan Hocam, öyle görünüyor. Bizim arkadaşlarla bir deneyimimiz arttı. Biraz kendi hastanemizde de ama bir de iskemik stroke yapmış olduk. Değil mi arkadaşlar? Onda da iyi sonuçlar elde ettik ama Hakan Hoca'nın bahsettiği şey var. Çok çabuk düşürüyor değil mi Hakan Hocam ya? Evet. Biraz böyle alfa blokerlerden de bunu bekliyoruz herhalde. IV intravenöz veriyorsun, bolus veriyorsun. Birdenbire şok bir tansiyon düşüşü görüyoruz. Bu da siz gözlemlendiniz mi bunu?
Ben özellikle bazı acil tıp meslektaşlarımızın yan etkiler konusunda tedirgin olduğunu bu süreçte sorguladım. Yani ne düşünüyorsunuz falan diye. İşte ilk doz senkopu, refleks taşikardi. Benim yani burada dediğim vaka sayıları çok yüksek değil. Hani klasik derler ya, daha fazla bu konuda pratik değerlendirmeler gerekiyor ama benim kendi uyguladığım o ikili rakamlardaki hastalarda bu sıkıntıları görmedim. İnanın ki bir acil tıp kliniğinde siz bir ilacı uyguladığınız zaman ya bunun yan etkisinde şu sıkıntı olabilir diyerekten bir tereddüt içerisine girmeyin. hepsinin telafisinin olacak konfora sahip bir klinikte çalışıyorsunuz. Yani bu hasta arrest olursa ne olur? Genel anlamda söylemek istiyorum. Bu olay.
Evet. Açıkçası o zaman gençken profesörlerimiz bize dedi en az yan etkisi olan ve en az kontrandikasyonu olan ilaçtı ve ben gerçekten yani ilk etapta her zaman A planım ürapidil oluyor. Yani hamile kadınlarda bile. Ve şu ana kadar gerçekten hiç problem görmedim ve Hakan hocamızın dediği gibi ilk doz 25 miligram yetmedi, ikinci doz 25 miligram yetmedi, enfüzyon olarak veriyorum. Genelde 10 miligram başlıyorum, 25'e kadar çıktığım oluyor ama genelde o kadar 120'ye kadar hiç çıkmadım. Çok memnunum açıkçası. Laboratuvarda da herhangi bir şeylerim yok. Yani bunu gerçekten hani bir acil tıp uzmanı olarak paylaşmak istedim.
Ya bu harika bir şey çünkü inanılmaz bir katkı oldu, katılım oldu. Çünkü burada biz ilk ilaç kullanımı alfa bloker infüzyon yapacaksınız ya, her asistan, her genç doktorumuz, hatta hocalarımız ilk başta ben bile ya bir yapın bakalım başında bir duralım ne olacak fikrinde bir yaklaşımımız oluyor yani şimdi. Tabii burada Nazmiye 15 yıllık bir hikaye bilmiyorum. Firma yetkilileri bu konuda ne der? Böyle bir tecrübe hiç görmemişlerdir herhalde. Muhteşem oldu. Yani şimdi bizim tereddütlerimizi giderdin Nazmiye. Bizim tereddütlerimiz gitmiş oldu. Asistanlarımız da dikkat etsin buna. Bakın 15 yıldır kullanan Fransa'da acil uzmanı. Tabii Türkiye'de biz 15 yıldır temin edemiyoruz. Bize yeni geldi ve bu çok aydınlatıcı oldu. Çok teşekkür ederim. Artışlar veya akut MI'da artışlar gibi konular hep gündemimize geldi. Özellikle COVID'in böyle pıhtılaşma mekanizmaları üzerine de etkisi bunu biraz daha farklı bir boyuta taşıdı. Ama akut koroner sendromlar herhalde acil eğitiminde bizim ilk sıraya koyduğumuz, resüsitasyondan sonra ilk sıraya koyduğumuz akut koroner sendromlar oluyor. Akut koroner sendrom tedavisinde yıllar içinde oldukça iyi gelişmeler yaşandı. Özellikle invazif girişimler bu konuda bir çığır açtı. Akut EMA'yla kaybettiğimiz, akut koroner sendromla kaybettiğimiz hasta sayısı hep asetil salisilik asit üzerine çalışırdık. Ama süreç şunu gösterdi ki bir de P2Y12 inhibitörlerinin özellikle bu konuda çok ciddi bir gereksinimi var. Ve bunların erken verilmesinin, zamanında verilmesinde çok büyük önemi var. Yaklaşık 4-5 yıldır biz bu konuda özellikle eğitimlerimize devam ediyoruz. Kılavuzları takip ediyoruz, çalışmaları takip ediyoruz. Son 1-2 yıl içinde de yine yüz yüze yaptığımız kongrelerden sonraki süreçte kılavuzda çok önemli değişiklikler oldu. Bizi çok ilgilendiren değişiklikler ama bu derste özellikle bir herhalde sunmamız gerekecek. Burada çok değerli yabancı konuklarımız var. Onlar da muhtemelen dinliyorlar kulaklıkla. Hindistan'dan, Özbekistan'dan, dünyanın çeşitli ülkelerinden onlar da takip ediyorlar. Onların da katkıları bizim için değerli olacaktır. Bu konuda çok değerli bir hocamızı ben davet edeceğim. Profesör Doktor Adnan Abacı, Gazi Üniversitesi Tıp Fakültesi Kardiyoloji Anabilim Dalı'ndan değerli hocamız bizi bu konuda aydınlatacak. Hocam buyurun.
değerli başkan, değerli meslektaşlarım. Bu oturumda ben size ST yükselmesiz miyokard akut koroner sendrom kılavuzundaki hem değişikliklerden hem de bu değişikliklere neden olan çalışmalardan kısaca bahsedeceğim. 2020 ESC, Avrupa Kardiyoloji Derneği, ESC diye kısaca söyleyeceğim bundan sonra. Kılavuzu biliyorsunuz 220'de yenilendi, 2020'de yenilendi. Daha önce 2015'te bir önceki versiyonu çıkmıştı. Arada bir güncelleme yapılmıştı. Şimdi buradaki esas konumuz ön yükleme meselesi. Bu kardiyologlardan daha çok sizi, yani acil hekimi meslektaşlarımızı ilgilendiren bir konu. Ön yükleme diye Türkçe'ye çevirdim. Ön tedavi denebilir, pre-treatment. Öncelikle ön yükleme dediğimiz zaman ne anlıyoruz, ne anlamalıyız? Ön yükleme, ST yükselmesiz akut koroner sendromda. Burada ST yükselmesiz akut koroner sendrom ifadesini özellikle kullanıyorum. ST yükselmesiz MI ve kararsız anjinayı kapsayan bir terim bu, biliyorsunuz. Ön yükleme, ST yükselmesiz akut koroner sendromda koroner anjiyografi yapılmadan önce P2Y12'nin başlanmasıdır. Bu bazen ambulansta ama hemen daima acil serviste yapılan bir uygulamadır. Bazen de kateter laboratuvarı olmayan bir hastanede de başlanabilir. Ama esas itibariyle ön yükleme acil servislerde yapılan, ülkemiz şartlarında acil servislerde yapılan bir tedavi şeklidir, bir uygulamadır. Konumuz, bugünkü tartışacağımız nokta ST yükselmesiz akut koroner sendromlar. ST yükselmeli miyokard enfarktüsünde ön yükleme diye bir tartışma yoktur. Çünkü bu hastalara tanı konar konmaz P2Y12 yüklemesi yapılmalıdır. O nedenle burada ön yükleme tabirini kullanmıyoruz. Hemen başlanır ve yüklenerek başlanır. Ön yükleme tartışması veya ifadesi ST yükselmesiz akut koroner sendromlar için geçerlidir. Öncelikle bunu vurgulayayım. 2015 kılavuzunu hatırlatacağım. ESC'nin klopidogrel verildi. O nedenle ön yüklemenin ve görüldü ki beklentilerin aksine, aslında beklentiler şöyleydi, ön yüklemenin iyi çıkabileceği yönündeydi. Fakat görüldü ki iskemik olaylardan kastettiğimiz kardiyovasküler ölüm, tekrar enfarktüs, inme, acil revaskülarizasyon ve glikoprotein 2B3A inhibitörü kullanımı. Yani iskemik olaylar, iskemiyle seyreden olaylar. Bunlar arasında bir fark olmadığı görüldü. Yani beklentimizin aksine ön yükleme yaptığımızda bu klinik olaylar, bu iskemik olaylarda bir azalma görülmüyor. Buna karşın kanama, tabii ki antitrombosit veya antikoagülan tedavinin kötü bir tarafı kanama, biliyorsunuz, her zaman için önem verdiğimiz bir nokta. Kanamalarda artış olduğu görüldü, majör kanama. Arkadaşlar, biz kardiyoloji olarak kanamalara uzun yıllar gereken değeri vermedik. Ama son yıllarda, son 5-10 yılda şunu fark ettik ki kanamaya bağlı ölümler, enfarktüse bağlı ölümler kadar önemli. Bu nedenle artık dikkat ederseniz büyük çalışmalarda majör kanama bir enfarktüs kadar önemli kabul ediliyor. Ve kanamada artışa yol açıyorsanız eğer yaptığınız tedavi yüzünden, o zaman mortalite faydası sağlayamayabiliyorsunuz. Hatta tersi bile oluyor. O nedenle kanama çok önemli. Bunlar majör kanamalar. Yani hayatı tehdit eden kanamalar. Ölümle sonuçlanabilen kanamalar. Dolayısıyla ön yükleme yapılan grupta majör kanamanın daha fazla olduğu görüldü. Yaklaşık bakınız 2 kattan fazla bir artış var. Bu şeyi çalıştırabilirsem. %1.7'ye karşı 0.7. Mutlak rakam olarak da %1'lik bir kanama artışı var. Dolayısıyla AKOS çalışması bize ön yüklemenin faydalı olmadığını gösterdi. Peki bu acaba ön yükleme ile anjiyografi arasında geçen süreyle alakalı olabilir mi? Yani süre uzadıkça, anjiyo geciktikçe faydalı olabilir mi ön yükleme? Bu da analiz edildi. Görüldüğü üzere erken yüklenenler, daha doğrusu yüklemeden, pardon, şunu çalışmıyor mu? O yüzden mouse kullanacağız. Tamam. Bu sefer de şey oluyor. Tamam. Ekranı göstermiyormuş dijital ekran olduğu için. Gördüğünüz gibi anjiyografi, yükleme ile anjiyografi arasındaki süre uzadıkça bir fark yok. Yani o düşüncemiz süre uzadıkça ön yükleme işe yarar düşüncemizi de desteklemiyor bu çalışma. İster ön yüklemeyi yaptıktan kısa süre sonra, ister 24 saate varan sürelerde ön yükleme yapmış olun, bir fark olmuyor. Yani ön yükleme faydalı değil. İşte bu çalışma biraz önce 2015 kılavuzunda prasugrelle ön yükleme yapmayın önerisinin nedeniydi. Peki 2015 kılavuzu bize ön yükleme hakkında clopidogrel ve ticagrelor ile ilgili size bir şey söyleyemem demesine rağmen hepimiz hem siz hem biz kardiyologlar olarak bu hastalara ön yükleme yapıyorduk. Neden? Elimizde bilimsel bir veri yok. Kılavuz da o zamanki kılavuz ön yükleme hakkında bir şey diyemem ama prasugreli yüklemeyin. Rağmen ön yüklemeyi rutin kullanıyorduk. Hatta ilginç bir şey oldu. Bakın 2015 kılavuzu ne diyordu bize? Ön yükleme hakkında bir şey diyemiyorum prasugrel dışında. Prasugreli yüklemeyin ama clopidogrel ve ticagrelorla ilgili de